invite our esteemed chairperson, Dr. Hetal Patolia, and Dr. Snehal sir. Thank you. Hetal Patolia and Snehal sir no મને CV આપો. Chairperson છે. જો Hetal, એ તારો CV પ્રોજેક્ટ કર. તારો આપેલો છે. One minute. Each and every, those who are present in audience knows Dr. Hetal Patolia very well. She's a famous gynecologist from Rajkot, shifted to Ahmedabad, and she doesn't need any introduction. Dr. Snehal sir, I'm very sorry, tamaru mara hathma nathi. So, Snehal sir, so I request, okay. So according to Munjal, we would like to hear you after this to talk. I guess we get the time. Thank you very much.
Thank you so much, Dr. Manisha, for the kind introduction. So we begin our first session today. Our first speaker today is Dr. Akshay Shah. We are going to hear on manual removal of placenta, tips and tricks from sir. He is, of course, our very beloved associate professor from NHL Medical College, the most sincere, academic, and the most loved person in our AOGS. Welcome, sir.
Thank you so much, madam. Thanks for your kind words. I welcome you all on this our own international conference on critical care. So I thank the Gynec Society for giving me opportunity to share the stage. So I will be talking on manual removal of placenta. So if we go into the basic science, what causes placental separation? We all know that since our undergraduate days, that after delivery of the fetus, there is a retraction, that is a permanent shortening of the uterus. So placental bed diminishes in size, and we know that placenta being inelastic does not diminish in size and separates. If we divide this separation of placenta into stages, we have a latent stage, that is thickening of the placental free wall, then contraction, that is thickening of placental side wall, and then detachment, which causes complete separation and detachment of the placenta, and there is expulsion. Retroplacental hematoma is formed, which pushes the placenta into lower uterine segment. Uterotonics enhances the placental separation, and encounter tachylysis, inhalation anesthetic agent, or nitroglycerin causes uterine relaxation and causes delay in placental separation. We know that WHO has guided us a strong recommendation for active management of third stage of labor, that is use of oxytocin, that is 10 unit of oxytocin, either intramuscular or IV. That is one. Second is controlled contraction. is recommended even in during cesarean setting. We are advised to perform controlled contraction, and sustained uterine massage is not recommended as an intervention to prevent postpartum hemorrhage who has received prophylactic oxytocin. We know that there are definite confirmed signs of spontaneous separation of placenta, that is sudden gush of blood from vagina, apparent lengthening of the cord, rising in the uterine fundus, and uterus becomes firm and globular. When these signs have appeared, placenta is ready for expression, what we know it as Brand-Andrew maneuver. How to suspect and how to proceed? There are different guidelines. As per the NICE guideline, we can wait for up to 30 minutes. And if there are no danger signs, we can wait for 60 minutes as per the WHO guideline. Retention of placenta may be, there are different types: separated but retained. Second is separated but incarcerated, what is known as hourglass constriction. Third is adherent but separable. And fourth is adherent and inseparable. Time factor, sorry for small fonts. Time factor plays an important role. The clock shows that patient has delivered at 12 o'clock, but there is no separation of placenta till 12:20. So obstetrician's active role comes into the play. And by 30 minutes, that is 12:30, anesthetist is informed. After giving a proper anesthesia, placenta is delivered by 1 o'clock. So that is a maximum limit of 1 hour, that is 60 minutes. Which are the high-risk patients who can have this retained placenta? One, previous history of retained placenta, previous cesarean section, maternal age more than 35 years, preterm labor, induced labor, multiparity, previous uterine injury or surgery, and uterine malformation or uterine infection. These are the high-risk patients who can have retained placenta. What is the role of ultrasound in adherent placenta? There are two phases: antenatal period and at the time of third stage of labor. The literature says that meta-analysis has confirmed that ultrasound carries a 90.72% sensitivity and 96% specificity for antenatal detection of invasive placenta. As far as the role of MRI is concerned, sensitivity and specificity of ultrasound are superior than those of MRI. But of course, we can take help of both in high-risk patient, especially when placenta is posterior and in obese woman. Again, ultrasound plays an important role for detection of adherent placenta in third stage of labor. Normally, there is cessation of blood flow between placenta and myometrium immediately after birth. Persistent blood flow from myometrium deep into the placental tissue, demonstrated by color Doppler, suggests placenta accreta. Again, ultrasonography plays an important role during MRP to avoid incidence of, or to minimize the incidence of inversion of uterus. This has been supported by certain papers that grayscale and color Doppler plays important role in early detection of placental separation. WHO guidelines for retained placenta. As far as the management is concerned, should uterotonics be offered as treatment for retained placenta? If the placenta is not expelled spontaneously, clinician may use 10 units of oxytocin in combination with controlled contraction. Ergometrin is not recommended, and neither the prostaglandin A2. What is about intra-umbilical injection of oxytocin with or without saline? It has been found to be useful in many cases, but statistical difference is not observed, but there is no harm. So we can try intra-umbilical vein injection of oxytocin with or without saline. This has been supported by certain papers. Should antibiotic be offered if we do manual removal? Yes, a single dose of antibiotic, either ampicillin or first generation cephalosporin. Use of sublingual nitroglycerin. Sequential administration of oxytocin and nitroglycerin seems to be an effective and safe procedure in the management of retained placenta. However, larger studies are needed to confirm the same. What are the prerequisites? Bladder should be empty. Strict asepsis has to be followed. Anesthesia and OT setup has to be up to the mark. Obviously, we need to have personal protective equipment. Antibiotic prophylaxis as mentioned, and uterotonic agent immediately after completion of the procedure. When to perform? As it has been already stated, we can wait up to 30 or 60 minutes if patient is not having heavy bleeding. hemorrhage prior to spontaneous expulsion of the placenta, do ultrasonography for morbidly adherent suspected placenta. Which anesthesia? We all know that depth of anesthesia is of utmost important whenever we are doing MRP, since we are doing it since years together. Initially, halothane was used, and nowadays sevoflurane. As I have mentioned, glycerin trinitrate can be used up to 200 microgram. Obviously, this anesthetic agent either or glycerin trinitrate, we need to be prepared for uterine atony and PPH management. How shall we proceed for MRP? We all know that. Follow precautions common to all intrauterine procedure and septic precautions. Cup of the fundus with one hand and hold it down. Advance the other hand into the uterus, supinated, direct it towards the fundus and locate the cleavage plane between uterine wall and placenta with the fingertips. This hand is inserted all the way up to the forearm into the genital tract. Once the cleavage plane has been located, use a side-by-side supinated hand like a spoon to detach the placenta and bring it down. That is a slicing movement of the hand. Immediately reinsert the hand to perform uterine exploration, that there is no trauma, no retained tissue, no blood clot, no placenta bead missing out. On very rare occasion, it is impossible to remove the placenta manually because there is no cleavage plane between placenta and uterine wall. In this event, we need to obviously refer to hysterectomy. What are the complications? Hemorrhage, shock, injury to the local parts, infection, inversion of uterus, subinvolution, embolism, and in subsequent pregnancy, there are increased chances of cervical insufficiency, weak cesarean section scar, and increased chances of adherent placenta. This one of the very well-known studies shows that Elter et al. Published a study involving 57 cases with placenta accreta, where all women underwent hysterectomy. In 15 cases, an attempt was made to remove the placenta manually, but this entire woman required immediate hysterectomy for uncontrolled bleeding. The author of this study concluded that a case of suspected placenta accreta scheduled cesarean hysterectomy without attempting placental removal is a carry-home message. In very few instances, we can leave behind the placenta. To be very honest with you, I don't have any personal experience with this, but senior audience raising their hands says that they have experience of leaving the placenta in situ. Obviously, we know that it has an increased risk of sepsis and secondary PPH that can be managed with the help of antibiotic. We may give it low dose for a long time, and for of course that can lead to secondary PPH. And some doctors believe to give methotrexate 1 dose injection when they leave the placenta behind. Thank you so much for a patient hearing. Thank you so much.
Thank you, sir. With the rising CS rate, the placental issues have again re-emerged, and we very commonly see placental issues like adherence and accreta, percreta nowadays. So this was a very concise and complete talk on it. Thank you so much.
Thank you, ma'am. Thank you so much. Thank you so much.
Any difference between normal delivery retain and cesarean retain?
See, again, MRP remains the method the same, right? During cesarean section, we can make out if it is adherent. Well, if it was not diagnosed previously, suppose we are doing an emergency cesarean section, unbooked patient, and antenatally not diagnosed to have placenta accreta or percreta, we can make it out well during cesarean section because everything is our hand compared to normal delivery. But as stated that nowadays we all of us have ultrasonography machine, preferably having an operation theater, we can put a probe on abdomen with sterile precaution during cesarean or in normal delivery, and we can make out that there is a plane of separation between myometrium and placenta.
Thank you. Thank you. Any questions from audience? Thank you, sir.
Thank you.
I invite Dr. Janki Pandya for next talk, teamwork in obstetric crisis and critical care. She is assistant professor in LG Hospital, AMC Medical College. She has done diploma of minimal invasive surgery, and she is our second lady of the AOGS.
Thank you, Snehal sir, for an introduction, and thank you, Hypertensive Patolia ma'am. Hello, good morning, everyone. Myself, Dr. Janki Pandya, working as assistant professor in AMC Medical College, Ahmedabad. Today's my topic is role of teamwork in critical care obstetrics. So this is the perfect example. The ball is in the air and it is being catch. Oh, just catch by another person. So this is perfect example of the team that we know. So together, everyone achieves more is called a team. Basically, team is what? It consists of the individuals who work closely together and are interdependent with each other to achieve a constant, one common goal. Coming to the maternal mortality ratio, as we know, now the maternal mortality ratio has been declined worldwide by 38%. Current rate is 211, that's per 1 lakh live birth. And in India, it has also been declined by 70%. In 2021, the MMR is 98 to 99 per 1 lakh live birth. And the hemorrhage, indirect cause like sepsis, pre-existing medical condition, and preeclampsia are still the leading cause of maternal mortality. So what is obstetric care? It is a team activity, whether we are seeing a patient in clinics, whether we are performing a delivery, or whether we are managing a critically ill patient. Why we need this teamwork? What is the importance? As we all know, the obstetrics is very complex, risky, and uncertain behavior. It's very dynamic. It is now known as a high hazard industries. There are many different in high hazard industries like aviations, like nuclear science, like chemical industries. We have doctors, nurses, all healthcare staffs are all well trained, all competent enough to perform the emergency task as well, but they don't know how to, they are not trained how to work as a part of a team. So the communication failure or the teamwork, these are among the top contributors to the adverse events and different malpractice claims. The different source of errors in teamwork are, they are not identified, the problems are not identified, failure of communication, delayed in reacting to change clinical circumstances, delay or failure to transfer the patient, inappropriate designation to inexperienced assistant, or there is lack of multi-professional team working. So Joint Commission USA, it stated that communication and teamwork issues were most common contributors for the perinatal deaths and injuries and maternal deaths and injuries. So IOM suggested all the healthcare organizations should promote effective team functioning for ensuring safe healthcare. The impact of interprofessional teamwork was researched by SAFE study, that is simulation and fire drill evaluation, to state the ability of labor staff to manage the acute ops emergency. The results were there were clear improvement after skill training. The recommendation were obvious obstetric team rules and multidisciplinary teamwork training. What does a maternal critical care unit consist of? There are teams, objectives, their goals, effective leadership, and efficient communication. So which are the different training methods for teamwork? There's debriefing of staff after real life emergency to learn the lessons for all the staff. Video recorded role play. Role play should be there, which has to be video recorded to stimulate the self-learning and to take feedbacks, whatever, positive or negative, whatever it may be. Case-based learning, that's all what we all know. Didactic team learning, that is the most common method to teach the two-way trainings. And the newer one is simulation or drills, which give us hands-on experience. And now these are also included in undergraduate curriculum also. All the clinical and non-clinical staff should participate in some or all training activities, include senior staff, along with this teamwork. So these are the examples. These are the simulation examples on mannequin for training session of PPH. Second one is showing the uterine massage. Third one is showing didactic lectures. They are showing the flow of PPH management. And the fourth is showing the obstetric emergency drill, which is to be conducted in the real life situation with the resources available like medicines and equipments. So main difference between simulation and drills is that the simulation are done in like fictitious environment and the drill are basically real. Now this is the tiki-taka procedure of football. It is the fastest and quick passing of football. And so we can see the performer achieving the goal. The beauty of this goal system is that they are outnumbered. They are only 3, but still they manage to achieve their goal. Now, what are the teamwork factors? These teamwork factors are defined by these 4 stages: leadership, situation awareness, communication, and shared mental methods. Leadership, well, who should be the leader? Definitely one thing is that which comes in our mind is experience. Definitely experience for what? Experience to handle the emergency situation, experience of different team members, experience that particular team member, what can they do and which role we can assign to them. It is not necessary, it should be always a senior person. And who is the leader? It's a verbal declaration, or someone, if does not declare, allocate the leader. How to lead the team? You should know the team members, their roles, their responsibility, the situation. Like suppose if the woman has been admitted in ICU post cesarean delivery 4 hours back, and she has been done cesarean section for indication of placenta abruption and DIC. The background will be assessed like she has received 2 pints of packed blood, red blood cells, and 4 units of fresh frozen plasma. Then assessment they will be given like that. You have to assess the patient for their vitals, pulse, BP, and tachycardia and saturation, as well as the abdominal distension, because the clinicians are worried about this most. And the recommendations are like, if they found any problem, suppose they found tachycardia or hypotension, they should notify the senior consultant immediately to evaluate the condition. The closed loop communication is also important, and avoid distraction for the leader. That means if the team member is performing well, then don't interrupt in between. Situation awareness, to find out clinical situation, team abilities, and keep aware of patient and her companion for this communication or information. Communication, as I have already stated, is very important. It's closed loop, like it is directed, acknowledged, executed, and confirmed with the help of SBAR, which I have just told. And the failures in orientation or communication may lead to this Bermuda Triangle of healthcare. Shared mental methods, that means you have to declare the diagnosis that this is yes, this is an eclampsia. So it will improve the good team performance and good patient outcome. Coming to the main problems that members of ad hoc team or leader sometimes does not know the name, profession of the team members, seniority, their roles and responsibility, as well as the experience that how can they perform this task because of the staff rotation or turnover. What are the solutions? Regular timings, trainings several times per year, emergency ops drills every 3 months, and introductions of every team member at the start of each shift. That will be helpful. So what are the success of teamwork leads to? Yes, it does definitely lead to good clinical outcome, job satisfaction, and staff retention. The summary is all one and all that train together those who work together to improve our outcome, that is maternal and perinatal outcome. So this is one last video to show.
Get over the line here. Through the field, mid-off is up, cover is up.
And he's taken one glove off. So in case it's a matter of throwing, he's got that.
This is the last ball of the India versus Bangladesh T20 series.
Here we go,
Showing
ball.
just 2 runs unhit from one ball. And this is a perfect and magnificent example of the leadership and the teamwork, that showing in the critical condition how to remain calm and cool and optimize your desired goal. And this is the desired goal. They are waiting for the goal. So this is one of the greatest example that we should learn, this kind of teamwork.
Bear with me, gentlemen.
Before the decision, as we have seen, the Indian skipper has announced that obviously it is the person, the sports person is out.
He's got him. That's it. India win.
for decision.
Get over the line here.
So thank you for this listening of this teamwork. Coming together at last, I would say the coming together is a beginning, keeping together is a progress, and working together is a success. Thank you all.
Thank you, Dr. Janki. That was a very interesting talk with some very interesting videos. So thank you so much. Yes, beforehand, at some places like PHCs and all, we don't have a team. And where we
Yes.
have a team, most of the time it is chaos and not coordination.
Yes, ma'am.
So it has become very, very important to train the
Train the
team.
staff. Yes, ma'am.
The training that we have started with Foxy, Dr. Alpesh Gandhi
Yes,
has
sir.
started of paramedics, has become so important
Mhm.
in recent times. Yesterday, when we had a workshop on PPH
Yes,
and we
ma'am.
trained the nurses in that, they were very enthusiastic to learn, and wherever they have done the training, they have seen significant improvement in
Yes, ma'am.
maternal mortality and all. So yes, training of the team and working together is so important in today's times. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Again, I welcome you all. Good morning on behalf of Ahmedabad Obstetrics and Gynec Society. Thank you, our esteemed chairperson, Dr. Hetal and Dr. Snehal sir. Now, moving onward to our second session, I invite Dr. Mahendra Soni sir and Dr. Jitendra sir to chair the session. Dr. Mahendra Soni sir has passed from BJ Medical College. He is practicing at present in Himmatnagar. He was the founder president. He hosted a SOGOG conference in 1994. He was president of SOGOG in 1995, participated in many national and international conferences. He had a special interest in critical obstetrics and infertility and awarded oration at SOGOG conference Bhuj 2021. Dr. Jitendra Patel. Dr. Jitendra Patel is not there, I suppose. So Dr. Mahendra sir, you have to carry on for the session. Good morning, sir.
Hello. Good morning, friends. At the outset, I am thankful to ICCOB and particular Dr. Alpesh Bhai. Now we'll just start this session. And I invite Dr. Asha Singhani. Is there, Madam Asha? I don't know, sorry. This session is online. Dr. Asha Singhani is from USA. She is a professor maternal fetal medicine in the University of Washington, Seattle, WA. So now let us start.
Doctor,
Yeah. Should I go ahead?
Dr. Asad, please join in.
Thank you. Thank you. I want to thank Dr. Gandhi for inviting us, the SMFM group, to give us to have us participate in this very important meeting. I've participated in this meeting in person previously, and it's an excellent meeting. I also want to thank Dr. Arthur Watt, Dr. Tori Halscott, who are on the East Coast, and it's close to 11 p.m. there, and they have stayed up just to give this talk. They both are at Johns Hopkins. That's where I had my training, and I'm on the West Coast. So for me, it's about 8 o'clock, but for them, it's really late. So I really thank them for staying up. I'm going to go ahead and share my screen and start my talk. It's on maternal mortality worldwide. And how do I do it? Right there. So I'm going to spend the next 20 minutes talking about it very quickly. I'm going to first talk about the ratio, first the definition, and then from there we'll go to the global maternal mortality, India maternal mortality, where we are today compared to 20 years ago, and where we are headed. So there are global numbers, India numbers, and then of course the causes. And then I have these icons here, so it'll make it clear to you what these numbers are and from which country. So if you look at the global numbers, the maternal mortality is decreasing over the last 2 decades. It has decreased significantly. In the year 2000, there were 342 deaths per 100,000 live births in the world. Total of 451 mothers died while giving birth. 17 years later, it dropped down to 211. So that's quite a big drop. And the good news is a lot of this drop was due to the good care people are getting in India and due to the decreased maternal mortality in India. The target, the UN target, is to have global mortality less than 70 deaths per 100,000 live births. And so we really need to reach there, and hopefully we will. So this is just the global mortality. You can see back in 1996, this is from the Melinda and Bill Gates Foundation. Worldwide, it was 250 per 100,000 in 1990, and it dropped down this year. Past year, it was 152. And if you look at it, the Indian amount has really, really gone down. It used to be 400, and now it's down to 130 maternal deaths per 100,000 live births. So this yellow line that you're seeing, 70, that is the goal. And we have to reach that goal in the next 9 years. And so this 130 really needs to come down, but you should really be proud of yourself, because if you look at your neighboring countries here, the Indian number is in red, 130, 189 is Pakistan, and global is 152. So India is relatively doing quite well, and it's going to continue to do well. And hopefully it will reach by 2030. The projection is that it's going to reach maybe 92-ish, but we really want it to go down 92 to 85, but we want it to go down to 70. So you all have to work really hard. So this is India, the trends in India, 398 back in 1997. There are all these different numbers because they're from different studies. So I have pulled numbers from various studies, but this is from about 7 years ago. They looked at these 3 numbers, and then there's a recent paper that's in online, but it's going to be published soon by the British Journal of OBGYN, where they have predicted that last year the death rate was 99 per 100,000 MMR. So it's a 75% drop. And so in order to drop it further, we need to really know the cause of what is causing these moms to die. And once we know it, we can reduce it. There are 3 classifications. In the classification, there are 3 categories. So one is directly related to pregnancy, such as hemorrhage, pulmonary embolism, and a few others that I'll discuss. One is associated, so it's not related to pregnancy. It's just that the woman happened to be there at the earthquake and she happened to be pregnant. She died while she was pregnant. So it's associated, but not related. The other one is undetermined. Maybe it was related, maybe it was not, such as killing herself, committing suicide. It may be because the pregnancy caused depression, but it may not be. So we don't know. That's the 3rd category. So this is the category, the pregnancy related, that we really, really need to put our efforts into. And in the US, 50%, I have numbers even for India, but in the US, 50% of the maternal deaths are due to hemorrhage. Cardiovascular is a big one. We are seeing many, many more women have cardiac diseases, cerebrovascular accidents, infection, preeclampsia, eclampsia, embolus, and more of the same cardiac things. And the factors that put these women into the high risk category is because we see a lot more older women now getting pregnant. I think in India too, the age is increasing, but here we are seeing a lot more women that are beyond the age of 35 getting pregnant, and they have pre-existing diseases that are mentioned here: cardiovascular, renal, hypertension, diabetes, and so on. And so that increases their pregnancy risk even before they get pregnant. You can tell them that. The medical factors that are increasing it is, of course, HIV, hepatitis, tuberculosis. Substance abuse is a big one here in the USA, and a bad history, previously a bad OB history. So in USA, as I mentioned, a third of the deaths are due to the heart. And so here, if you have a patient who is sick, who is not able to breathe, or oxygen is going down, or a blood pressure is going down, we immediately request a maternal echo. And many of our MFM fellows are trying to learn how to do maternal echoes. And so that way we can rule out maternal cardiac disease. Pulmonary hypertension is also another cause: arrhythmias, respiratory failure, shock, preeclampsia, and renal failure. In India, it is estimated that, look at the number of deaths. About 16 years ago, 69,000 women died from pregnancy causes, and back this past year, only 23,000. I mean, that's a huge number. It's not only, but compared to 69,000, it's a big drop. So the WHO 2 years ago said that in India, the number was 145 deaths per 100,000. The pregnancy-related complications are mostly seen in younger women, that younger women are at much higher risk, maybe because they are not coming early for the care. So 2/3 of the patients in India that die from postpartum hemorrhage. Huge. That's why your placenta accretas, take the uterus out. If you leave it in, they can hemorrhage so badly. Here we do not leave it in. We used to think and talk about it, but no more. We just do a hysterectomy. If she's bleeding, get it out. We don't leave the placentas in. Anyway, postpartum hemorrhage, postpartum infection, pregnancy-induced hypertension, and unsafe abortions is a very, very big problem from what I can see in India. And I think part of it may be because of the training, because here in USA, you have to train to, well, you can elect not to, but abortion training, doing DNCs is critically important for us. And even up to 22 weeks, the residents are learning how to do DNEs and DNCs and not medical abortions. So there was a study called the Million Death Study. It was right around the time of the millennial goals. And at that time, they looked at the deaths, and you can see the Northeast is really heavy duty paying for these deaths and contributing to the numbers. This is 350 deaths per 100,000 in these states. Southern states, it's far below that. So, this group was called, these states are called the EAGA group, or the Empowered Action Group, where the government is trying to help. And so the numbers are going down there. This is, as of this paper, is as of 2014. And then this paper is from 2021. And here you can see that the causes here, they're talking about how to bring that number down. So they looked at the causes from 20 years ago. Hemorrhage is a huge one. They had a big group called other obstetric complications, but they didn't define what that was. And I wonder if some of those are not cardiac related, because patients were not getting echoes. But so there's this big, huge gap that we don't know what's causing these deaths. It's almost as frequent as hemorrhage. And then, of course, your sepsis, indirect, and abortion is a huge one in India. Far, far more women are dying of abortion in India than in US. And hypertensive diseases is less risky in terms of maternal deaths than getting an abortion. So hemorrhage, other complications are the big ones. So in these 5-6 years, hemorrhage made 47%, abortion was 6 point. This is yet another paper, 6.7%. Other direct causes, they did not define it, 19.6%, indirect 9.6. But abortion really makes the list. Every time you go and see a paper from India, abortion is way up on top over there. Here are the causes in a pie graph. And this 47% is hemorrhage, and abortion is over here, right here, 5% deaths in this other paper. So where can you intervene? There are disparities, the educational programs you can really help patients with, and then of course, empower some of the states that have the highest problems. And so the Indian government initiatives have been quite good, actually excellent. They have this Safe Motherhood Program, the Reproductive and Child Health Program, National Health Program, and ASHA. I like that ASHA program. It's nice, 2010. And so all of this, and this is quoted in the journal the paper that's going to be printed soon. But this tells you that all of this has really helped. And they say in this paper that the death rate was 99 per 100,000, which was down from 400 per 100,000. So 1/4 the number of women are dying, a 75% reduction in 20 years. In UP and Uttarakhand, it's about 200. So it has halved, but it needs to go further down. 63% of the deaths are up still in the northeastern states and the poorer states, and younger women are dying far more frequently, I guess, because they're the ones that are getting pregnant. So we need to focus on the northeastern states. Now, globally, what can we do to prevent these deaths? So the SMFM, there was a workshop, and this is by our past president who initiated this. He's one of the authors over here, Dr. Blackwell. He was supposed to come to India last year, and COVID prevented him from coming. Anyway, they got together and they published this, and they said for the worldwide efforts, we have to really figure out what is going on. And there are older women now that are getting pregnant with medical conditions, unintended pregnancy. We need to help them with contraceptives. We need to help the underserved. We have to help family planning, because if you help with family planning, doing tubal ligation or whatever it is, salpingectomy is the way to go. Tubal ligation has a 1% failure. We are nowadays trying to do salpingectomy, removing the entire tube in our patients rather than just cutting it, because hopefully that has a lower pregnancy failure rate and lower pregnancy rate following the surgery. Safe abortions, critical. It will reduce maternal death by 13%. And so medical abortions, 0.7% in USA deaths occur from abortion, whereas in India, it's a whole lot higher. So what can an obstetrician alone do in India? There is a tool that was published. It's called the OBCMI tool. It's the comorbidity index tool, and they give a score. So you can score the patient. And these are all the diseases. Don't try to look, it's hard, but here. So whenever you have these diseases, just give the patient points, and you can see these are the points you can give for the diseases they have. And here are some more points, and then you add up the points. And if you have 0 points, that's excellent. But if you have 9 points, that really puts the woman at risk. So that's your comorbidity score. So you can use this comorbidity index score. And if you look at the score, a woman who has a score of 9 or greater than 9, her chances of death are so much higher. It's not percent of death, but that is percent of all women that died. These many people will have a high score. Whereas if you have a lower score, that makes up only 0.41% of all the mortalities. So you want a 0 score. So you could go through this and do your scoring. And if you want these slides, email me and I will send this to you so you can keep those scoring cards in your office. There are these women with 0 scores. You can actually prevent these disease. Even if you have a score of 9 and you try to be prepared ahead of time, you can prevent 9% of those deaths because you are prepared for it. Teamwork, you just heard the wonderful talk on teamwork. So teamwork will help you. If you realize that you have such a high score, you'll go asking people, come on, help me do stuff. And so the training should be provided in residency programs. We should, there's lack of abortion providers in many areas. And so that should be in USA, it's now becoming sort of common in Texas that people are not going to do DNCs, which is really sad. And we are trying to fight that in the courts. But because of this disparity and lack of finances, people can't fly here, there, and everywhere to get termination. And they're going to be put at risk for death. So we're very concerned about it. Important strategy is early, reliable identification of the woman. Score them, figure out what her risk is. And then once you identify, you train the residents, you implement the safety bundles. There are many, many safety bundles that have been described by SMFM. You also in India are doing the safety bundle training. Team training, critical. Team training is very, very critical. You need all your help. One person can't do everything. And be prepared when the patient is 3, 4, 5, 6 months. Don't wait till she's in labor. It's too late by then. Stratified levels of maternal care depending on the risk, and improvement in communication. Very important to improve your communication and address the social determinants. And I think that's my last slide. So be prepared for the unseen complications. Be sure that you have all your, whatever cards you want stacked up properly so you know what to do when she comes in. And the youngest women can get a PE, can get an amniotic fluid embolus and die right there. So be prepared for all of that. If you want a copy of these slides, you can email me. I'll be happy to send it to you. And I think I'm on time and I want to get out soon so that Dr. Arthur can give his talk. It's 11 p.m. He'll give his talk and he'll probably go to bed after that. Thank you very much for your attention. All right.
Hello.
Yeah, go ahead.
Thank you, Dr. Asa.
Nice to see you, Dr. Alpesh.
Thank you. Good morning from India.
Yes.
We are usually, you are a permanent speaker in all the critical care in obstetric conference. And this time we have you on online platform, virtual platform for the first time. Good to see you. You have nicely covered so many, you have presented so many data, US, India, and so many data. Yes, a recent MMR in India is 115. So we have gone ahead of it, and we are, as you have mentioned, in India, I think we would be able to achieve SDG goal by 2030. And I would like to share one good news from India is that out of nearly, there are 10 states who have already achieved SDG goal or near to SDG goal. Of course, Gujarat is also one of them. And you have mentioned that cardiovascular diseases is at top in USA, whereas still we are facing with PPH, and that is why we are also doing lots of activity to update our members and paramedics for PPH. We are having unsafe abortion, sepsis. These are the major indications for maternal mortality in India. Thank you very much for your excellent talk. You have nicely covered all the aspects. And thank you. I would like to inform all the delegates that Dr. Asa has helped us in coordinating with SMFM session. She has communicated with all the expert faculties of different fields. They all are master authority of their fields. So thank you, Dr. Asa, for helping us for this session. Thank you.
Thank you very much. And it's always a pleasure, Dr. Alpesh. Anything for you. Thank you.
Thank you. So for next talk.
Yeah. Our next talk is on persistent hypertension after pre-eclamptic pregnancy. And to speak on this, we have Professor Arthur Jason Ward. He's the director at the John Hopkins Hospital, and he's an expert in maternal fetal medicine and surgical critical care. I think this is a very relevant topic, and I invite Dr. Jason to speak on persistent hypertension after preeclamptic pregnancy.
All right, thank you so much for that introduction. And we will go ahead and get started with the talk for the essence of time. So first and foremost, I have no disclosures. And the objectives of this talk will be to define persistent postpartum hypertension after preeclampsia, to discuss the risk factors for persistent postpartum hypertension, and to discuss management strategies for persistent postpartum hypertension, and then discuss treatment algorithms of care. So first, the definition of preeclampsia. So preeclampsia is usually defined of new onset blood pressures of systolic blood pressures of greater than 140 for non-severe preeclampsia, and systolic blood pressures greater than 160 for severe. And for the diastolic components, that would be 90 and 110. Many times proteinuria is evident in preeclampsia, both non-severe and severe. But in the absence of proteinuria, thrombocytopenia, renal insufficiency, impaired liver dysfunction, pulmonary edema, and cerebral or visual symptoms can also be added to augment the definition. While the incidence of preeclampsia or hypertensive disorders of pregnancy within the United States is somewhere between 4 and 7%, the incidence in India is actually higher at 8 to 10%. So it sounds like it's a very big problem there. So now that we've defined preeclampsia, let's talk about persistent postpartum hypertension. So when I first heard this term, there were multiple things that I thought of. So first, it can be exacerbated chronic hypertension by superimposed preeclampsia. It can be newly diagnosed postpartum preeclampsia after a normal intensive pregnancy, which makes up about 2% of all pregnancies. Or it can be this persistent incidental postpartum hypertension after preeclampsia that is not superimposed with antenatal hypertension. And that's the type of hypertension that we'll be discussing today. After we define what is persistent, after define like what exactly is the postpartum hypertension, we have to define what is persistent. So depending on who you read or the studies that you look at, persistence could be requiring antihypertensives to discharge or greater than 72 hours. It could be requiring antihypertensives up to 1 week, or it could be requiring antihypertensives up to 6 weeks postpartum, or even at 3 to 6 months and beyond. Again, going over the definition by the American College of Obstetrics and Gynecology, hypertension in pregnancy is defined as a systolic blood pressure greater than 140 or diastolic blood pressure greater than 90 on at least 2 occasions 4 hours apart. Then, of course, we have severe range hypertension with systolics of greater than 160 and diastolics greater than 110. Chronic hypertension is any of these diagnosed before 20 weeks or being greater than 3 months after the postpartum period. And then you have chronic hypertension, which is superimposed on preeclampsia. Recently in 2017 and in 2018, the American College of Cardiology and the American Heart Association changed their own definition of hypertension to decrease it from a systolic blood pressure of 140 to 130 and a diastolic blood pressure from 90 to 80. The American College of Obstetrics and Gynecology further created a statement saying that even though they respect this change, it is unclear what this new diagnosis of hypertension will have on outcomes of reproductive age women within pregnancy and outside of pregnancy. When we speak of more critical illness in hypertension, that's when we talk about hypertensive urgency and hypertensive emergency. So by our medicine colleagues, hypertensive urgency is an elevated systolic blood pressure of greater than 180 or diastolic blood pressure greater than 120 without evidence of end organ damage. So again, this is different than what we would consider severe range hypertension. Hypertensive emergency is an elevated systolic blood pressure greater than 180 or a diastolic blood pressure greater than 120 with evidence of end organ damage. Repeat blood pressures are not necessary to have these definitions. And I'm sorry for going through all of those definitions, but I think having the definition or framework in your mind is very important when you talk about treatment algorithms for persistent postpartum hypertension. If someone has hypertension alone, you would just kind of stop the vasoactive drugs. That could be anywhere from methergin or ephedrine or things of that nature, and start antihypertensives and look for a treatment response. If they have hypertension plus end organ damage, which could be heart failure, palpitations, shortness of breath, pulmonary edema, you might need to look further into their oxycosis, cardiomyopathy, or pheochromocytomas and get expert opinion. If it's hypertension plus proteinuria, of course, this would bring back decision-making algorithms for preeclampsia, HELP syndrome, or so forth. And you might actually add magnesium sulfate to your antihypertensive treatment. And then, of course, if you have hypertension plus neurologic deficits or symptoms, that would make you think more so of stroke or any sort of reversible cerebral vasoconstrictive syndromes. And of course, as we've mentioned before, hypertension plus nausea, vomiting, epigastric pain, low platelets can make you think of HELP syndrome. And if there's no response to treatment of magnesium sulfate, antihypertensive, or supportive care, that might, depending on how far out postpartum that patient is, it may actually make you think of other things such as TTP, hemolytic uremic syndrome, or catastrophic antiphospholipid antibody syndrome. So what is clear is that within ACOG, severe range blood pressure should be acutely treated with antihypertensives within the postpartum period. Intravenous medications can be labetalol, intravenous hydralazine, and oral IR nifedipine, and all can be used safely to treat blood pressures. There is insufficient evidence to say that one agent is better than another or one is more effective. Here is a schematic of just some of the ways that you can use labetalol, hydralazine, and IR nifedipine. And sometimes IR nifedipine can be preferred, especially in patients that don't have intravenous access. For patients with persistent severe range hypertension or signs of end organ damage, one might want to use secondary agents that are more of infusions, such as esmolol and labetalol for beta blockers, or for calcium channel blockers like cardipine or clofidipine. Many of these medications may be available in your hospital, but usually they are either available on an intermediate care unit or critical care unit. However, depending on your labor and delivery, they may be available to you as well. For instance, at Hopkins, we have labetalol infusions available and nicardipine infusions available. So why is postpartum hypertension important? And from Dr. Shanani's last talk, it's because it's a major cause of severe maternal morbidity and mortality. Half of intracerebral hemorrhages and preeclampsia from preeclampsia occur postpartum, and about 1/3 of eclamptic seizures occur postpartum, and 50% are beyond that first 48 hours. Even though it is clear what the severe range hypertension targets are in postpartum persistent hypertension, it's unclear how to treat them with oral medications. So by the NICE UK and ACOG, they propose treating blood pressures that are greater than 150 with oral antihypertensives, which can be oral labetalol, hydralazine, or extended release nifedipine. And you should consider reductions or cessation of blood pressure medications if systolic blood pressure is less than 130 or if diastolic blood pressure is less than 90. When we talk about examples of end organ dysfunction, of course, there are neurologic, which can be headaches, visual disturbances, seizures, altered mental status, and stroke. Cardiac, which can include demand ischemia or infarction, acute renal failure, and then vascular for aortopathy patients or patients with Marfan syndrome, they can have aortic dissections or peripheral ischemia. And then, of course, there's acute renal insufficiency with elevated creatinine or even failure with elevated creatinine along with oliguria. If the patient is still pregnant, you could also have a placental insufficiency abruption, which could lead to preterm birth. So for persistent postpartum hypertension, who is at risk? Well, we know that maternal hypertension and proteinuria usually resolves within the first week, but within that week, it can be bimodal, which means that it gets better and then it gets worse again within the first 72 to 96 hours. However, approximately 60 to 70% of women will actually need antihypertensive medication at 1 week if they have preeclampsia with severe features. The good news is only 20% of these women will need need antihypertensives at the 6-week postpartum period into 1 year. And these women that are at risk for this are usually have obesity or a BMI greater than 30, have African American or Black race in the US, advanced maternal age, which is defined as an age greater than 35, or have early onset preeclampsia, defined as preeclampsia at less than 34 weeks gestation. So why does it happen? Why do, if the treatment for preeclampsia, or if one of the treatments for preeclampsia proposed to be delivery or evacuation of the uterus or the placenta, why is it that women continue to have persistent postpartum hypertension? Well, one is volume expansion. There's a thought that the volume expansion during delivery with contractions and intravenous fluids and magnesium, and even blood and postpartum hemorrhage, can sometimes exacerbate the volume expansion within pregnancy and cause an inflammatory and angiogenic cascade. Speaking of angiogenic cascades, there can be a persistence of angiogenic substrates such as VEGF, S-FLT, or placental growth factor, which can remain within the system up to for months after delivery. Also, subsequent use of vasoactive medications like metrogen or ergo derivatives, ephedrine, and sometimes Nsaids have been theorized to precipitate persistent postpartum hypertension. In the US, with access to care, underdiagnosis of chronic hypertension, which is exacerbated by pregnancy, is often a reason as well, but there can be other pre-existing or underlying conditions such as thoracicosis, TTP, and renal artery stenosis, which are also exacerbated by pregnancy and delivery. So what's the best agent for someone who has persistent postpartum hypertension after 72 hours? So calcium channel blockers like nifedipine and vasodilators like hydralazine and beta blockers like labetalol are all effective in the management of postpartum hypertension. And again, like the IV substrates, it's unclear with preferentiality or efficacy which one is the best. However, there are some reports that calcium channel blockers like nifedipine may actually lower blood pressures more quickly and prevent severe range blood pressures. However, these studies are very small, and one of them actually compared nifedipine to methyldopa, which is an antihypertensive that is not commonly used in the US. Other considerations would be if the patient has type 2 diabetes mellitus, chronic kidney disease, is a renal transplant, or has cardiac disease such as heart failure or left ventricular hypertrophy. So are there any ways that we can ameliorate persistent postpartum hypertension after preeclamptic pregnancy? There was a study that actually used furosemide by Savai et al. And they found that, and the theory was that proactive fluid mobilization could abate postpartum hypertension. This was a randomized controlled trial, double-blinded in a single center study with furosemide, which again is a loop diuretic, and versus placebo. And the patients that were involved, or the participants involved in the study, were preeclampsia with and without severe features, as well as superimposed preeclampsia. And they found that torsemide did not significantly reduce postpartum blood pressures less than 150/100, which was the primary outcome. They also noticed that there was really no change in the use of acute antihypertensive medications, length of stay, need for readmission, hypertension at 7 to 10 days, or hypertension at 6 weeks. However, they noted that limitations of the study were that the original study was powered for torsemide for 5 days postpartum, and many of the patients were actually discharged on day 3, and there was a large non-compliance to follow-up clinics. Another is the use of Nsaids. Another randomized controlled trial, blinded and single center, showed that Nsaids did not have an increased risk of persistent hypertension and or postpartum preeclampsia. The theory behind it is that because Nsaids directly affect the kidney, excuse me, salt retention, volume expansion, and diuresis, that Nsaids would cause persistent postpartum hypertension or would cause persistent blood pressures greater than 150/100. However, this was not found in this study. So are there any biomarkers besides demographics that can be used? We actually, kind of segueing to the kidney, did our own study here at Hopkins where we looked at AT1R autoantibody in women with preeclampsia and 4 years postpartum. An AT1R autoantibody is basically an agonistic antibody that works at the level of the angiotensin receptors and can cause a cascade of hypertension, endothelial dysfunction, et cetera. And we found that, interestingly enough, that women that had elevated that preeclamptic women had higher AT1R autoantibodies at during pregnancy and at their 4-year postpartum period. And within the preeclamptic patients, participants that had persistent or incident hypertension had higher AT1R autoantibody levels than those who did not. So just something that's very interesting, and we're continuing to do this work. So postpartum treatment algorithms. So they've had severe range blood pressures, you've treated them, and now how do you keep them safe from discharge and on to the rest of their life? So generally speaking, for most of us in the US, we see patients at the 6-week postpartum visit and at the 3 to 10 day blood pressure check. But after the 6-week visit, it becomes a little bit more difficult to figure out who and how their blood pressures are going to be controlled. Also, it becomes difficult to kind of understand what their blood pressure targets will be. Are we still going to use the ACOG guidelines of mild range and severe range, or are we transitioning to the ACC-AHA guidelines that look at stage 1 hypertension and stage 2 hypertension? And this is when the concept of interconception care becomes incredibly important. And interconception care is basically that time period from the postpartum period to the next pregnancy, which is a window of time where women that have chronic medical diseases like hypertension or persistent hypertension can be treated by a primary care specialist, whether it's an internal medicine doctor or a cardiologist before they see maternal fetal medicine for the next pregnancy. At Hopkins, we do have a postpartum care checklist that specifically deals with hypertensive disorders of pregnancy, among other medical problems that are related to obstetrics, like pregestational and gestational diabetes, mood disorders, and cardiomyopathy. But specifically looking at hypertensive disorders of pregnancy, we really institute getting blood pressure monitoring immediately postpartum, being aware of medications that can cause hypertension like decongestants, ergotamines, and even though Nsaids don't cause persistent hypertension within the admitted period, it's unclear if continued use postpartum into the 4 to 6 week range causes issues. Also to making the patients aware of long-term sequela, and then also to doing long-term screening, such as by looking at blood pressure, body mass index at 6 months postpartum, annual fasting lipid checks, and hemoglobin A1Cs, as well as your urinalysis when appropriate to look for proteinuria. So in conclusion, persistent hypertension after preeclamptic pregnancy is a known risk. Despite its prevalence, there are no particular treatment algorithms nor modifiers to decrease the risk or persistence. Institutions should be poised and charged to care for these women, both postpartum and for their interconception care. And hopefully with this, we will mitigate long-term cardiovascular risk. Thank you again for this invitation, and I'm open for any questions.
Thank you. I think excellent lecture. Well, I think all the aspects of this topic have been well covered, and I feel that presently even here this condition tends to be under-reported because it is underdiagnosed, and most of the times patients tend to get lost to follow-up because post-delivery, even those post-delivery follow-ups are so important, so that at that time we must pick up these conditions, keeping in mind the predisposing conditions, as you rightly said, that would be there. So, and obviously the checklist, I think that is very important. All of us should be following those checklists so that we don't miss on these patients who would probably land up in persistent hypertension later on. I think, thank you very much.
Thank you.
Yeah, please. Yeah, please. I know it must be an odd hour at your place, but please be there till the end of the session. So if there are any questions, thank you very much.
Sure thing.
Thank you, Dr. Walk. And now I invite Dr. Nick Burns. He's from University of Washington, Seattle, USA. He is a specialist in maternal and fetal medicine in Department of OB&GY at University of Washington. He is a founder of CREOGS, very interesting name, that is Coffee Training of Residents and Junior Faculty, which is really needed. On his part, honors and awards are Donald R. Custom Courage and Lead Award 2020, Outstanding Resident Award for Professionalism and Humanism in Women Health, He is a 40 feature voices of maternal fetal medicine 2020, Alpha Omega and Alpha 2015, Gold Humanson Honor Society 2015. He is a member of National Advisory Council 2018 to 2022. And on his behalf, there are many presentations, abstracts, and publications. So thank you, and I invite Dr. Nick Ban to deliver his talk. Thank you. Dr. Nick.
All right. Thank you very much for the very kind introduction. And yes, my name is Nick Burns. I'm a fellow in maternal fetal medicine under the tutelage of Dr. Rishignani at the University of Washington. I'm presenting this talk today on behalf of one of my other mentors here at the university, Dr. Catherine Albright. Dr. Albright and I co-authored some guidance on the topic of acute severe hypertension that's in use at the University of Washington hospitals. And that's what this talk today will largely be based on. Neither Dr. Albright nor I have any relevant disclosures, and our objectives today will be to be able to identify acute severe hypertension in pregnancy, to define the timely treatment of acute severe hypertension, and then compare various medications for the treatment of acute severe hypertension. We'll start with some background, so I think that Dr. Rishignani gave us an excellent overview of why hypertension is such a concern. Globally, over 800 patients die daily from preventable pregnancy-related and childbirth-related causes daily. The majority of these deaths occur in low-resource settings. When we look at global maternal mortality overall and causes of death, as Dr. Rishignani pointed to earlier, there are a number of indirect causes that have the largest share of maternal mortality worldwide. But then when we look at direct causes globally, hypertension trails only hemorrhage for direct causes of death in the pregnancy and the postpartum period. So again, this is something that we have control over and something that we should strive to improve upon. Not only does hypertension cause issues with mortality, but also with significant morbidity. It's true that mortality has some of the most striking statistics. We also must remember that severe hypertension increases risk for a number of other conditions, such as stroke, pulmonary edema, or renal failure in the mother, and placental abruption or fetal growth restriction on the fetal side. One thing that we would be remiss to not speak about is the prevention of severe hypertension. While we'll spend the majority of the talk again talking about treating severe hypertension, it has been proven that treating hypertension antenatally before it ever reaches severe levels decreases the risk of severe hypertension in pregnancy by up to 70%, according to some studies. The landmark CHIPS trial, which was a trial in the United States of tight versus less tight control of blood pressure in pregnancy, targeted a goal diastolic blood pressure of 85 versus 100 in the less tight arm, demonstrated that tight control reduced the risk of severe hypertension in later pregnancy without any adverse effects on the fetus. No study has yet to demonstrate what exactly the perfect blood pressure should be, as Dr. Vaught pointed out earlier, and this may even vary by individual. But studies have consistently demonstrated that treating patients with high blood pressure allows us to achieve the best outcomes without harming the fetus. And it's with this evidence that actually just yesterday, the American Heart Association released new guidance advocating for lower blood pressure targets in pregnancy and more tight control than previously advocated. This statement will be published in full in the Journal of Hypertension in early 2022, that is, but that's a very exciting development that should probably change what we do in hypertension in pregnancy. But let's talk about severe hypertension in pregnancy and the diagnosis. Acute severe hypertension is defined as a sustained systolic blood pressure of greater than 160 milligrams of mercury and or a diastolic blood pressure of greater than 110 millimeters of mercury. And this diagnosis of acute severe hypertension is regardless of any diagnosis of an underlying blood pressure disorder, whether that be chronic hypertension, gestational hypertension, or preeclampsia spectrum disease. What do we mean by sustained? Well, when you have a patient in front of you who has this initial single severe range blood pressure, that is that 160 over 110 or greater, at that point, an OB provider should be notified and preparations immediately begun for treatment in the events that this blood pressure remains elevated and severe. You may recall that from blood pressure definitions, we may often space out the repeat blood pressure by up to 4 hours. But in the case of severe range blood pressure, the recommendation is to reassess again within 15 minutes, as sustained severe range blood pressure requires prompt management to prevent the morbidity and mortality concerns we spoke of earlier. So let's talk about that management now. The goal is to treat sustained acute severe hypertension, that is those 2 elevated blood pressures in that 15-minute period within 1 hour after the confirmation of diagnosis. It's important to note that the rapid lowering of blood pressure can actually be detrimental, particularly to the fetus. And so we're not looking necessarily to correct the blood pressure to normal range, but we're actually just looking to lower it a little bit to get it out of the danger zone, with the initial blood pressure goal settling somewhere between 140 to 150 systolic over 90 to 100 diastolic. Considerations should be made as well during this time period towards oral antihypertensive therapy. Once the blood pressure is non-severe, we want to prevent that severe range blood pressure from recurring again. So even though we're treating things acutely, we also want to be thinking towards the future of how will I prevent this blood pressure from going up? Part of the other things that we should be considering beyond the treatment of this initial severe hypertension is, as we mentioned before, the obtaining of IV access and labs. IV access will be necessary to facilitate treatment, and laboratories should be obtained, such as a CBC, CMP, and urine protein studies to assess for preeclampsia spectrum disease. Given the risk of severe range blood pressures to precipitate cerebral edema and a clamptic seizure, you should also consider at this point to initiate a bolus of magnesium sulfate. Even if it's unclear at the outset whether this truly represents preeclampsia versus a so-called chronic hypertension exacerbation, magnesium is prudent to administer. You can always discontinue it later if it's deemed that this is just an exacerbation of chronic hypertension and poses less threat to the mother. Fetal well-being should also be continuously assessed during these interventions, ideally with continuous cardiotocography if the fetus is viable. There's high risk of delivery within 7 days of acute severe hypertension, and so corticosteroids for fetal lung maturity should also be considered at this juncture. One of the more exciting things that I hope to speak about today is actually the initial treatment or choice of therapy. So before discussing the particular agents, I want to break down blood pressure into some components. You may recall from medical school training that the mean arterial pressure is directly proportional to both the cardiac output as well as the peripheral vascular resistance. So we can think about this in this diagram in the form of a fire hydrant of flow versus a faucet of flow, and how you might be able to achieve high pressure coming from each of those. On one hand, if you have high cardiac output or high flow, as in from a fire hydrant, you will get high pressure coming through a small hose as this. This is representative of, again, that high cardiac output condition that will raise that mean arterial pressure. With the faucet, in order to achieve the same pressure, we need to increase the resistance in the line. And so you pinch the flow here at the end. So this would be representative of an increase in peripheral vascular resistance. We can often lump our patients into one of these two categories as representing either a high cardiac output patient or a high peripheral vascular resistance patient. And while not all patients will be categorized neatly into one versus another phenotype, this is a helpful categorization that might help you consider your initial therapy. So again, just as a reminder of these initial therapies, we have a choice of IV labetalol, IV hydralazine, and pionifedipine. As a reminder of the mechanism, labetalol is a combined alpha and beta blocker, but when given IV actually has a much more preferential beta blockade effect, and thus has the effect of lowering cardiac output. IV hydralazine stimulates vascular nitric oxide release and causes arterial vasodilation, lowering the peripheral resistance in that fashion. And finally, oral nifedipine is a calcium channel blocker for vascular smooth muscle, causing vasodilation and also lowering peripheral resistance. These are the recommended drugs regardless of whether this is new onset hypertension or the patient is already on an antihypertensive regimen. So again, when we think about that diagram from earlier about the two ways that you can get elevated blood pressure, you might consider the patient with the severe range blood pressure. On one hand, you may have a patient with an elevated heart rate who has a wide pulse pressure that is a predominance of the systolic pressure. Her pulse is bounding. Maybe she has the metabolic syndrome, obesity. This is someone who would be much more suggestive of an elevated cardiac output state, and our recommendation would be to choose labetalol as your initial agent. On the other hand, you may have a patient with a lower heart rate or perhaps bradycardic with a narrow pulse pressure favoring the diastolic and the skin findings of something called levato reticularis, which I've shown here, which is a purple lacy reticular rash associated with vasospasm. This would be a patient who, again, you would put into the elevated resistance category and may be better off picking nifedipine or hydralazine as your initial agent. Demonstrated here are the initial dosing regimens for each of these medications. And I don't have to go through and read each of these, as you probably are already familiar with the dose cascade that is recommended here. What I do like to point out is that labetalol acts very quickly, and so the repeat dose recommendation is within 10 minutes to reassess the blood pressure. Hydralazine and nifedipine, on the other hand, the recommendation is to repeat after 20 minutes. The 20-minute recommendation here for IV hydralazine is because hydralazine can be particularly potent, and so it's recommended to wait a longer period of time before repeating a dose. Finally, oral labetalol is a drug that can be given second line if IV access is not attainable. This isn't a preferred choice, as nifedipine has shown some degree of superiority in randomized trials, but labetalol could be considered orally in a patient where IV access remains impossible or in low resource settings. Labetalol has been demonstrated superior to methyl-dopa for this purpose in randomized trials. The starting dose for labetalol in this instance would be 200 milligrams orally. In the event of resistant hypertension, that is failure to control the blood pressure after completing two of those aforementioned blood pressure regimens. So you go through labetalol and then go through hydralazine, or you go through nifedipine and then go through labetalol. That is what we'd classify as resistant hypertension. And as Dr. Vaught mentioned earlier, this is a scenario where you need to consult with specialists such as maternal fetal medicine, intensive care, or anesthesia. At this point, it's probably prudent to place an arterial line for ongoing continuous assessment of hypertension and considering transfer to a higher level of care, or if you are in the higher level of care, this is the point where you would be initiating the antihypertensive drip. In scenarios with a viable fetus, you should also certainly be making preparations for delivery after maternal stabilization, or if the blood pressure remains truly uncontrolled. And then finally, I know that Dr. Vaught just spoke on this, but we wanted to discuss just finally an endpoint with a note on postpartum hypertension. As Dr. Vaught pointed out, this is an oft forgotten time period where severe hypertension can still be observed. And there's significant morbidity and mortality during this time period. One study actually demonstrated that up to 70% of maternal deaths from hypertension can occur in the postpartum period. As Dr. Vaught pointed out, we may be lulled into a false sense of security as in the initial postpartum period, due to the effects of anesthesia and blood loss, blood pressure may appear to normalize. But with that fluid mobilization, usually in the day 3 to day 5 period, we may see an increase in blood pressure. And this requires prompt treatment, just as in the antepartum period. There has been much interest in the literature with respect to loop diuretics. Furosemide has somewhat been shown to reduce the need for additional antihypertensives, but as Dr. Vaught pointed out, this evidence can be weak. We at the University of Washington, just as kind of an anecdotal evidence, do typically use furosemide 20 milligrams orally for 5 days postpartum in order to help with fluid mobilization and ideally help with the need for additional antihypertensives. So I'll close here just with a quick summary of that hypertension in pregnancy, as you know, remains a leading cause of maternal mortality. We define severe hypertension today as that sustained systolic blood pressure over 160 millimeters of mercury, or a diastolic blood pressure greater than 110 millimeters of mercury. You should initiate and receive timely treatment within 1 hour of a confirmed diagnosis with the initial agents IV labetalol, IV hydralazine, and pionifedipine, thinking again towards the maternal hemodynamic picture and guiding your first choice of agent. Thank you very much for your time today. And I can pause for any questions. And these are some of the references that we used for this talk.
Thank you, Dr. Nicholas. And very good carry-on messages, I think, for particularly hypertension in pregnancy. That is, start immediate treatment if the hypertension is sustained. Very good. Then now there are three main agents adopted, that is labetalol, hydralazine, and nifedimic acid. And one more important thing which you said is that most of the death occurs because of hypertension are at postpartum level, because sometimes we just discharge patient within 24 hours. And at that time, blood pressure is normal. But after fluid balancing, after 48 or 72 hours, the blood pressure increases. So this is a very important point, that in an acute hypertensive patient, after delivery, we should not discharge it immediately. So very important points. Thank you very much, Dr. Nicholas, for a very good speech. We are all obliged. Thank you.
Our next lecture is on neurological emergencies in pre-eclampsia, and it was to be given by Dr. Bahas Sibai. Due to emergencies, the doctor would not be available, so we will request Dr. Asha Singhani to speak on this topic, and I thank Dr. Asha for pitching it at the last moment. We already know she's already been introduced, but again, Dr. Asha is a consultant obstetrician and gynecologist at Seattle, Washington, and she is the office bearer of the SMFM, that is the Society for Maternal and Fetal Medicine, and I request Dr. Asha to speak on this topic. Dr. Asha has actually done a lot of work in this COVID times, and I congratulate her for that also, because on the social media we could find that she has actually done a tremendous amount of work in during this COVID times. Though this is not really pertaining to the topic that she's going to speak now. But just as I was introducing and I was going through her CV, I realized that tremendous amount of work, and I think we all should recognize these her work even for during the COVID times. Thank you, Dr. Asha, and the stage is all yours to speak on this topic.
Thank you very much. Dr. Sabai, it's too late for him to give the talk. And, it's a bit tough to nail him down. And so I'm going to give this talk for him. Neurologic emergencies and preeclampsia. So we see that, we see a lot of eclamptic women dying. And one of the reasons they die is because the eclampsia or preeclampsia can cause brain hemorrhage and can cause brain emergencies. And unless we recognize it on time, it will not happen. And so we need to recognize it, and we need to have a protocol. And you can have, again, there are all kinds of these, what happened to my slide? There are all kinds of bundles available. And so we will just go through some of those things here. I work at the University of Washington where Nick is. It's a phenomenal institution and it's the birthplace of COVID in United States. So a lot of COVID studies actually come out through University of Washington, which is in Seattle. So the neurologic complications, there are so many different complications that can occur. And we usually conclude when the patient comes in with a neurologic symptom, we'll conclude that, oh, she has preeclampsia or eclampsia, but it may not be that. It may be so many different things. And here are the few things that they can have: preeclampsia, eclampsia, stroke, Press syndrome, cervical arterial dissection, cerebral sinus thrombosis, subarachnoid hemorrhage, and so on, AVM rupture, cerebral aneurysm rupture, and so on. So it is not always necessarily just eclampsia. There was a study that was published in 2016 by a professor in Guwahati who looked at all the abstracts, all the papers that were submitted to AICOG conferences, printed as well as abstracts from 1976 to 2014. And then he took all of these cases, including the cases that were seen in his department, and he came up with this conclusion, and I'll give you a summary of what he found in terms of strokes and eclampsia. Eclampsia affects 50% cases will be in the antenatal period, and intrapartum 30%, postpartum 20%. And in these women that get the eclampsia, the reported incidence, actually depending on where the woman is, which part of the country she is in, it could be anywhere from almost 2 to 3.7%. So it changes. The maternal mortality also varies according to where the patient is. It could be 2.2 up to 23%. So in northern India, it's higher. In southern India, it's lower. Those EAGA states that I had mentioned previously. Unfortunately, majority of these women are nulliparous. Majority of them are young. And the sad part is these are mostly uneducated or primary education only. And almost no one, these patients that get very, very ill, almost no one has come to regular antenatal care, and they get missed, and they'll come only when they have these issues. So 93%, few of them, the remaining 6% have had less than 3 antenatal visits. So here it is, they talk about how many patients have preeclampsia. This is that paper that I was mentioning to you. So 8 to 10% of all pregnancies are complicated by eclampsia and preeclampsia and eclampsia. And if you look at this, the incidence of eclampsia from 1969 up until 2014, the incidence has not changed. And it has not changed because patients are not coming, they're not getting the prenatal care. Hopefully the numbers after 2014 will be much better because all these other support groups are going there to get these patients from villages where they may not have any physician. The same paper showed that maternal mortality, over here it is eclampsia related maternal mortality, has not changed. And so maternal mortality is pretty high. In 2010, it was 9%. But it's, some years ago it was 17, but this really hasn't changed much. The way to change it back, I don't know when India started using magnesium sulfate. When I was in training, we used to do what was called Lytic cocktail. And even the Britishers did not believe in magnesium sulfate. And then there was a randomized trial, and then they started believing. And I know many of the Indian protocols are based on the UK protocols and NICE guidelines. So I don't know exactly when the switch occurred. I'm hoping that the maternal death rate from eclampsia, my guess would be that it's far lower than what it was in 2010. I just couldn't find the number for the most recent years. And my guess is it's much less because the maternal mortality rate has dropped so much. And this is one of the big contributors to maternal mortality. Even perinatal mortality is increased when moms have eclampsia. So what is the cause of death? Why do these eclamptic women die? Some of them die 30 to 70% because of neurologic complications. Some of them may have hemorrhage, and then some of them may have edema that may be so massive that it doesn't respond to any kind of diuretic or max sulfate or anything. And it's too late. There was an international study done regarding hypertension in pregnancy, and they saw that the neurologic features, if you put the neurologic features with the new onset hypertension, they said that that would be determined as preeclampsia. Now we know ICCOB recently, few years ago, it's been a few years, it's been at least, I want to say 8 years, but they changed their definition of preeclampsia. It could just be simply new onset hypertension after 20 weeks. But in the past, you had to have proteinuria. Now you don't need proteinuria. If you have new onset hypertension after 20 weeks, it's preeclampsia. So if in this particular paper, which is a bit older, if you had neurologic features and hypertension, they would call it preeclampsia. So the neurologic symptoms that these patients are, that they have are headaches, which is of new onset. Of course, anybody can get a headache, but if you give them Crocin or some pain medication, the headaches should go away. But if the headaches do not go away and they're persistent in spite of medications, then that would be preeclampsia related headache. Altered mental status, of course, eclamptic seizures, stroke, persistent blindness or scotomata, and cortical blindness, which is reversible, of course, as you all know. I'm sure you've seen many of these. It's reversible and it can be very, very sudden. So the from chronic hypertension to preeclampsia to eclampsia, what happens? The cerebral autoregulation is impaired and the blood flow to the brain, it's, it depends on many of these factors such as VEGF and split and inflammatory factors. So there is the cerebral autoregulation is impaired, which increases the blood-brain barrier, and there's more permeability, and the cerebral edema keeps increasing. It's very similar to the PRESS syndrome. You can see PRESS in non-pregnant people, and of course, people with chronic hypertension and so on. But in these preeclamptic cases, or actually almost all eclamptic cases, it's very similar to the PRESS syndrome, and you'll see those PRESS signs if you do MRIs or CT scans on these patients. And the thinking is it's probably neuroinflammation, and there are some changes in the angiogenic pathways that is causing this permeability, causing the cerebral edema, and causing the subsequent clinical findings that the patient comes with. So they looked at migraine patients and they looked at preeclamptic patients. And when they looked at both of these, it's very, very similar, where they have this endothelial dysfunction, and then they have the pro-inflammatory cytokine, which will cause the neuroinflammation, which changes the vascular reactivity and autoregulation, causing edema, and it very, very similar. So they think that there is some kind of a connection between migraine and preeclampsia. So going to migraine, if women have migraine prior to pregnancy, they have a 5-fold increased risk of preeclampsia. This is really very interesting because, as you know, we are giving aspirin to women who have higher risk factors for preeclampsia. And in those risk factors, migraine is not there. Somebody can do a study and, once it gets published, you can get famous. But so migraines do increase the risk of preeclampsia significantly. And the migraine is seen often in younger women that are of childbearing age. These two have very, very similar pathophysiology, as I showed you. And the strange thing is, during pregnancy, because of the hormones or whatever it may be, about 2/3 of the patients will have improvement in their migraines. Not all of them, but about 2/3, 1/3 will not. And if they breastfeed, it delays the migraines from returning after delivery. So it also has something to do with the hormonal levels. So we go to stroke. Next, we go to stroke. So what are the risk factors for stroke in the peripartum period? All of these factors, hypertension, preeclampsia, help, cardiomyopathy, patent foramen ovale. So anytime you have a stroke, of course, you'll do an echo to see if they have patent foramen ovale and maybe a DVT that just went up to the wrong side. Sickle cell, thrombophilias, migraine with aura. So migraine increases the risk for stroke, C-section, hyperemesis, diabetes and obesity, all the high risk factors. The other thing you have to remember is, I think Dr. Watt alluded to this earlier in his talk, that women that have severe PIH or even preeclampsia, aneclampsia, even mild preeclampsia, they, in subsequent years to come, they are at increased risk for stroke, increased risk for vascular dementia, cognitive impairment, and it's possible that this may be due to long-term cerebral small vessel disease. And so if you see a 20, 25-year-old having preeclampsia, and then she delivers and she feels fine, she's not out of the woods. She, as age increases, is at much higher risk for all of these complications, including cardiac complications. So these patients should be followed very closely for the rest of their lives. Press syndrome and the reversible cerebral vasoconstriction syndrome, it's vasogenic brain edema, as I mentioned previously. There is something wrong with the endothelium of these arterioles. There's some dysfunction, there is leakage, there is hypertension. And if you have an eclamptic patient, you will see that 98% of them will have press on the MRI, whether you do MRI or CAT scan, they will have 98% of them will have it. That's why, when we do discussions about somebody has eclampsia, should we be getting an MRI to look for press? Yes, it's going to show press. Essentially, everybody shows press that has eclampsia. So if the patient is unstable, it's best to first stabilize her and then send her for testing if you want to test her. And yes, we do send people for testing because you saw that it could be hemorrhage, it could be cerebral, cervical artery dissection, or it could be a thrombus. It could be so many different things. So once you stabilize her, then you can certainly send to look for other things, not for press syndrome. Press syndrome, you will get the answer anyway. What about strokes? There are two kinds of strokes. There's a study from India that was that said that there are 60 per 100,000 births, 66 women have strokes. In USA, it's about 30, so it's about half as much. And in USA, the maternal mortality is currently about 35 per 100,000 live births. Strokes account for 7.4% of these deaths. So you can have an ischemic stroke or you could have a hemorrhagic stroke, and the incidence is gradually increasing. The peculiar part is that in pregnancy, when you have a stroke, 66% will have a hemorrhagic stroke. The only way to know it is if you do an MRI or a CAT scan. In the non-pregnant people who have strokes, about 13% will be hemorrhagic, about 87% will be ischemic strokes. In the peripartum period, these are far more common than during the pregnancy. If in the middle of the pregnancy at 26, 24 weeks, a patient comes in with seizures, her blood pressures are not really very high. They may be high because she's going through an acute phase, but she doesn't appear to have preeclampsia. She may have ruptured her AVM. So AVM ruptures occur sooner in pregnancy. Strokes occur closer to the peripartum period, before or 2 days before or 1 day after delivery. And preeclampsia, eclampsia strokes occur peripartum as well, as you know. These risks can persist up to 12 weeks post-delivery. So you have delivered a mild preeclamptic, she's gone home, her blood pressure was okay, slightly elevated, you didn't give her medicines. because intermittently it was normal. She was going to check her blood pressure at home. And she calls you 8 weeks later with a bad headache. Bring her in, because she could be having a stroke. Even if it's 8 weeks out, she could easily be having a stroke because it can go on up to 12 weeks after delivery, not the typical 6 weeks that we think of. Now, there are many different reasons for ischemic stroke and hemorrhagic stroke, and I expect you to read this. Actually not. I've put this down for you. So the ischemic strokes are here, hemorrhagic strokes, and many of these associations are pretty common. And oh, I thought I had it and it disappeared. I'm sorry. Well, if you write to me, I'll send it to you. I did have 2 other slides and they seem to have disappeared. So anytime a woman comes to you with neurologic symptoms, you will go through this scan me. Should you be doing neuroimaging in her? Should you not be doing so? You will use scan me as your helper to decide whether they need to be scanned or not. So sudden severe headaches or seizures in a non-epileptic patient. Change in the position worsens the headache. So if they are still, they're on their back, they're okay. The minute they change, the headache is excruciating. Altered mental status, neurologic deficits, nausea, vomiting. She's taking tons of medication, all kinds of pain pills, not helping. And of course, her blood pressure is elevated. So this was just reported. The scan me was just, it's a very nice paper written by the neurologists from Columbia and New York. And they ask us to, go through this. Just remember this. If she has scan me, any of those, then scan her. MRI is preferred, but if there is no MRI, CT scan is perfectly all right, because most of the times a CT scan is immediately available. If the woman is pregnant, do not use gadolinium. It's in animal studies, it's harmful to the pregnancy. If you're doing a CAT scan and you need to use iodinated contrast, that's fine to use. Just don't use it in the first trimester. But second and third trimester, iodine is fine, as long as, we don't treat thyroid with I-131 Graves' disease, because that is radioactive iodine. This is not radioactive active iodine. This is just iodinated contrast, and you can use it with your cats if you need to after the first trimester. First trimester, you don't want to use it because the baby's thyroid is not working and it's not functioning yet, and it can create issues. So if a woman comes in with a stroke, she didn't have any eclampsia, the family says she did not have any, in India, they say she didn't have any fits. What do? She's passed out and frothing at her mouth. Alone, you as an obstetrician cannot take care of her. You need an entire team. Again, we are going to the concept of team approach. Before she comes in or as soon as she walks in, you're immediately going to get your anesthesiologist, your neurologist, the anesthesiologist. If you have an OB anesthesiologist, that will be great. An interventional radiologist and neurosurgeons right away. And if you're in a smaller place, then stabilize her and send her right away to the more tertiary center, so she can have all of these services available at the same time, because you as a single person cannot do it. And God forbid if she dies, and the death rate is high, you would be obviously blamed for it. The treatment, if you think she has an ischemic stroke, so majority of 66% will have a hemorrhagic stroke, but those of them that have an ischemic stroke, maybe she has lupus or she has antiphospholipid syndrome and has a huge ischemic stroke, you can use IV thrombolysis in ischemic stroke during pregnancy. You can also use mechanical endovascular thrombectomy, but you don't make the decision, have the neurosurgeons make the decision. If she has a hemorrhagic stroke, prevent rebleed, see why is it happening? Is it because she's got severe hypertension? Try to bring it down. If she is thrombocytopenic, try to fix it. Any coagulopathy, try to fix it. Get your CT angio, see where the bleeding is coming from, and see if you can do anything about it. And of course, the neurosurgical people are going to come and help you. If it's an AVM, they need to treat it. And you should not be using steroids. If she is 34 weeks or 32 weeks or whatever, you want to give steroids for fetal indications, don't do that. Don't do it, because steroids are actually harmful and worsen the situation if the patient has PRES or the brain edema. So it's very important to the understanding of maternal strokes actually currently is under study. Why are pregnant women getting strokes? Will they get a stroke again? There's not much literature on recurrence of strokes. There was one paper, a small retrospective study, where they saw that about 2% of them will have recurrent strokes. But this is future research, aspirin for prophylaxis in patients with migraine. I actually like the idea. I think I'm going to start doing it, because we give aspirin for such small reasons. And I think that hopefully somebody will do the study. But up until then, I may consider it. And when a patient suffers stroke, please get a multidisciplinary team to help you. That's my email, just in case. I'm sorry that other slide didn't work out. I had it. I don't know what happened to it. But thank you very much. I appreciate your attention.
Thank you, Dr. Asha. Thank you very much for elaborating this subject in much detail, and particularly the relations of migraine with this stroke condition is also very important. And now in India, in periphery also, there are MRI and CT scans are available. So I hope that our obstetrician will use these modalities more frequently, and will try to reduce this problem. So thank you very much.
Thank you.
So any question from the audience? I think we are out of time. So thank you again, all the faculties from US, and we are really very much thankful to you all, friends. Thank you. Thank you very much.
Thank you. Thank you, Dr. Alpesh. Thanks, Nick and Arthur. I think Tori is on the sepsis thing. Wonderful to see you. I'll see you. Take care. Thanks for being awake, Arthur.
Thank you. Thank you.
Thank you, madam.
Of course, thank you.
Thank you, our esteemed chairperson, Dr. Harsat sir and Dr. Mahendra sir. Harsat sir, I'm very sorry on behalf of Ahmedabad Society, as I didn't receive your CV. Our next session is severe anemia, which is the major killer disease in developing country like us. For that, I would like to invite our chairperson, Dr. Parul Madam. Dr. Parul Shah is the senior most amongst our chairperson. She is working since last 28 years of teaching experience. She is professor and head of Obstetric and Gynec unit of NHL Municipal Medical College. She is assessor of MCI and DNB students. She is a frequent examiner, and special interest is high risk obstetrics and emergencies. I would like to invite Dr. Nilesh sir. Please be on dais. He is clinical head and fertility specialist, Pune. He is gold medalist. He is presently a chairperson of Foxy Quiz Committee. He has won many awards: Dr. Usha Saraya Quiz Award, Best Debutant Award, Dr. Shirish Daftari Award. He has many publications in his basket. Our third chairperson is Dr. Sushmita Shah, madam. Please come. She is senior professor in NHL Municipal Medical College. Her special interest is UG and PG teaching. In research, infertility and high risk, she is doing excellent work. She is also an examiner and assessor of UG and PG examinations. All our delegates and senior members, ladies and gentlemen, we are sure you are enjoying this academic feast. Please note that we have an inaugural function and awards at 6:30 in this hall only. Please make sure that you be there, presence, and grace and honor the event. Thank you very much.
Hello.
Yes, good morning, everyone. We are starting with the session severe anemia. Severe anemia is really a major killer and remained first cause of maternal mortality in our country and all over the world. Now I invite Dr. Sadaya Hassan, Madam from Pakistan. And the topic is screening of anemia and interpretation of reports. That's it.
Thank you for the honor.
Good morning, Elsa and Paul, Madam. Let me introduce her. Yeah. Madam, your camera is off and your mic is also off. Can you just turn it on? Hello? Yes, you are fine now, Madam. Madam is a chairperson of Maternal and Fetal Health Commission,
Good to see you.
Suffolk.
Thank you. Can you hear? Thank you.
Yes. Madam is a co-chair, academic board and ex-vice president, Society of Obstetrics and Gynecology, Pakistan. She is a member of editorial board, Journal of Pakistan Association, and director concept of Fertility Center, Karachi. Can we start now, Madam?
Yes, please go ahead.
Yes.
You can start my lecture. I'm here.
We are starting in just 2 minutes, Madam.
Okay. Thank you.
We are starting with your session, Madam. Can you highlight the salient features of your lecture before we start? There is some time till we have your recorded presentation on.
Speak about screening of anemia and interpretation of its reports. I'm Professor Sadia Sinpal from Pakistan. So anemia needs to be evaluated to determine its underlying etiology and must be appreciated for both its primary medical impact on the patient and its secondary impact on the patient's comorbidities. Through patient history and physical examination, thorough patient history and physical examination are necessary to direct diagnostic testing and subsequent treatment. In case of obvious cues on the history of physical examination, the workup can be streamlined and focused on clear therapeutic choices. A multidisciplinary healthcare team should further evaluate anemia and in some cases seek consultation from a hematologist. So when we come to screening, I will discuss who is to be screened and what strategies one can take. But generally, screening can be clinical examination, which includes examination of the conjunctiva and other mucous membranes, examination of the retina. And now we have these phone apps where, as you can see here, light can be directed towards the fingertip and the hemoglobin assessed. And of course, we have the traditional laboratory testing. So one of the ways of screening for anemia is through the signs and symptoms, which we in the subcontinent are quite familiar with. And these include fatigue, weakness, lightheadedness, headache, pallor, or jaundice, tachycardia, palpitations, chest pain, dyspnea, cold distal extremities, and claudication. For pregnant women, these pose a greater problem, and including the pale skin, cracks at the side of the mouth, swelling or soreness of the tongue, brittle nails, or spooning of the nails in chronic anemia. While the symptoms, as I said earlier, chest pain, dizziness, weakness, these just get aggravated. Cold hands and feet, pica, shortness of breath, of course, go with it. Iron deficiency anemia is the commonest anemia in pregnant women, and other causes are folic acid deficiency, which causes megaloblastic anemia, use of drugs like anticonvulsants, folate antagonists, other hematological conditions can also lead to this, and hemolytic anemia, thalassemia, sickle cell disease, and hereditary spherocytosis. So what factors contribute towards iron deficiency anemia? Poor diet, menstruation, high consumption of cereals, legumes, and plant-based diets, and early marriage, which is quite prevalent in the subcontinental society, a low literacy rate, and poor socioeconomic conditions. So the serum ferritin usually falls markedly between 12 to 25 weeks of gestation, and most of the iron transfer to the fetus occurs after 30 weeks of gestation, which corresponds to the time of peak efficiency of maternal iron absorption. So this is and the consequences of iron deficiency anemia in pregnancy can lead to preterm birth, maternal anemia, puerperal sepsis, and low birth weight. So opinions vary about whether to screen for anemia or not, especially in the developed countries. Where it is not so prevalent. The WHO criteria for diagnosing anemia requires hemoglobin less than 12 grams for premenopausal females and 13 grams per DL in postmenopausal females and males of all ages. Universal screening for anemia should be performed at 12 months of age. This is according to the American Academy of Family Practice, their position statement. However, the evidence of the effect of routine screening for iron deficiency anemia in asymptomatic pregnant women on maternal health and birth outcomes is insufficient. But the American College of Obs and Gynae says all pregnant women should be screened for anemia and treated if necessary. So, and at present, there are no recommendations for routine anemia screening of non-gravid well adults. Now, most of our professional societies would go along with the ICCOB recommendation of screening all pregnant women. So the etiology of anemia is attributed to one of the three processes. And number one is the decreased production of red blood cells. And the number two is increased destruction of the red blood cells. And the number third is loss of blood. Any loss of blood, whether it's microscopic or macroscopic, that exceeds hematopoiesis will result in anemia. Frank loss of blood can be via trauma from any of the body cavities. It can be nutritional deficiency, it can be chronic disease or chronic inflammation like cancer, infection, collagen vascular disease, can be genetic illness, thalassemia, hemoglobinopathies, and enzyme abnormalities of the glycolytic pathways. Infections, for example, bacterial, viral, and protozoan, especially malaria in our subcontinental area, is a major global cause. Drugs and chemical exposure, bone marrow suppression results in anemia, and bone marrow suppression can be primary or secondary, and autoimmune disease, of course. So the prevalence is 60% is hypochromic microcytic anemia, and 6% is macrocytic, 34% is normochromic. So regions, this is not a huge problem in developed nations, where around 4% of males and 8% of females may have the diagnosis of anemia. However, regions with populations commonly show higher rates of anemia include Africa, India, Mediterranean basin, where sickle cell disease is more prevalent, and regions of the Mediterranean basin where thalassemia is more common. Regions with endemic malaria protozoal illness where anemia of chronic disease is common, and impoverished areas where there is higher risk of nutritional anemia. So as you can see in the global prevalence, there is the countries with the darkest red color are the ones with the highest prevalence of anemia. And unfortunately, we are all in that region. So the diagnostics tests, I will first give the diagnostic tests. We already talked about screening. So basically the CBC, complete blood count, is both a diagnostic and screening test. The reticulocyte count estimates the bone marrow red cell output. The iron profile, and the most important is serum ferritin. We want to be cost effective as well and not do a battery of tests, but serum ferritin reflects the body stores the best. Peripheral blood smear gives us the morphology. Serum creatinine tells us about the renal function. Thyroid function test will diagnose, just as TSH will do and diagnose hypothyroidism, and a coagulation screen for hemolytic anemia. LFTs and hemolysis profile, macrocytic profile, hemoglobin electrophoresis to screen for thalassemia, and an abdominal sonogram to check the spleen size, and bone marrow analysis or a hematology consult may be required to obtain this. So according to interpretation of these results, classification can be according to the mean corpuscular value. So microcytic is classified as an MCV of less than 80. Normocytic is between 80 to 100, and macrocytic is over 100. So when we get a microcytic picture, the diagnosis can be iron deficiency, thalassemia, chronic disease anemia, sideroblastic anemia, lead poisoning, copper deficiency. While if it's a normocytic picture, it can be early iron deficiency, acute blood loss, sickle cell disease, chronic disease anemia, infections, bone marrow disease, chronic renal insufficiency, hypothyroidism, autoimmune hemolytic anemia. In the macrocytic category, vitamin B12 deficiency, folic acid deficiency, drug-induced, riboflavin, ethanol abuse, liver disease, myelodysplastic syndromes. So comparing the three things, these are the three main tests which you can do for the type of anemia and iron deficiency to classify it. So now in iron deficiency anemia, I would like you to look at serum ferritin, because I favor this test the most as being most cost efficient. In iron deficiency, serum ferritin will be decreased. In chronic disease, it may be increased or unchanged. In sideroblastic, it will be increased. In thalassemia, it may be unchanged or even increased. Okay, and if you are rich enough to do all the three tests, serum iron and iron deficiency is decreased. In chronic disease, it's decreased. In sideroblastic, it's increased. In thalassemia, it is unchanged or increased. Now, the total iron binding capacity in iron deficiency is increased. In chronic disease, it's decreased or unchanged. In sideroblastic, it is decreased. And in thalassemia, it is unchanged or increased. So the results reporting and critical findings which help in differential diagnosis, these will help in the differential diagnosis for chronic disease and neoplasia, nutritional deficiency, injury, genetic illness, infection, autoimmune, and medication and chemical exposure. So I've already mentioned the differential diagnosis, and if the patient is actively bleeding, you basically have to treat the bleeding. The most common non-traumatic cause are chronic GI and genitourinary bleeding. Hemodynamic stability and appropriate intervention is required. Subtle hemorrhage can be observed and categorize the anemia. Three categories of the macrocytic, microcytic, and normocytic based on RBC size, and hypo and normochromic based on relative hemoglobin concentration. So basically, I'm repeating what I've already told you. You can have algorithms applied based on the red blood cells to help you with the management. This is not the domain of my lecture, so I will not discuss that. And so the clinical significance and conclusion are that anemia is a sign that warrants further evaluation to determine its underlying etiology. It must be appreciated for both its primary medical impact on the patient and the potential secondary impact on the patient's comorbidities. The diagnosis of anemia and its management is multi-speciality. Simple iron deficiency anemia is commonly managed by our obstetricians alone because it's so common, but anything that is not responding to your diagnosis should be referred to another specialist or a hematologist. Thank you very much.
Thank you, Dr. Sadia. It was wonderful to hear about screening of anemia. And I think in this era where we are in the 21st century, talking about all recent advances in medical field, this basic yet very important topic is much important. We had launched by Foxy the Anemia Mukt Bharat Abhiyan, and we have done the hemoglobin estimations of several women in this campaign. Not only this, our president, Dr. Alpesh Gandhi, sir, had his theme Foxy for Foxians last year. And in this, we had hemoglobin estimations of all this hospital staff also, which was done. I think this is a very important aspect to check a very simple test, but I think screening of anemia is very important because we have all the other complications because of it. And you highlighted all the tests which can be done for this. Thank you. Any other comments? Thank you so much. Any questions from audience? Yeah, so we'll move ahead. We have our next speaker, Dr. Rohana Hatuthowa from Sri Lanka. Can we have?
Thank you very much.
Thank you. Can we have Dr. Rohana's video, please? He is the founder chairman of Nine Wells.
Dr. Rohana. Dr. Rohana. Sri Lanka, Sri Lanka.
Dr. Rohana on severe anemia in pregnancy. Is he going to go live?
Have we done that?
We'll go to the third recording, Dr. Hira, then we'll come again. Is Dr. Rohana live? Next one.
Okay.
Next one. Yeah.
Yeah,
We'll go on to the next talk. That is Dr. Hira Tuladar from Nepal. And she'll be talking about making labor safe in severe anemia.
Can I play?
Yeah, good morning. It's my pleasure to be here in this session. You can go ahead with my presentation. Thank you.
Thank you, Dr. Hira. It is wonderful to have you here live also. She is the head of the Department of KIST, MCTH, and immediate past president of the Nepal OBGY Society. We welcome you, madam.
So first of all, I want to thank the organizers for giving me this opportunity to speak on very important topic, severe anemia in labor, which we face in our daily practice. So currently I'm working as professor and head of department in KIST Medical College Teaching Hospital, Nepal. And I'm also the immediate past president of Nepal Society of OBGYN. So regarding my presentation, we'll be focusing mainly on severe anemia in labor, prevalence, causes, pathophysiology, and impact of severe anemia on pregnancy. What are our major concerns during labor? What are the lab investigations, management during labor, and how to prevent it? So as we all know, anemia in pregnancy is defined as hemoglobin less than 11 grams per dl according to WHO. And severe anemia is defined as hemoglobin levels less than 7 grams per dl. So we come across this medical disorder very often. It is more common in developing countries because of poor nutritional status and high prevalence of parasitic infestation. And there are 3 degrees of anemia, and severe is less than 7 grams %. And when it is very severe, if it is less than 4 grams %, we say that this is very severe anemia. It affects more than 56 million women globally, 2/3 of the from Asia. And WHO has reported 35 to 75% of pregnant women in developing countries and 18% of women from industrialized countries are anemic. It is also considered one of the major risk factors contributing to maternal death in developing countries. It contributes to 20% of direct maternal deaths and 50% of indirect maternal deaths. And there are various papers published on anemia in women. And this is one of the papers which states that maternal severe anemia is associated with the risk of preterm and low birth with babies. Regarding causes of anemia, most commonly it is nutritional deficiency like iron, folate, and vitamin B12. And especially when pre-pregnancy poor nutrition is there, it predisposes to anemia in pregnancy. Acute or chronic blood loss, maybe due to GI bleeding or menorrhagia or antepartum hemorrhage. Infections, recurrent UTI, sepsis, malaria, HIV also predispose to anemia. Similarly, chronic renal disease, neoplasia, parasitic infestations also predispose to anemia in pregnancy. Hemolytic anemia, which could be due to drugs or congenital, or one of the manifestations of HELLP syndrome also is responsible for anemia. And similarly, multiple pregnancy due to increased demand, multiparity with short spacing, on-book cases, especially when anemia remains undetected and untreated during pregnancy. Rare causes are hemoglobinopathies and aplastic anemia. So basically, the pathophysiology is the impaired transportation of hemoglobin and thus oxygen to all the organs, including uterus, placenta, and the fetus. So there is tissue enzyme and cellular dysfunction when there is deficiency of oxygen transportation. And in the uterus, it leads to impaired myometrial contractility with various consequences like labor dystocia and later on atonic postpartum hemorrhage. The susceptibility of women with severe anemia to preeclampsia has been linked to deficiency of micronutrients and antioxidants, which we'll discuss more later. And severe anemia also predisposes to congestive heart failure, because during labor, it causes more stress and causes circulatory overload due to increased stroke volume and tachycardia. Now coming to effect of anemia on pregnancy and mother, there is higher incidence of pregnancy complications like preterm labor, preeclampsia, rupture placenta, and labor dystocia. And they are predisposed to infections like UTI and peripheral sepsis. They have more chance to PPS, which will worsen their condition in already anemic status. And there is more chance of subinvolution of uterus during puerperium, lactation failure. Maternal mortality usually occurs due to congestive heart failure, cerebral anoxia, sepsis, and thromboembolism. The fetal impact due to severe anemia is from early pregnancy, higher incidence of abortions, risk of preterm delivery, prematurity, low birth weight, intrauterine growth restriction, birth asphyxia, and even intrauterine fetal death can occur. And neonates are more susceptible to anemia and infections with higher perinatal morbidity and mortality. Anemic infants have cognitive and affective dysfunction also. Due to a state of low-grade chronic hypoxia, it induces maternal and fetal stress, leading to release of corticotropin-releasing hormone or cortisol, which can activate the maternal fetal hypothalamic pituitary adrenal axis. And iron deficiency also increases oxidative stress. These all can initiate preterm labor in anemic women. And placental dysfunction can lead to low birth weight and growth restricted babies and increased perinatal deaths in the babies of anemic mother. Iron deficiency also causes impairment of innate and cell-mediated immunity, contributing to increased risk of infections. As we all know that iron deficiency is the most common cause of anemia during pregnancy and labor. Incidence of hypertensive disorders and preeclampsia is also higher in these women, and the susceptibility could be explained by a deficiency of micronutrients and antioxidants, especially reduction in levels of calcium, magnesium, and zinc has been shown to increase the incidence. Intrauterine growth restriction and low birth weight of babies is attributed to chronic deprivation of oxygen to the developing fetus. severe maternal anemia, especially if it is present from early gestation with reduced placental weight and surface area of peripheral villi, is a determinant of nutrient transport from the mother to the fetus. Risk of low birth weight has been shown to be 3.6 times higher in a paper, published paper. Anemic women are twice as likely to go into preterm labor, and babies are more likely to be iron deficient and experience delayed growth and development, as well as behavior abnormalities in later life also. Regarding neonatal and perinatal complications due to chronic deprivation of oxygen from maternal blood, there is 4.3 times risk of stillborns reported in one published paper, and significantly higher perinatal mortality and intrauterine death have been shown in other researches also. Now coming to what are the major concerns of severe anemia during labor. This is a critical situation with increased risk of adverse fetal-maternal outcomes. And severe anemia in pregnancy, defined as hemoglobin less than 7 gram, requires urgent admission. And when hemoglobin is less than 4 gram%, this is a medical emergency. Clinical presentation. These women are usually already high-risk women, adolescents, multiparous, multiple pregnancy, or from lower socioeconomic status. The symptoms are weakness, fatigue, dyspnea, dysphagia, palpitation, and swelling. If we look at the signs, they are pale, there is facial puffiness, raised JVP, tachycardia, tachypnea, palpitation in long bases, hepatosplenomegaly may be there, edema over abdominal wall and legs can be seen. And in the heart, there may be murmur, true murmur, features of congestive cardiac failure may be there, glossitis, similarly stomatitis, chelosis, brittle hair are other features. So these are the clinical presentation by which we can identify the women with severe anemia. Severity of anemia can be determined by sending hemoglobin, hematocrit, and complete blood count. Type of anemia should be ascertained by sending general blood picture, whether it is microcytic, macrocytic, dimorphic, normocytic, hemolytic, or whether there is pancytopenia. Reticulocyte count also should be sent, and cause of anemia can be determined by various other special investigations according to the type of anemia. So in general blood picture, we can see microcytic hypochromic picture, and anisocytosis and poikilocytosis in iron deficiency. We can see malarial parasites if there is malaria infection. Aplastic anemia shows low or no counts, and only bone marrow can diagnose this. Sickling can be seen in sickle cell anemia. Toxic granules and abnormal blast cells are seen in leukemia, and target cells, loss of target cells can be seen in thalassemia. Red cell indices like RBC count, PCV, MCV, MCH, and MCHC are especially important in iron deficiency anemia and other deficiency anemias. Special investigations like serum ferritin, serum iron, iron binding capacity, percentage saturation of transferrin, RBC protoporphyrin, all are important in case of iron deficiency anemia. Now we are coming to the main focus of the presentation, which is management of severe anemia during labor. The severely anemic woman in labor carries significantly high maternal and perinatal morbidity, as already discussed. So they should always be delivered in a tertiary care hospital. And because severe maternal morbidity can occur, including near-miss events, and even maternal death can occur. And similarly, there is high perinatal morbidity, including preterm babies, low birth weight babies, and other complications. Cross-matched blood must always be available. Strict asepsis is very important because these women are already susceptible to infection. And severe anemia with congestive, if there is already congestive cardiac failure, then we should consult cardiology and the team should be coordinated for the management. If severe anemia is first seen after 36 weeks of pregnancy or during labor, it is an indication for blood transfusion. Or if the anemia is due to acute blood loss like antepartum hemorrhage or postpartum hemorrhage, then also blood transfusion is indicated. Similarly, if there is associated severe infection or sepsis, or patients who are not responding to oral or parenteral iron therapy, or symptomatic pregnant women with other complications like heart failure, they should also get blood transfusion. Labor should be closely monitored and supervised by expert obstetrician and team. Proper counseling and consent to be taken from the patient party. Whole blood and packed RBCs should be kept cross-matched, and they should be nursed in propped up position to avoid dyspnea. Oxygen should be standby and administered if needed, and strict antiseptic and aseptic precautions to prevent infection, and also measures to prevent blood loss should be taken. Prophylactic antibiotics should be started. IV line should be kept open, but overload of fluid should be avoided to prevent congestive heart failure. In already decompensated patient, diuretic can be given. During second stage, it should preferably be cut short by instrumental delivery like forceps or ventouse, because these women cannot withstand the stress of labor for a long time. Active management of third stage of labor is compulsory to prevent more blood loss. Oxytocin should be compulsorily given after delivery of the baby, but injection methergine intravenous is contraindicated to prevent heart failure. Even normal blood loss may be tolerated poorly in severely anemic patients, so we should be very, very cautious to minimize blood loss. To decrease cardiac overload, intravenous furosemide should be given after delivery. Close monitoring should be continued in postpartum period also for signs of decompensation, because during postpartum period also these women can go into congestive heart failure. They can have infection or they can have thrombosis. So appropriate thromboprophylaxis and contraceptive advice should be provided at the time of discharge. Hematinic supplementation should continue during postpartum management also. And erythropoietin is also coming up as a therapeutic option during pregnancy and the postpartum period to manage anemia. And during postnatal period, early ambulation is encouraged to prevent thromboembolism. Hematinics are continued for 3 to 6 months. Also should watch for subinvolution, peripheral sepsis, congestive heart failure, thromboembolism, and lactation failure during postnatal period also. They should avoid next pregnancy for at least 2 years or more. Lactation amenorrhea method, barrier contraception method, progesterone only pills are suitable for these women. POP can be started after 3 weeks. IUCD is also suitable for them. And if feasible, then they should be offered permanent sterilization after correction of anemia. So rather than facing the severely anemic women in labor, it is better to prevent anemia during pregnancy itself, or even pre-pregnancy. So pre-pregnancy counseling and dietary advice is important to prevent severe anemia in labor. Complete blood count at booking and 28 weeks in pregnancy to screen for anemia is compulsory for all the patients. And repeat hemoglobin can be done near term in high-risk mothers and multiple pregnancies. This is a paper published from Ethiopia to study the determinants of severe anemia among laboring mothers So they also found the similar results. Early detection of anemia and management during pregnancy and labor is very important. Iron supplementation and folic acid should be given to all the women where iron deficiency anemia and nutritional anemia are prevalent. Deworming is must during pregnancy. And to prevent anemia in neonates, delayed clamping of the umbilical cord at delivery is an important step. Packed red cell transfusion may be indicated for pregnant women with severe anemia who are close to due date, or if they have a chance of increased blood loss at delivery. So in conclusion, the take-home messages are that anemia is most common medical disorder in pregnancy, especially in developing countries. It contributes significantly to maternal and perinatal morbidity and mortality. Preventive measures before and during pregnancy is important. Extra precaution and management is necessary during labor to prevent complications. So thank you very much. And if you have questions, please. Thank you.
Thank you so much, madam. This was a very, very comprehensive and a well illustrated presentation. And no matter what, we cannot ignore anemia. Even when we have landed on the moon, anemia still continues to trouble us and our women. Thank you so much for a beautiful presentation, and more so, thank you for your wonderful commitment to the women of your nation, because I know you are in a nation with different kind of challenges, difficult terrains, and it is a difficult time for you. But we really appreciate what the Nepal OBGYN Society is doing and its commitment for the welfare and improvement of the pregnant women out there. I really wish we could have had you here personally, but maybe some other time when we are not so endangered by COVID. Thank you so much. And we really appreciate you giving your time and your presence here. Thank you very much.
Thank you, ma'am, for your kind words. Thank you so much.
And once again, it is our pleasure to invite our next speaker, Dr. Rohana Hathutuwa from Sri Lanka.
We welcome Dr. Parul Kotadawala, sir, to introduce.
Hello, welcome, Dr. Rohana. I hope you can see us.
Oh, yes, certainly. I can see you very well.
It is indeed a pleasure to invite you to this conference. I, in fact, expected you to come here personally. But anyway, we can see you well. Dr. Rohana is from Sri Lanka. He has been president of Sri Lankan College of OBGYN, and currently he is the president of SAFOG, South Asian Federation of OBGYN. Very active, quiet personality, but high academic standards. He was also the person responsible for the AUB classification of FIGO palm coin classification, which we all are talking about now. Dr. Rohana, the floor is yours.
Thank you, Parul, for your very kind words of introduction. And I must firstly thank Dr. Alpesh and also apologize to him for the confusion I had this morning. So I am very thankful to Dr. Alpesh Gandhi for inviting and giving SAFOG an opportunity to join in this wonderful conference on critical care in obstetrics, which is hosted by the Ahmedabad Obstetrics and Gynecology Society and FOXI. So we are very happy to be a part of it this day. So thank you again. And actually, I had wanted to give an introduction to anemia in our South Asian region. So I'll share my screen with you. So this is I will give a brief introduction to anemia in pregnancy in the South Asian region, which as I mean, from the previous lecture, you would have realized how great this problem is in this region. So anemia is common worldwide and affects 33% of the global population. So it's a global problem, and around 32 million women become pregnant with anemia or become anemic following pregnancy. So this is around 38% of annual pregnancies globally. So it is, as we can understand, it varies significantly across the regions. The Central and Western Europe only 24%. In Africa, we have a higher, that is 56%, and also South Asia contributes with 52%. So we have a very high significant rate of anemia during pregnancy. So as you can see in this chart, so our region is completely dark red areas. So that means we have a higher prevalence. So if we go into details in this region, so if you take Bangladesh, you can see it accounts to 49.6% of women, nearly 50% suffer from anemia. But the important thing what we can realize is in our countries in this region, the maternal mortality rate, of course, even in spite of the anemia is still high. Maternal mortality rate has come down very significantly, and it is 176 per 100,000 in Bangladesh at the moment. If we take Bhutan, the anemia is much less, is about 27%. And the maternal mortality is also around 86%, 86 per 100,000. So then India also similarly, it is fairly common, about 50% of the pregnant women anemic, but we can be very happy that the maternal mortality rate in India has come down very drastically. And I think the Indian Foxy and everyone is doing a very great job. And maternal mortality has come down to 167 per 100,000 live births. So when we take Maldives, the Maldives is also doing well, and the anemia is much less, is about 15.4%, and the maternal mortality rate is also quite low. It is 68 per 100,000. In Nepal, as we would have heard, it's about 46% the anemia, and the maternal mortality rate is still a little bit on the higher side, but still it has been coming down very much during the last few years. So it stands at 239 per 100,000. In Sri Lanka, also the anemia is not quite low. The percentage is 31%, though we in Sri Lanka have a quite a low maternity rate mortality ratio in the region, which is around 30, is a little bit more than 30, sorry, maybe around 33%. But this maternal mortality rate has been stagnant for the last few years in Sri Lanka. But anemia continues to be a significant problem in this country also. Right, so we can see from all these, so that some of the countries in our region, we have a higher anemia. So anemia, women in South Asia suffer disproportionately high rates of anemia, about 49%, And the factors which contribute to anemia in South Asia are multiple. So they range from early marriage and childbearing, high parity, short birth spacing, gender inequalities, lack of access to diverse and nutrient-rich food, infections, inadequate water, sanitation, hygiene. So these are some of the general things which affects our women in our region. So these are things which contribute to anemia. So this is not only an obstetric problem. So this is much more than that. And so we have to tackle this problem as a team. So this is the percentage of women aged 20-24 who were married or in union before the age of 18. So you can see that early marriage is a significant problem in our region. In Bangladesh, it is quite high. It's around 51%, and Bhutan 26%, India 31%, so Maldives is quite low, and Nepal 33%, and Sri Lanka 29%. So anyhow, except in Maldives, in all our countries, this early marriage has been a significant problem. And this also indirectly contributes to the anemia. So, so I don't have to go into details. These are the common anemias in pregnancy, which ranges from nutritional anemias to hemoglobinopathies, and then of course the rare types, the aplastic, hemolytic, and all the other things. So the most common what we realize is the nutritional anemia, but anemia is a late indicator of iron deficiency. So the estimated prevalence of iron deficiency may be 2.5 times of anemia. So you can see the gravity of the problem of iron deficiency is much more than it is, but anemia is the tip of the iceberg, but the iron deficiency is much more. So the percentage is a state of negative iron balance. Pregnancy is a state of negative iron balance. So as I say, iron stores are reduced without reducing serum iron levels at the beginning, and so iron stores can be depleted without any cause of anemia. And iron deficiency occurs and hemoglobin falls just above the lower limit of normal in the second stage, and the third stage is the one where we considered as iron deficiency anemia, and occurs because of the hemoglobin falls to less than normal values. So the consequences of anemia, as we know, it is not only about the mortality, it is associated with so many poor maternal outcomes, including increased morbidity due to postpartum hemorrhage, antenatal sepsis, and postnatal sepsis. They are more prone to these complications, and so therefore there is an increased morbidity in patients with anemia. And also during pregnancy, it gives rise to low birth weight in the South Asian countries. So more than 60% of these preterm births occur in African and South Asian countries. So these papers also suggest that maternal anemia, especially in severe form, elevates the risk of maternal mortality and accounts for 12% of the low birth weight and 19% of preterm births. And so this is, so therefore, anemia is one of the key issues which we have to tackle.
It's 11:30.
Then anemia is a severe public health problem in some of our countries because of the prevalence is high in Afghanistan, Bangladesh, India, Nepal, and Pakistan. Moderate public health problem in Bhutan, but in fact only Maldives has brought the prevalence below 20%. But no country in South Asia is on track to meet the World Health Assembly target to reduce the anemia in women of reproductive age by 50% by 2025. So I think so this issue which we are discussing today is quite significant because of this. So it is anemia is not only simply a medical problem. It has medical issues, social issues, as the attitudes and the malnutrition, and also it's a health right. So it's not the obstetricians, we alone cannot tackle this problem. So it is a thing which has to be tackled by a team. So we have to have good integrated planning, multi-sectoral approach, and the health systems have to be strengthened, and of course the community support should be there. So all these factors we have to consider in tackling this problem of anemia in this region, because it has, as was mentioned, it has grave outcomes, not only on the mother but on the newborn also. So anemia causes so many other problems like stunting, problems in breastfeeding, wasting, low birth weight, and childhood overweight, and so on. So it's so over and over again, what we have to understand, it is a great problem which has to be addressed, and which can so if we are able to address this issue, I mean, it can prevent so much of morbidity and mortality in our pregnant women. So I would like to end by saying that nothing can be finished in the first 100 days, nor will it be finished in the first 1,000 days, nor even perhaps in our lifetime on this planet, but we have to make a beginning. So this is by what has been mentioned by John Kennedy. So that is what we also, I think, should follow, and we have to make a beginning to tackle this problem. Thank you very much for your patience. Thank you.
Hello, thank you very much, sir.
Thank
you very much, Rohana, sir. It was really very nice, purposeful and useful lecture. And once again, thanks for your palm coin classification, which we and our students are using it regularly, and it is really so helpful. I thank Dr. Alpesh Bhai, Dr. Jignesh Bhai and Munjal for giving us opportunity. And on behalf of all three of us, we thank you all. Thanks.
Thank you.
Any questions for sir? Sir, thank you so much. I suppose there are no more questions. And thank you under your able leadership in Suffolk. We all in the Southeast Asian region hope to do better with anemia. I would just like to add a small development. Just recently in India, we have been able to raise the marriageable age for women from 18 to 21. Though it seems like a small step, but I think it will go a long way in reducing early pregnancies, teenage pregnancies, and pregnancy-related anemias and morbidity. Thank you for your very able leadership, and thank you for the time to be able to be here with us.
So along with Anemia Mukt Bharat, we all can do Anemia Mukt Asia together.
Thank you, Rohana sir, Dr. Nilesh Balkawade here from Pune. It was a wonderful lecture and overview of all the Suffolk region regarding the practices of anemia, incidence of anemia. Thank you so much. It was a wonderful lecture. Again, amidst this August gathering. Thank you.
Thank you. Thank you for
Thank you, resting chairperson. It was a wonderful session. Dr. Parulben, Sushma Ben, and Dr. Nilesh. We would like to go ahead with the next session of PPH, a scare of every obstetrician. And we have to chair the session, Dr. Rishikesh Pai, President-elect, and he is a liaising officer in FIGO. Rest, I think he will tell you. I would like to invite Dr. Pragnesh Bhai. He is a finest endoscopic surgeon in Gujarat. And I would like to invite Dr. Satyan, the young endoscopic surgeon. Please come, he's from Navsari. Welcome on the stage. And would like to give the next session to our respected chairperson. Dr. Rishikesh, you can invite Dr. Arun Kumar.
Hello, check.
Hello. Hello, good morning, everybody. First of all, I would like to congratulate Dr. Alpesh and all his team for a fantastic conference which is being held here in Ahmedabad. It's one of the first in-person conferences of the Federation, and we are really happy to interact with all of our colleagues and the faculty as well as many delegates who have come here. I would like to now invite Professor Arul Kumaram, who is one of the great leading gynecologists, I would say, in the world, past president of the RCOG, past president of FIGO, and he's of course knighted. It's very few people who have knighted Sir Arul Kumaram, and it's a privilege to invite him to talk, to give his talk on carbetocin and tranexamic acid reduced PPH related admissions to ICU. Sir, we are eagerly waiting for your talk.
Good morning, and thank you very much, Rishikesh, for the kind introduction, and Alpesh Gandhi for the invitation. And it's nice to see everybody, including Dr. Hathatur, President of SAFOG. So I'll start sharing the screen. I hope it comes out okay. So my topic is actually about carbetocin and tranexamic acid, whether it should reduce admission to critical care unit. And at the very outset, I can say I have no particular interest in this topic of clinic, and the learning objectives will be carbetocin should reduce blood loss and hence reduce admission to the critical care unit. And similarly, tranexamic acid also should reduce blood loss and reduce the admission to critical care unit. The first one, carbetocin, is given as prophylaxis, whereas tranexamic acid is given as treatment. But both, if it is combined, then it might give better reduction and reduction to the critical care unit. Now, the problem actually is when we look at the literature, there is very little papers published or hardly any looking at blood loss and critical care unit admission, because most of the studies are from low and middle income countries where the critical care units are not well organized. So they are put in a corner in a HDU bed or similar arrangement other than in the private hospital settings. So that's why Dr. Alpesh Gandhi has been a champion trying to drive establishment of critical care unit in most hospitals. So in research-wise, in future, we should include admission to critical care unit as an outcome criteria. Now, there's no doubt that postpartum hemorrhage is a burden for the global maternal health and maternal mortality. And if you look at the women who develop postpartum hemorrhage, this is 14 million each year, of whom if you take a 5-year period or a 6-year period, 480,000 have died, but 99% are really in low and middle income countries. Now, the fact is that they have surgery like hysterectomy, internal iliac ligation, they have blood transfusion, and as a result, they end up in critical care unit. And if the critical care unit doesn't have the facilities to look after them, they die. And if they die, they have an impact on the family, because 3 out of 4 healthy babies die within 6 months, or the mother dying, and the daughters have to adopt the role of the mother and may miss out on education. The loss of income leads to a deepening cycle of poverty for the family. So in other words, we can avoid all this if we have a good critical care unit along with the treatment of postpartum hemorrhage, of which the latest developments are carbetocin and tranexamic acid. So this is in a nutshell. 15 million postpartum hemorrhage, 75,000 die, and every 6 to 8 minutes, one die of postpartum hemorrhage. Now, not only the immediate aftermath of dying or hysterectomy, admission to ICU, and immediately like Sheehan's syndrome, renal failure, but they have also possibility of cardiovascular disease in later in life. This is a paper from Korea, which says that those who have blood transfusion following postpartum hemorrhage has an increased risk of cardiovascular incidents later on in life. So it's not only immediate, but also later outcome. Now, this is a very important graph saying that it is better to prevent and treat before they go down the slope into the death zone. So prevention is by carbetocin, and treatment it's the tranexamic acid. Obviously, if it is refractory to the tranexamic acid, one has to think about simple surgical techniques like a balloon tamponade or a compression suture. And if that fails, they have to think on hysterectomy. But as Dr. Rohan Hattattu mentioned, the pre-delivery hemoglobin or the anemia status is quite important, because if they are anemic, then they will die much quicker compared to if they have good hemoglobin. So it's from the very early antenatal care, we had to look at the outcome. And early treatment should be instituted, otherwise they will have coagulopathy and severe shock. So I'm going to emphasize that even in carbetocin studies and tranexamic acid, although we say within 3 hours if the treatment is effective, it may not be effective unless you give it as early as possible. Now, when we look at the question whether active management is necessary or not, it is very clearly necessary, because in placebo-controlled with active management versus active management, you can reduce the incidence of PPH by 65%. And the essential component of the active management at third stage is oxytocin. Now, this is the woman trial. This is one of the papers resulting from the woman trial. There were 483 maternal deaths in that trial of 20,000 women. And the answer or the problem was late presentation, maternal anemia, availability of blood transfusion, and poor infrastructure. This poor infrastructure refers to most centers did not have structured critical care unit or critical care unit care, even if they are put in the ward and hence succumb to death. So they were not monitored. The monitored signs were not acted upon, and they died. So it's quite important that we should avoid late presentation, avoid maternal anemia, make blood transfusion available, and enhance the infrastructure. The question about carbetocin now is actually carbetocin is heat stable, because if you look at oxytocin, these are about 1,890 samples and tested in 4 different countries. And oxytocin in 39.7% or 40% was ineffective because oxytocin is heat stable. And of all the countries, you can see 8% were from India, the population studied or the drug studied. Ergometrin, again, 75% were ineffective, bisoprostol, 38%. So it is quite important there should be a good manufacturing practice and a cold chain storage, temperature, maintain the quality of oxytocin. And heat stable formulation on oxytocin is currently not available because it has to be kept at 2 to 8 degrees centigrade. So from supply chain, where they are put into lorries and transported in containers in ships and so on, it is difficult to quality assure. So it's the responsibility of the supply chain managers, the procurers and distributors and medicine regulators to make sure that the cold chain is maintained if oxytocin is to be relied upon. This is a study done by WHO in 2013, which indicates, if you look at the top box, in low and middle income countries, and it is divided into those countries where they had low maternal mortality, moderate, high, and very high maternal mortality countries. The prophylactic use of oxytocin is very high, nearly 95%, 90, 91, and therapeutic oxytocin also high, 80, 85%. But nevertheless, if you look at the bottom line, the maternal deaths are high in very high maternal mortality countries. These are the poor countries who can't afford the cold chain storage. So this might be one of the problems in addition to the lack of coronary care unit. Sadia is there, Professor Sadia, so she might recollect one of these studies done in Pakistan as part of the WHO multi-center country survey. This is 13,000 women who were admitted to the hospital. 97% had prophylactic oxytocin. And of them, 187 bled as postpartum hemorrhage. Nearly 93% had oxytocin. But yet, 13 women died. And this might be partly because the current oxytocin did not help. They were not heat stable, or they didn't apply simple surgical techniques effectively because balloon tamponade was only 6. And tranexamic acid was not used as expected because this was a study long before the woman trial. This is a recent study published in 2021, that is this year. This is in France, and there was a heat wave, and they looked at the incidence of PPH was increasing, and it was about 6% or so 1 year before the heat wave, and with the heat wave, it jumped to 20% because I think the oxytocin got exposed for a short time and it got deactivated. So they replaced the stock of oxytocin and the PPH rate came back to about 6-7%. So it's quite important that oxytocin plays a major role, and we had to keep it as in a cold chain as possible. So it's not only from the point of starting, but also in transport, because 99% of the deaths occur in low and middle income countries. This is where the transport problem arises. Only 22% of health facilities surveyed across 64 countries had refrigerators. And the staff, only 1 in 4 knew that it has to be kept at a cold storage. So there is a problem, not only in manufacturing and transport, but also understanding of the staff. They take the oxytocin out of the fridge if it is. First of all, 22% there are no fridge available. Even if it is available, they take it out and put it outside. So heat stable carbetocin becomes a good boost for these countries in low and middle income countries. So the previous formulation of carbetocin, the first iteration, was not a heat stable compound, which was that we kept at 2 to 8 degrees. But the current one can be kept for 48 months at 30 degrees at 75% humidity. And this has been proven by various research. This is carbetocin kept at 30 degrees, 40 degrees, and it keeps maintained. These are different, either vial or ampule of carbetocin, and 95% efficacy is maintained for 40 months here. And if it is at 40 degrees, if for at least 6 months, and if it is 50 degrees, then at least for 3 months. So during transport, it won't get spoiled. Whereas the same syntocinon sent in the same shipment, within a very short period, so within 17 days, it degrades and the efficacy is less than 90% and becomes less and less as time goes on. So carbetocin is quite important. Now, in terms of action, it comes very quickly. The onset of uterine contraction with IV is 1.2 minutes and IM is 1.9 minutes. And compared to oxytocin, it takes 2.5 minutes with IM. And the most important thing is the uterine contraction lasts approximately 4 times longer with carbetocin. As you could see, if you give it intramuscularly, it lasts up to 2 hours. If it is IV, then it lasts 60 minutes or 1 hour. Whereas oxytocin lasts only for 30 minutes when given IM. So it's 4 times more effective in terms of controlling the contractions. Now you have to remember that carbetocin is a generic name, and there are a number of companies which are producing carbetocin, but most of the carbetocin available in the market are 2 to 8 degrees. You have to keep it. So you have to look for heat stable carbetocin. Ferring has changed from the low temperature carbetocin to heat stable carbetocin altogether. Now it can be used in cesarean section, and the dose is 100 microgram heat stable carbetocin given over 1 minute. You have to give it slowly because it can cause a little hypotension, and IV because the cesarean section women have an IV line. For vaginal birth, you can give the same dose either intramuscular or intravenous, and after the delivery of the infant, after you can give it with anterior shoulder, but best thing is to wait after the delivery of the infant. The study which popularized the use of carbetocin is Champion study by WHO. And there is nearly 30,000 women studied with 100 microgram carbetocin on one arm and oxytocin 10 international unit on the other arm, given intramuscularly. Now, one of the issues is the real world studies are needed to confirm the results of RCT, this particular RCT, because it was double-blind randomized control study. Both the drugs were kept in the refrigerator. If they were kept outside oxytocin, as what normally happens, then this figure might have been much higher. Now, you might be surprised that the incidence of postpartum hemorrhage is 14.5%, much higher than expected. Why is that? So despite the fact, one reason might be they use measuring drapes to measure the blood loss. But the most important thing when you sub-analyze the data, that if you look at the horizontal line, this is at 100 milliliter increments of blood loss. And only 26% of women had received the treatment uterotonic drug at that time. And when they bled, and when it comes to 1,000 ml blood loss, 30% of women did not receive a treatment uterotonic. So they had the carbetocin and oxytocin. When they bled, they were not given the treatment appropriately. So there's a delay in early detection and treatment, not in the prophylactic part, but early and delay. That's why the blood loss is much higher. Now, it is indicated to prevent PPH, so it's approved for prevention of uterine hemorrhage, but we have to be careful that it not be used for induction or labor augmentation, because that can cause fetal hypoxia because it produces regular contractions. So you have to avoid using before the birth of the baby. Now, there have been a network meta-analysis done by Eunice Gallos, and this shows very clearly. So network meta-analysis is if A can be compared to B and A can be compared to C, you can compare B versus C. And of course, carbetocin has been compared with many drugs, with symptometrine, with misoprostol, with oxytocin. There have been 30,000 cases over 10 studies which has compared carbetocin with oxytocin directly, which includes Champion study, but there are 1,000 cases with ergometrine or symptometrine study, 5,000 cases with misoprostol, and so on. The effect is actually, when you look at prevention of postpartum hemorrhage of more than 500 and 1,000 mils, there are 3 drugs which are more effective than oxytocin. Either a combination of syntocinon and ergometrine, which is symptometrine, carbetocin, or misoprostol and syntocinon. So if you use syntocinon alone, it's not effective. But if you combine it ergometrine or misoprostol, that's effective. So in other words, 10.5% of women given oxytocin will experience PPH over 500 ml. But if you give it in combination with ergometrine, only 7%, and with misoprostol, only 7%, and it's equivalent to carbetocin, 7%. So it's an effective drug. So the WHO has revised its recommendation that oxytocin is the first choice because of the price of the drug, and carbetocin is the second drug. And this is the recommendation, 100 micrograms IM IV for prevention of PPH, so that where the cost is comparable to other effective uterotonics. So that is the recommendation, and the companies are working hard to bring the cost down. And it is now in the WHO essential medicine list, so that it can be purchased in different hospitals. This is an international consensus statement from the anesthetists, who also prefer to have carbetocin as their, because it's a long analog of the oxytocin, similar action of oxytocin, increased duration, avoids giving repeated injections of oxytocin or oxytocin infusion. So this is the consensus of the anesthetists. We move on to tranexamic acid, which I had the privilege of chairing the steering committee, which we studied 20,000 women who had bleeding. And the idea is actually the tranexamic acid blocks the sites where the plasmin goes and breaks the fibrin. So if already there are clots in the uterine vessels, it won't be broken down if you give tranexamic acid. It doesn't promote clotting, but it prevents fibrinolysis. So that is the key action of tranexamic acid. So we look at the deaths. There is a 30% reduction in death, as you could see here, and it is significant. So maternal deaths following postpartum hemorrhage were due to a number of reasons, like pulmonary embolism, sepsis, eclampsia, but the maximal deaths was postpartum hemorrhage. And you can see, compared to placebo, tranexamic acid reduces the number of deaths. And it was not only deaths due to atonic hemorrhage, but also due to trauma, like in cesarean section. So if it is, give it before 3 hours, because if you give it after 3 hours, it's not effective. So you can see that if whether it is a vaginal delivery or cesarean section, it is quite effective. And also because vaginal delivery, they can bleed from the TAS, or cesarean section from the operation site. So tranexamic acid is effective for traumatic PPH as well as for uterine atony. And the maximal effect was for uterine atony, as you could see here. So death was reduced by tranexamic acid, but be given before 3 hours for maximal benefit. And it should be for vaginal delivery or cesarean section, or atonic or trauma, you can give this drug. In terms of thromboembolic events, we have looked at the arterial and the venous side, and you can look at the venous side and the arterial side, and there's no difference between the tranexamic acid and placebo. In other words, it doesn't increase thromboembolism in the arterial or venous side. Now, systemic complications, again, it is almost identical, whether it's renal, cardiac, respiratory. So systemic complications which happened are due to the bleeding and not due to the drug, because it is equivalent in the placebo group. Now, this is an important slide about surgical intervention in the study. As you could see, they had manual removal of placenta, intrauterine tamponade, brace sutures, arterial ligation, and a proportion of them need laparotomy, and they needed care in a critical care situation, but that was not available. So compared to tranexamic acid, the placebo arm had more cases of laparotomy because they were bleeding more, and many of them needed critical care, but ICU was not available post laparotomy. And that is one of the reasons the placebo arm ended up in maternal deaths. If you would have had primary endpoint as admission to critical care unit, then we would have found out that's the case. So in other words, you had to really have a reduction by, this is in CRASH 2 study, this is for accident victims, this is for PPH, you had to give it before 3 hours. So that is recommended by the WHO because it reduces laparotomy by 35% and death, it is given 3 hours. But the most important thing is you can give it prophylactically as well. This is a study from France, which shows less blood loss if you give it in vaginal delivery, and by cesarean section, again, it reduces blood loss if you give it as prophylaxis. So there's a large study which is taking place based on what we found in the first study, that we are doing Woman 2 trial, which is to give tranexamic acid prophylactically in anemic women. So this will also show whether we can reduce maternal deaths and morbidity. There's been some study done in Sri Lanka using oral tranexamic acid. It takes a little bit of time, But IEM, if you can't give it intravenously, you can give it intramuscularly, 5 milliliter on each thigh, outer thigh, and that is effective within 10 to 15 minutes. Now, there was a consensus opinion meeting at the FIGO in Rio, and there are a lot of people involved. And essentially what they said was that rather than waiting for whether bleeding will stop with oxytocin, give tranexamic acid at the same time. So both has to be given at the same time. Why? Because you have to detect it early, because in many practical reality situations, the treatment is given late. So better if you give it early, then you can cut down the admission to coronary care unit and maternal deaths. And tranexamic acid as well, if you give it immediately, then 70% effective in survival. But every 15 minutes delay, there's a 10% decrease in survival, and it cuts at 3 hours at this point. After that, there's no benefit. So whether you are giving carbetocin or tranexamic acid, you have to give it early. And there's a large study which is taking place called the E-Motive study by Kumarasamy and Anis Gallos, indicating that you give everything at the same time, which you're going to hear as the next lecture. And I'm sure you will learn more from that lecture. And I would like to conclude saying there is indirect evidence that carbetocin and tranexamic acid would reduce admission to critical care unit. And prevention is by carbetocin and treatment is by tranexamic acid. But you can combine these as well for prevention. And prostaglandin, like misoprostol, might be effective in early treatment and should reduce admission to critical care unit. So future research will have critical care unit, but most importantly, more critical care units are needed in low and middle income countries to establish and reduce avoidable maternal deaths. Thank you very much indeed.
Fantastic talk by Sir Arul Kumaram. And I think we are going to have the discussion and questions after the talk. Would anyone like to ask a question? I think that's a fabulous, and PPH is very important part of obstetric management of PPH, and that really would impact the reduction in maternal mortality in the world. Thank you, Sir Arul Kumaram, for a fantastic talk.
Thank you very much. Thank you.
Thank you for giving a precious time for our conference. Thank you, sir.
Thank you.
Good morning, everybody. Now we are moving ahead with the next lecture. I would like to invite Dr. Poonam Verma Shivkumar. She is a professor and head OBGYN, Vardha. She is having advanced training in SHRH from Uppsala University, Sweden. She is having advanced training in obstetric ICU and ICU Foundation, Columbia. She is having clinical skills trainers training for EMOC, CMC, Velo. She is a core member of PPH working group, FIGO, President's Walks, Principal. And she is a recipient of awards as Doctor's Award for Management of Anemia, Best Human Service in CAT Pulgaon, and Best Doctor Award by Lions Club. Madam, now stage is yours.
Thank you. So a very good morning to all, rather afternoon to everybody. Thank you, chairpersons, my senior colleagues and dear friends. Today, what I am going to talk to you about the PPH bundle, actually it is going from roots to roof. And I bring greetings from Mahatma Gandhi Institute of Medical Sciences, where I'm working as professor and head. And we have been really working for the community, and we still follow the ethics of OBGYN. When I talk about PPH bundle, this is the man who has actually to be given the whole credit. Dr. Thomas Burke came to MGIMS with his one UBT kit. And I was just wondering, what is this UBT kit? India has been doing so much. We've been using condoms since long time. But to my surprise, there was one patient who was extremely serious, post-cesarean section, was bleeding profusely. And when I reached to operation theater, I was told that there's no pulse, no blood pressure. And then at that desperate moment, all I remembered was this particular UBT kit. I called it, I inflated it out of desperation, 900 ml, and precisely in 20 minutes, the woman was back. And after 20 days, we discharged her with a healthy baby. So with that note, I realized that there's something different in this particular UBT. So with that UBT, we started, and how did we go to PPH bundle? In a minute, I'm going to tell you that. So today, my objectives are to tell you what are the clinical components of PPH bundle, non-clinical components of PPH bundle, what is the role of UBT and NASG, and then what are the quality components which have to be used to make this non-clinical bundle forceful. We all know this is the definition, and probably this is the definition which was accepted by MGH, where from Dr. Berg belonged to, and we use this definition for our project. We all also know that these are the 4 T's and we need to tackle them. Now, why this bundle is there and why are they needed? See, these bundles are basically comprehensive approach, and all evidences put together when we use the different strategy so as to save the mothers and not let them die. Probably that is the bundle when we talk in terms of PPH. Bundle is nothing new. It's all there. We are all doing it sporadically. But when you bring it together and do it together, probably the things become better. And if I want to tell you what the bundle is and why this bundle is to be used, only these 2 slides are important. Woman is at home. She should have something to get integrated to the health facilities. So there's vertical integration. When she reaches the health facility, she should have facility readiness. There should be PPH kit. There should be emergency trolleys, and people should not be running around for that. So preparing the facility, then having an emergency response team which knows what work they have to do, and they know that there is something called team division. And that team knows that what I am supposed to do, what the other is supposed to do, so there's no chaos. Then we come on to the clinical management, which is not only surgical, there's a lot to do, medical, mechanical, and then go for the surgical management. Then in case we are in the lower facility, we know how to transfer the patient, so going for the referral protocols. Then, of course, in the emergency section, there should be everything ready. So a good infrastructure where you have a triaging and you also have an obstetric HDU ICU. And then, of course, documenting the data, doing repeated quality improvements, and finally doing advocacy. So everything comes in policy and everything is made available. For this, we cannot go alone. Community level, district level, state level, and national level. Until we do this whole thing, we will not be able to implement the PPH bundle. So PPH bundle comes with the clinical and non-clinical component. And believe me, this is the only card which is there, which talks everything about the PPH bundle. And I would share it with you. Now, when I talk about this PPH bundle, something very interesting is that the whole training package has already been made by MGIMS, and there are 10 other facilities, right from the Marathwada area of Maharashtra to Vidarbha and to MP, who have created this whole bundle. What is clinical bundle? So in the clinical bundle, there's something called AMTSL. Now, where oxytocin was there, it is being replaced by carbetocin, but yet we are using oxytocin. And then there is something called call for help, which is one of the important components. And then comes the first response. After that is the refractory response. So when we talk about active management of 3rd stage of labor, we all know it's IM oxytocin, if not available, misoprostol, controlled contraction, and uterine massage. There have been a lot of hue and cries about, giving uterine massage. Should we do controlled contraction at the lower setting? But believe me, these things, if trained well, So the most important component what comes is pre-training. So if you train well, even to the non-medical person, probably you can save the women by active management of third stage of labor. Second is call for help, and this is something extremely important. We will laugh that by call for help, there are a number of people there in the what, but believe me, lower settings, you do not have these many people. And a help from the relatives also helps in the lower setting. So call for help, immediate triaging, and doing A, B, C, D, E. Previously, we were saying only airways, breathing and circulation. But now we are also talking about D and E, which is disability and exposure. And there's a huge things to do, especially in the survival and later not having neurological deficits in the women. So we will do that. We'll do rapid initial assessment, a good history and vitals, and do resuscitation by emergency response team. And then comes the first response. The first response has got 4 things. The first is that feel the uterus if it is contracted or not. If not, please do the massage and express out the clots. The concept of putting the whole hand inside and taking out the clots is gone now, because it's well proved that if we do that, later on we are going to have myometritis and endometritis, and this women may have infertility. IV fluid, there's a concept of infusing the women with good amount of fluid, 1 liter, 2 liter, 3 liter, that's out. Give 300 bolus, another 300 bolus, and then what you have to do is ensure that you give blood transfusion earlier, because infusing too much of fluid in a woman who has had PPH will either lead to pulmonary edema or it will cause dilutional coagulopathy, and you will actually be precipitating her death. The third is giving uterotonic medications, where we all know that oxytocin is the recommended one and carbetocin is coming in a big way. There's a little restricted use of methyl ergometrin and PGF2 alpha. The reason being that we must know that the women does not have heart disease. Tranexamic acid, very nicely said by sir, that it has to be given within 2 hours, 1 gram IV, and another dose to be repeated after 30 minutes. So once we have done the first response, there comes the first response supportive measures. And in this, you have to empty the bladder, you have to check for the tears, and if they are there, you have to repair, and then you have to empty the uterus. Now, again, the question is that here, if the uterus is not empty, maybe there is some kind of retained products, and there you may need some surgical intervention later on. Coming to the refractory response, now these are compression manuals. We all know there's something called bimanual compression, there's something called aortic compression, and there's something called using uterine balloon tamponade and NASG. Now, in one word, I would like to tell you that when we do bimanual and aortic compression, there's a specific way to do it. Half-heartedly doing it like this does not work. One has to stand on the toes and hand has to be straight. Your elbow has to be straight to give enough pressure. And there have been several studies to notice how much pressure has been inserted if you do it with the folded elbows and if you do it with the straight elbows. These two are the saviors, and so we talk a lot about them in PPH bundle, because uterine balloon tamponade is a very simple thing. If you train, even the nurse and A&M can do it, and we have done it in MGIMS, and we have seen that when we vertically integrated all the PHCs, in the PHCs where we had trained the A&M sent the patient who could come to the medical college and be safe. So UBT is one of the technique which is absolutely being used in refractory PPH, and NASG, which is anti-shock garment, is also being used, and we are shifting the patient right from labor room to OT also with NASG, and because the blood is pushed to the vitals, there is very much chance that you can save this woman and have much better survival. There are also certain supportive measures of refractory part of it, which is blood transfusion. transfer to the high care level with all referral protocols, and then of course, all the surgical interventions which are needed. So this is what is the clinical bundle, and in which there are some additional clinical practices also there. This is something I would like to talk to you. This is PPH checklist, which is being used by all of us who are using this bundle, and we do not miss on anything. And that is why we are able to save the patient. Whenever a PPH emergency comes, it's really a chaos. And many a times we forget to give tranexamic acid, or we forget to give certain things. But if you use this particular checklist, you will not be able to forget anything, and you will save your women. We come on to the non-clinical components of the bundle. And this is one chart which talks about it, in which the first one, when we talk, is respectful maternity care. And at nowhere we should leave this, whether it is an emergency or it is an elective procedure. This I need not define, I think all of us know, but International Childbirth Initiative has come up. The White Ribbon Alliance has talked too much about it. And if we see, these are the principles of respectful maternity care. In PPH, we specifically want to mention it because you have to call the relatives and tell them what you are doing, because your woman is not in a state to listen to you. So that's why we talk about respectful maternity care. Teamwork and communication is something which I would just very quickly tell you that this football team, they have the best teamwork. And if you talk about the good teamwork, we're talking about there's rapid response, there is right diagnosis, clinical skills, and no delays and no errors when you talk in terms of team division. And here I would like to tell you that there are certain things this team has to follow. One is division, in which we divide it like this. And I still remember from PGI, Dr. Neelam had come and we were taking examination, and my 2 cases, eclampsia and PPH, came, and she was quite surprised that how did we do it without any noise. And this has been over the years effort, which has brought us to a level that we've been dividing our team into these groups. And every team member knows what they have to do, so there's no hustle bustle in the department. Now, these are 4 things which we talk when we talk in terms of team. One is debriefing. After the whole scenario is over, everyone has to stand together and try and find out what was good and what was bad. So what was good, you carry it forward. What was bad, you improve. So that's called debriefing, and there's a tool by which you do debriefing. S-bar, everybody knows, you talk about situation, you talk about the background and so on and so forth. Closed loop communication is that when I am giving oxytocin, I will speak loudly. I have given 10 units oxytocin, I am. So the in charge who's doing the scenario, or who's doing in real patient also, who's looking after the patient, knows that what all has been given. So closed loop communication is the communication between the people who are dealing with the emergency. Huddles are that you have a planned strategy and you do that whole scenario as per your planned strategy. And board rounds are when emergency team comes and takes rounds repeatedly and ensures that 24 hours are given totally to that woman to save life. So this is debriefing. These are S-bar, close communication, and huddles. Now we come to the communication, which is very, very important, because communication is not only between you, it is between you to the referral facility, in the referral facility to triage, to blood bank, to operation theater, and so on. So you should have a planned way of communication. And then leadership. This is something very important. If had Dr. Bug not come here, probably we were all doing something, but we were not putting it as the bundle. And since he came, there was something to notice that India is doing so well. We have our society, Foxy. Foxy is doing so well. I'm yet surprised that why there are 10 guidelines being made in spite of our repeated discussion with government, that government makes one guideline, Foxy makes one guideline, ICMR makes one guideline. Why is that? Because Foxy is one society which represents probably the whole India. and why that society not makes the rule like what ACOG and BJOG are doing. Let's have one single FOXY rule for everybody universally. So this is about the leadership. And then this is something very important, non-clinical component, where you talk in terms of facility readiness, where you have PPH kit ready, you have emergency response team ready, you have all the emergency equipments ready. So your facility has to be completely ready with all these things: drugs, equipment, services, referral services, infrastructure, ERT, etc. So if you have this ready team, probably you will do better. And we'll, in a minute, I'll tell you how we have changed the scenarios of PHCs, which were absolutely non-functional, and we made them functional. And after that, for 1 year, 3 months, we had 0 PPH death after using the bundle in the whole district of Varda. Until COVID came, and then we had 3 deaths. One was at home and 2 were because the doctors were not available. These are the barriers which are there when you talk in terms of effective facility readiness, because there's lack of staff, the infrastructure is not so good, the skills are not so good, but with the training, probably things can be changed. So these are some tools I'm talking about, the checklists, which have been developed by MGIMS, MGH, and the 10 other medical colleges. So these are the facility readiness. And then, of course, the network integration, that one facility should be integrated to the other. And this comes for the private facilities also. You should have communication with a facility which is a higher facility, where in case of any emergency, you can shift the patient. And if you have that kind of integration, probably your patients will not suffer. One team, bi-directional communication, and improved referral. This is something which is going to change the scenario. And when we talk about network integration, we talk about team building, training, talking, and transferring, tracking, and thanking. Now, these are some checklists which, if you all would be interested, we would share with you. So these are checklists which improve the quality of emergency care. And when we talk about quality, we are talking about reflect back and move forward and plan that so that you can have a better scenario and never a death of the PPH case. So these are various process of improvement. I think we all know this. I need not discuss in details that once you identify the problem, you plan to change, try it, check if it works, and then adopt and adapt. Data is very important because it is going to tell you what you are going to do next. So data, once you have, you know where are your pitfalls, and you're going to look into those pitfalls. So process measures, outcome measures, and then balance measure. These are the things which we look in data and use the data to improve our scenario. Now, what I am going to talk was the global experience, which because this bundle was used in lower settings as well as higher settings, like in MGH hospitals, and the results have been amazing. This is Kali's picture, where in Kali, how did they go from red coat strategy to transfusion policy, UBT, NASD, checklist, and this. And I would like to tell you that Kali is one place where obstetric ICU is there with 100 beds, and there are 0 maternal PPH deaths. There are PPH, but there's no death at all. This was our 10 medical colleges who have done this particular study. So this is the team of 10 medical colleges. And we have been training everywhere. We have done several follow-up meetings, workshop. We created our own WhatsApp groups. And then we have some very interesting stories about the women where we have saved our own people. And this, we did system integration, we did facility readiness, we did teamwork and communication, we did quality improvement. Many of my colleagues are here today. And then we did advocacy and branding, where we did walkathon for saving PPH women in Nagpur. So there have been several success stories, there have been several obstacles, but we've been able to overcome it. Now this particular PPH project has gone to UP through government and FOXY as Safe Motherhood Committee. Dr. Preeti, under the leadership of Dr. Alpesh Gandhi and Dr. Shanta Kumari, is doing such an amazing job in UP district, Bihar and Chhattisgarh. And I would also like to share with you that this is now going to go to Orissa, Assam and Chhattisgarh again. So these are the views and glimpses of PPH bundle, which has come up in a very big way. I request all of you, whether public or private, once you use this bundle, you will see the amazing difference and you would be able to save your women. Thank you so much for your patience here.
Madam, it was really a wonderful presentation. And Madam, the way you are talking about PPH bundle, it looks so promising in zero PPH maternal mortality. So is there any scientific published study in the index journal that conveys to authority to understand why in need of ever is to implement this? Because see, in an institution there are only 30-40% deliveries. The rest of the 60% what you are talking about is the training and the bundle communication, everything. So any study published and enforcing government?
I would just like to tell you that in the government policy it has gone, because we presented our particular study and it was in Government of India Innovation Portal, and it has gone in the government guidelines, and that is how UBT and NASG is coming. NASG is yet to come in government this thing. Dr. Thomas Burke is publishing the whole scenario in the journal, which is just waiting. We are just getting the proof. So we are going to get very soon those articles. The small articles have been published already. If you go into the international this thing and put PPH bundle, you will get several literature articles which are there by the name of Dr. Bangal, Dr. Anuja, me, Dr. Shama, many of us.
Okay.
Yeah.
Thank you so
it's
much.
already there.
Madam,
Thank you, madam.
Madam, one question for you, ma'am. Hello, ma'am.
Yes.
One question for you. You have mentioned that 300 ml of crystalloids is enough. We can stop and again we can reload the crystalloids.
Yes.
But by the time in the labor room, to get the blood and blood products, it will take minimum 1.5 hours to 2 hours.
See, I'm not saying that you give only 300. You start with 300 bolus. You give 300 bolus again by the time your blood comes. Because if you give 1 liter, 2 liter, 3 liter, believe me, she will die of coagulation.
I know 3 liter is too much.
Coagulopathy. So please do not infuse. Many times the women dies not because of PPH consequences, but she dies. Why? Because of pulmonary edema, because you've infused her so much, because of TRALI, transfusion related issues, and of course, dilution.
Thanks a lot.
Thank you, madam. Thank you so much. Thank you, madam, for coming to Ahmedabad and giving your precious time. Next speaker is none other than our teacher, senior teacher, my mentor, Dr. Ajit Rawal, sir. He is one of the senior most endoscopic surgeon and gynecologist, and he's the most, welcome gynecologist. Remember when there is an emergency and somebody feels that we can't do anything, what she has said about UPH bundle, and when surgical intervention is required, I think we have learned everything from sir, and I think sir will enlighten us when everything has been tried and when surgical intervention is required, how systematically one can address PPH. So sir, stage is yours.
And it's under control. I'm glad you had your
Hello.
vaccine.
Thank you, Pagnish. Thank you to team of Alpesh Bhai and to invite me for a lecture on this topic, lower segment bleeding. This is a very interesting subject to talk about. Not a single textbook of obstetrics has mentioned about the lower segment is problem. I'd like to tell you some of my experiences, what I've seen and what I've experienced and what we have managed the problem of lower segment PH. Before I start, I'll tell you, within the last 4 months, I managed about 2 patients of lower segment hemorrhage. One patient is already in the Sterling Hospital. She is severe section in Ahmedabad. She was patient from ISA.
So you come to me for.
And she was discharged as well on the 3rd day of the cesarean section. And then she went there. After 5th day, she started getting pain in lower abdomen, difficulty in passing urine, and temperature. On examination, they found some swelling in the lower segment, about 4 to 7 centimeter. Ultrasound done and the as other further investigation of CT scan, they found a hematoma. The patient was brought to me in the emergency room, and we'll examine her. We found that a hematoma was there with communicating with the lower segment. It was stabilized with antibiotics, and we are not to touch the case. We are giving a conservative treatment. A second, which is very interesting case of secondary hemorrhage, was patient was brought on 5th day of the cesarean section from Gandhinagar with the bleeding by a gynecologist, putting a PEC and given a transfusion also. And I have to go and see the patient, and we found that patient had a lower segment hemorrhage. In this case, we would find out the history why the patient is a hemorrhage. She had hemorrhage because of prolonged labor. And by the delivering the baby, they had a tear on the lower segment on the right side of the patient. They sutured the lower segment and the tear. The patient was fine and discharged, went home. On the 5th day, she had a bleeding. I have to explore the patient. And what I find, there's no bleeding internally. I opened the lower segment and I found a tear which is sutured, or maybe not be proper, sutured properly, but there is a collection of blood. There's hematoma. So I have to ligate the uterine artery with the open technique of ligating the uterine vessel, suture the lower segment with the fine suture, because this is a friable segment. So 20 vicarial, and technique that I use of suturing is the Smith-John technique. I'll tell you what it is exactly. They call it near suturing of the segment, friable segment. So that's about some cases that I tell you, and tell you further when I discuss the topic of lower segment. Now, VPH we know, 100 cc, 500 cc of blood. But the definition which I like to mention is when you find a amount of blood loss which is more than expected in vaginal birth or cesarean section is a PPH, and start managing. Use the bundle that madam has already described. That's the PPH. Don't wait. Next. Now, diagnosis of lower segment hemorrhage is very, very important. Suppose the patient had a normal birth, she bleeds. When you find a uterus is well contracted and retracted, and there's no cervical trauma, it's probably a trauma or something wrong with the lower segment. But the situation is different when you're dealing with a cesarean section, because you're right on the lower segment. You see the bleeding, you see the tear, the placenta there. So it's very important. But the important thing that the patient comes with the bleeding after cesarean section, where the diagnosis is very important, what has happened to the lower segment. Ultrasound may definitely help you. Next. So definition of PPH, the things which include is the bleeding from lower segment after birth, even preterm or post full term, during cesarean section or after the cesarean section. Before birth, placenta is lower segment. Before birth, placenta accreta, percreta. They might bleed before birth also. And rupture of the lower segment, previous cesarean. Patient with prolonged obstetrical labor. And sometime, and rarely, the lower segment after subtotal hysterectomy. I tell you some patients also, the lower bleeds there from the lower segment after the subtotal hysterectomy. Next. So it's the golden hours. Madam has already told you, early diagnosis, early management. Next. So lower segment bleeding will be sudden. Patient may collapse. Cases of placenta previa accreta, previous cesarean, or a lower segment tear with corporexis, the massive hemorrhage. Previous slide, beta. Then moderate bleeding, trickling slowly, and sometimes no bleeding, but there's a collection of the blood into the peritoneal cavity or sometimes broad ligament hematoma. So the presentation, next slide. Next, beta. Intraperitoneal, vaginal intraperitoneal, or both, or hematoma. Next slide. So to understand the lower segment, the pregnant uterus become anatomically and functionally different. The fundus body, lower segment, and the cervix. The three important structures they have to consider in management of our patients. Next. Formation. The two people you must remember. ICCOB, 1906. He described the lower segment from the isthmus, anatomical internal os and the histological internal os. But these are luminal diagnoses. Externally, we're not able to appreciate unless it is a loosely attached peritoneum. Next. Barbaros, 1907. He says it's the lower part of the body of the uterus. But we understand what is the lower segment now is the isthmus and the lower part of the body of the uterus makes our lower segment. Next. So this is the beautiful picture. This is the which forms the lower segment. Next slide. The lower segment is about 10 centimeter usually. Lower attached to the peritoneum and fixed at the upper part of the lower segment. Lower segment is the fibers, circular fibers most of the time. And in labor is a receptive relaxation. Because form a tunnel, big tunnel from fundus body, the lower segment in the birth canal. Next slide. Now, certain important points that we never thought of in lower segment management. This is very important. And I request all our colleagues to make a simple note of a lower segment that they operate every day. What happens to the lower segment during cesarean section? And if you, in the end of the year, if you're able to find out several important things in management of lower segment. And what are the points now? Length of the lower segment. What about the preterm, postterm, patient in labor, patient in obstetrical labor? What is the length of the lower segment? Broadness. Upper part is broad, lower part is narrower. What happens with different types of, with different terms of pregnancy? Thickness of the lower segment. Many times we are cutting until you reach thick lower segment. Particularly with the elderly patient, adenopathic patients, IVF patients, you find very thick lower segment. Vascularity is very important. What are the different viscers in front of the lower segment? When you cut, you start bleeding. Many times you just clean cut lower segment, nothing happens. Relation of the vascular bundle around the lower segment. Next. Relation of the bladder and the bladder peritoneum, particularly when you're dealing with the previous cesareans or dealing with the previous surgeries on the lower segment. What about the bladder? I've seen incidences of dealing with the baby through the bladder, anterior wall, posterior wall, and the lower segment. So what is the relation of the bladder peritoneum and the bladder? How it heals and how it behaves in the especially previous cesarean. And involution is very important. I am telling you, I had a case of a patient with the priming, have a cesarean section for oligohydramnion. And in the evening, they found the patient is collapsing. They find tachycardia, follow blood pressure, and they found intraperitoneal hemorrhage. And they called me to see a patient, and we decided to open her up. I opened her up, find intraperitoneal hemorrhage. No spurting vessels. You know what it is? My tip of the artery forceps going under the suture line. My tip of the artery forceps going under the suture line. The single layer closer. That means the involution is different in every patient. The lower segment must have involuted within 6 to 8 hours time, and slowly patient has started oozing from the suture lower segment. So involution, how it occurs is very important in management or understanding of the lower segments. So a recent literature search on this topic confirms that the nature and origin of these differences have never been investigated. So we now try to investigate and understand the different situation of lower segments. Next. Another important point of lower segment is the retraction, contraction, and retractions. This is wonderful in the upper part. Lower part is not so good, particularly when you're dealing with the previous scar and patient with previous scar and the placenta. So now we understand the importance of lower segment and the lower segment PPH, atonic and traumatic. Next slide. So one of the very important observation that we had in the patient with patient with placenta previa, not all the patients need a hysterectomy. Why? Because there is quantitative and qualitative difference in the musculature of the lower segment. We have to understand and be able to control the hemorrhage in the patient with placenta previa. Next. So we all clinicians now understands the importance. The only important and difficult situation is this. We face in regards to the subject defining clinically or imaging process where it is and how it functions at the lower segment. Next slide. So this is the picture of a lower segment. You know, this is the firm attachment. This firm attachment may be higher up because it is a prolonged labor. Firm attachment may be lower down also. So you have to understand the length of the lower segment. Next. This is the vascularity. Next slide. Placenta previa, accreta, previous cesarean. Dreadful condition. Patient is going to have massive bleeding and you have to have wonderful protocol and then the management in this type of cases. Next slide. This is placenta lower segment. Next. This is very important. This is very important, I tell you. I have to go and see a patient of normal birth. Patient was an induction of labor. She had normal delivery and she is slow trickling of blood continuously. And they started the blood, they were given oxytocin, but bleeding doesn't stop. Ultimately, we decided we'll operate her. And this is what a beautiful picture of that I've taken that time. Patient has a submucosal trauma here. You know, the muscular layer, it is small tear. It bleeds continuously. It stops sometime, again it bleeds. This is called as a submucosal trauma. With this reference, I tell you one of the patients I had so many years back. She had again a patient primary to deliver with induction of labor. She was discharged in the home. After 3-4 days, again she came to the hospital to the gynecologist with a massive hemorrhage. They given the oxytocin, the blood transfusion. She again, all right, went home. Again after 2 days, she came back. Then the patient was referred to me. Then I thought, what is wrong with this patient? Why she's bleeding every 3rd day, 4th day like this? So I did anesthesia, did examination, do hysteroscopy, examined the upper segment, lower segment. I think we didn't find much. I put a Foley's catheter balloon in the lower segment. But it stopped for 3 hours, 4 hours. Again it started. And I decided to operate. That she needed surgery now. And I did a internal ligation. Bleeding did not stop. Ultimately, she ended up in a hysterectomy, nearly primary patients. And we send this uterus for examination, we find a longitudinal submucosal trauma. That was the cause of bleeding like this. Next slide. Lower segment ectopic, scar ectopic, that we should not forget. Another part of hemorrhage in the lower segment. Next. So this hematoma, lower cesarean section, trauma, and the patient get a hematoma also. Next. And this is the specimen. This is a picture of hysterectomy specimen where you do a subtotal hysterectomy for atonic hemorrhage. And to a surprise, this segment bleeds. I tell you 3 of the patients that I had already, which had a hysterectomy done. One was by my colleague and 2 patients myself had done, and she had a secondary hemorrhage found in the evening from the lower segment. I tell you what, that history also. Next slide. So now, what should be included in the lower segment? Atony, you understand the qualitative and quantitative differences in the lower segment. Important is the trauma. Birth trauma, rupture of the lower segment. Before birth, during birth, some because of trauma that I already told you. Previous cesarean scar, and if you get a trial with the previous cesarean, might give rupture of the lower segment, or if patient is IU death, previous cesarean, you induce the labor with mesopause, sometimes the lower segment gives way and they bleed before birth also. Next. Then during cesarean section, the injury to the lower segment, the trauma to the angles, vascular bundle on the right or left side by delivering patients, previous cesarean scar, which might give you by delivering the baby also. And very important, the malpresentation if you deliver might give you trauma to the cervix. But one important thing I tell you about the application of the Foss's blade. I think I had a patient to handle the case was, they put a blade behind the fetal head, and that blade introduction is given the trauma to the posterior surface of the lower segment. And that patient is bleeding from the posterior wall of the lower segment. Then these are another important criteria. The lower segment of the unicornate uterus may move abnormally and give you a atonic hemorrhage or hemorrhage from the lower segment. Adult lower segment, previous surgeries, that also give you trouble. Fibroid of the lower segment. When you're delivering with the patients, you deliver the fibroid, but that lower segment might bleed. Next. Then the, as usual, problems with the lower segment. Inadequate suturing, angle, misdoing cesarean section, and different situation in the management of cesarean sections. But one important thing I tell you is the anterior edge of the lower segment suture to the posterior wall. I had two patients I tell you, one of the incidents was one of my senior was operating in my unit. And after the surgery is over, she asked me to see how I have done the surgery. Then I found something wrong with her. And she sutured the anterior edge to the posterior wall. And second case I tell you was I was called to go to the Gandhinagar for one patient of slow continuous postpartum hemorrhage after cesarean section. I'd open her up and find the same situation. There are some rare issues in our practice, but we must remember these are the cases. Then previous one, madam. The lower segment edge bleeding after the obstetric subtotal hysterectomy. It was the day of Raksha Bandhan. I was called to see a patient to a gynecologist. He was operated, IVF pregnancy, adenomatic uterus, twin pregnancy, did a cesarean section. Bleeding was not stopped. We tried the different methods and drugs. Ultimately, we decided the patient is elderly and we removed the uterus. I did a subtotal hysterectomy. She was the patient present when I operated the patient. In the evening, and we found the patient is collapsing, tachycardia, follow blood pressure. She was not comfortable. And next day when we operated, we found intraperitoneal hemorrhage and lower segment. Though it was completely sutured, patient was bleeding from the lower segment, moving from the lower segment. Corporexis, worst condition. And last I'm telling you, the posterior wall serosal surface. Posterior wall serosal surface. Particularly patients with endometriosis or pelvic inflammation, if you deliver the uterus, you see behind, the surface might separate it, and the amount of vascularity behind, that bleeds. And that is sometimes very difficult to control the hemorrhage. Next slide. Then the management modalities, something wrong, we have to go through, open her up, and decide the line of management. But the most important thing is the management is to talk to the patient related to make and understand the seriousness of the condition. Next. These are the different ways of suturing that we know. They're not going to go in detail or something. Next. The ligation of the vessels, therapeutic or prophylactic ligation of the uterine artery. And different next modality is this much. Different ways of hypogastric ligation. Sometimes you might do jaw sutures at the lower segment, depending upon what type of condition that you see. Next. This is the prophylactic opening of the lower segment. If you go with the finger, sometimes you extend lower down and you damage the vessels, bundle vessels on the lateral angle and lead to a bleeding. Next. This is the slide, important slide I showed you. When you suture the lower segment, still it bleeds. Then you take a metal sutures like this. Next. And to tie them. Next slide. This is very important. This is very important. The upper surface of the undersurface of the upper edge. I tell you a case of postpartum hemorrhage that I called to see a patient and he's bleeding slowly, continuously. And opening the abdomen and the lower segment, you find this segment was bleeding. Only this packet. Next, what to do with this segment? See, this segment is oozing continuously. Lower segment. 2 minutes. 2 minutes. 5 minutes. So this is the age. This is, I think, very interesting to listen to all of the things. So take little 2 minutes more. Okay. Then this is the upper edge of the lower segment, which is oozing continuously. What I did, next slide. Taking the suture from outside inside and coming down inside outside. Next slide. And it is tied here. It's a very simple technique. Everybody should understand this technique because you might come across this type of oozing in your day-to-day practice of cesarean section. Take a simple stitch this fashion. Where the placenta is attached lower down, and that area might bleed. Next slide. Then the ligation of the uterine vessels. Dr. Kotaral has mentioned about the two techniques when open segment is open and segment is closed. Next slide. I tell you what the technique. This is a technique that I described. When you're doing cesarean section, you find the lower segment tear, trauma to the vessels. Don't struggle. Just ligate the uterine artery. Very simple. Hold with the Babcock, the bunch of vessels, passing lateral to the medial side and come out and just ligate it. Next slide. I'll show you beautiful pictures of that. This is the lower segment. This is the bundle of vessels. My finger is below that. Port ligament. Next. So this is the Babcock fossa holding the bundle of vessels. So needle is passing from here into the cavity. Next slide. See now? My needle is going. The bundle of vessels are here. Outside, inside the cavity. And needle comes out, inside, outside, middle to the vessels. Next. Like this. This is the vessel coming out inside. Next slide. And needle is coming out from inside, outside, inside, inside, outside. And next, ligate it. When the lower segment is open, you ligate the uterine artery. It works as a prophylactic ligation as well as therapeutic ligation in problem of lower segment cesarean section. Next. Next slide. This is the technique which is originally described, old ladies in 1955. Take a whole bundle of vessels from anterior wall to the posterior wall. Next slide. Yes, next. So this is the way. Suppose you suture the lower segment and the patient is bleeding from the angle. Don't wait. Just take a suture like this. Anterior wall, posterior wall, come out from the broad ligament. And you ligate. Next slide. This is the way. Next. So this is the way. Needle is going through here and needle come out here. Next. This needle is coming out here. It's a bundle of vessels. So anterior wall to the posterior wall. Next. And it's just ligated. Next slide, beta. So this is the difference in the two techniques of controlling hemorrhage from the lower segment. Next. This is the ligation of the interiliac artery, particularly when you're dealing with the lower segment tear and the corpus axis. You don't struggle. You go for the interiliac ligation, which completely reduces the amount of flow, unable to find out the tear. I tell you, one of the patients was brought by Dr. Alpesh Bhai. Alpesh, you remember that patient? Lower segment tear in the corpus axis. She brought the patient immediately to the hospital. And we did interiliac ligation and the reconstruction of the lower segment and the tear. Next. This is the technique that I use with the aneurysm needle. They call it Dubé's technique. Next. About hysterectomy. It's fine. Next slide. This is even hysterectomy is very important thing I like to tell you about the vessels in the broad ligament. The vessels they call it vessels of Santorini. That is very important. They bleed around the lower segment and the patient has a secondary hemorrhage or hemorrhage after cesarean section. Next slide. Use of suturing, called Shaw sutures at the lower segment. Next. Use of balloon in lower segment. Next. So to conclude my lecture on the hemorrhage on lower segment, what I tell you is the prevention is always better. Anticipation of situation in the diagnosis, early diagnosis. Bundle they already made and described to management. Ask for help. Perfect counseling of patients, relatives. Take them into confidence. And those surgical modalities, depending upon the type of complication that you come across in the lower segment to control the hemorrhage. Thank you very much.
Thank you very much, sir. It was a wonderful, well elaborated lecture.
Excellent, sir.
Now we are moving forward to the next lecture. I'd like to call up on stage our own Dr. Parul Kotadawala, sir.
Parul is our past AOGS president. He is a SOGO president, past vice president, Foxy, endoscopic surgeon at Nsaids Hospital and VS Hospital. And to his credit, many designations and publication. Sir, stage is yours. You are also always, remembered when there is a problem of PPH and surgical intervention is required. So your input of special note with the advent of cesarean section increasing in the world, I think there will be a cases of placenta accreta, increta, and percreta. And we are going to face this adhesions, placental adhesions, and this will be addressed in a special way and different techniques. He will be interacting with us. So, stage is yours. So, anticipating that this adherent placenta is going to create a problem and how to address them is the presentation. Sir, stage is yours.
Thank you, Pragnesh. Well, I am part of the organizing team, so I do not thank anyone, but I welcome you all to Ahmedabad and make this, I would say, swan song of Alpesh for Foxy presidentship. His last commitment, big commitment, which he is finishing with this nice conference. Well, I will be sharing with you some of my experiences about this very peculiar problem which has come up over last decade or two, placenta accreta. And I was really confused 2 days back when I received the final program that that word was added, the Gordian knot. And in fact, I started asking colleagues and almost nobody knew about it. Well, it's a very interesting story. Time doesn't allow me to dilate upon it, but way back, there was a person, peasant farmer Gordias. He was, when he entered a city of Thuringia, there was a prophecy that whoever enters with his bullock cart will become the next king, and he was made the king. And his bullock cart he tied with a lamppost, and he prophesied that whoever unties this knot will become the king of Asia. And then Alexander, when he came to this place, he tried to untangle the knot, he could not. And then he took up his sword and just cut through the thread. And that is how the Gordian knot has come up. It is to give you an idea that whenever something is not happening, try something different. And that is how any complex situation which comes up is called a Gordian knot. Coming back to placenta accreta, it is a serious business. Average blood loss at delivery is to the tune of 3 to 5 liters. Almost 90% require blood transfusion, 40% require more than 10 units of PCV. Maternal mortality is high, almost 7% in most advanced setups. Maternal death may occur despite optimal planning, transfusion management, and surgical care. Have you ever wondered, friends, the wonder of nature, how a placenta sticks up to the uterus till turn? It detaches quickly at the time of delivery, not before, otherwise APH would occur or IUD would occur, not later on, otherwise PPH would occur. So we need a good endometrium and good decidua for this mechanism to work efficiently. And if we disturb this system anyway, we are likely to deal with placenta accreta. So presence of uterine scar, damage to the myometrium, previous cesarean, with each cesarean the risk increases, previous curettage, MTP, multiple events, uterine surgeries like myomectomy, septum resection, endometrial ablation, radiation, even IVF, endometritis, and post-delivery curettage. All of them increase the incidence of placenta accreta. And with increasing cesarean rates, we are observing this more and more in last couple of decades. As you can see here in this large series, they found that third cesarean
If placenta was in lower segment, 40% were eccrita. Fourth, 61%. And fifth, of course, very hardly we ever reach up to fifth cesarean. But after second cesarean, if placenta is lower segment, please think of eccrita. Please think that it may be adherent. Now, diagnostic modalities are, of course, clinical suspicion with history of previous trauma to the uterus, ultrasound and color Doppler, and placental MRI. I will not go into various details of ultrasound diagnosis, but large placental lakes are very pathognomic. Absence of this hypoechoic zone beyond the placenta and break in the continuity of bladder or bulge in the bladder. These are commonest ultrasound diagnosis. Doppler adds to it by perpendicular blood vessels going to the bladder or large placental lakes with large blood flow. The limitation is, this is what I wanted to highlight, 64% accuracy. That means 1 in 3 placenta eccrita will not be picked up by ultrasound. So even if you have an ultrasound report that placenta is not adherent, please be ready to deal with it if on table. And that is where many of our colleagues find very difficult situation. Even American College has mentioned level 1A recommendation. Although ultrasound evaluation is important, the absence of ultrasound finding does not preclude diagnosis of placenta eccrita. Then MRI. Now, MRI by and large endorses what ultrasound tells us, but we add one more thing. A partially full bladder, and if you perform MRI at around 30 weeks, these are various features of MRI, but this is one point which I want to highlight. Draw a line from the middle of the bladder, perpendicular to the bladder, and if any placenta is below this line, this is S2 segment of placenta, that is a serious condition. Please transfer this patient to a tertiary care. Don't attempt to do it in a small nursing home. If it is in S1 segment, you may deal with it if you have experience enough. If this one message I can pass on, my presentation is adequate. Now, FIGO classification, again, placenta, they call it creta, we call it eccrita. Creta, increta, and percreta. But what now we are thinking of is beyond percreta. So 3A is limited to and including uterine serosa. But if it goes beyond invasion in bladder, it is 3B. Invasion to other pelvic organ, 3C. We are seeing more and more such cases now. And that is why we should not use this classification. Otherwise, it would be just percreta. But 2 percretas may be different, and the dealing with it would be different. Type 1, this is a invasion classification. Type 1, where there is space between bladder and uterus, and you can dissect bladder away. Type 2, there are blood vessels going from uterus to the bladder. You have to ligate all these vessels and then separate the bladder. And type 3 is dense adhesion between bladder and uterus. So type 1, 2, 3 is more important than increta and eccrita. Now, management option when we think of extirpative technique is remove the placenta, which one should be very careful about. Leaving the placenta in situ approach, where either you perform a hysterectomy with placenta intact inside, or conservative, where you excise only the site of placenta. So only part of uterine wall you are removing. And third option is ultra conservative. You leave behind the placenta. If patient is stable, there is no bleeding. And after 2 weeks, once the villi atrophy, then try to remove it. But that is, of course, very serious situation. Patient has to be in hospital. Anytime she can start bleeding. Additional procedures like embolization, vessel ligation, intrailiac balloon occlusion, methotrexate have all been tried, but by and large, they have not been successful. Hysteroscopic removal of products later on may work. Triple P procedure I need to highlight, and tamponades. So surgical management includes separation from surrounding structures, delivery of the baby, resection of the scar, repair of the defect, and hemostasis. However, if childbearing is complete, the gold standard management would be perform a hysterectomy, planned hysterectomy with placenta in situ. If childbearing is not complete, then one has to think of other options. I need to highlight this. Dr. Ajit Rawal has already highlighted the lower segment. The sectional diameter of uterine artery is 1.8. This is immediate postpartum. However, middle vaginal artery is 1.88. So the vaginal artery is wider than the uterine artery, especially when there is higher blood flow in lower segment. And so ligating the uterine won't solve your purpose. You need to ligate the internal iliac, and that only will reduce the blood flow by half. It will not completely stanch the blood flow. And this is what the Dr. Jose, I'll refer to him again also, his study of about 50 cadavers and blood flow in the lower uterine segment shows that the lower uterine segment has blood coming from the vaginal branch of uterine, the superior vesicle, and lower vaginal, which is branch of pudendal. So when you ligate the uterine here, these three vessels are completely escaping. And so blood flow will continue and heavy bleeding will ensue. Another point which I wanted to highlight was these blood vessels between uterus and bladder are neovascularized, newly formed blood vessels. They do not have a muscle coat. So don't use cautery here. If you use cautery, you need muscle, that protein to coagulate. If there is no protein, this may stop bleeding for a while and again they will start bleeding. So individually identify them and ligate carefully. That is a better way. And this is how you identify, ligate, and then look at the placenta. If you find that there is no space between uterus and bladder, and purposefully opening the bladder will be safer, because then you will identify the ureteric orifices and then dissect it away from the uterus. Another issue is avoid the area where placenta is for baby delivery. Go higher up. Fundal delivery is not an issue. And I personally prefer the anterior wall. You can take a higher transverse incision. Sometimes even supraumbilical transverse incision also I have taken. Deliver the baby and then decide if bleeding is not there, leave the placenta inside. Here also you deliver the baby, put the cord back and close the uterus like that. Now, important points. Before you take a patient for surgery, decide the place of delivery, center of excellence, timing of delivery, 34 to 35 weeks. Don't go later. Otherwise, patient may go in labor and you are in an unplanned situation. Maximize the pre-op hemoglobin by oral IV iron or erythropoietin. Minimize urinary tract injury by pre-op ureteric catheterization, bladder dissection before delivery. See, many times we have an attitude of let us deliver first, then we will dissect. But all the time patient is keep on bleeding. So you may take 10-15 minutes to dissect the bladder away and patient will lose significant blood. So dissect the bladder first, so you are ready to do a hysterectomy if required immediately. Partially full bladder is better for dissection. You can delineate the plane better. Anesthesia, generally GA, but epidural if anesthetist prefers, then he can immediately institute GA. Spinal may not be the right incision because your incision also may be higher up. For important points are incision, access to the uterus. As I said, you have to go to upper segment for delivery. Another idea has caught up is go for a transverse incision and then cut the rectus upward to access the upper part. Blood conservation like tranexamic acid, balloon occlusion of vessels, interiliac ligation, cell salvage, which we used to do in older days, and placental separation. Total, we do not go for placental separation. Total versus subtotal, whenever it is a lower segment placenta, think of complete removal of uterus. Subtotal hysterectomy is ideal for atonic PPH, but not for lower segment, especially if placenta is at least 2 centimeters away from the cervix, then you can think of subtotal, otherwise do a total hysterectomy. Planned or delayed hysterectomy also people have performed when the placenta was left inside. These are 2 cases just to share with you where I have put the incision. This is much higher, much closer to umbilicus, and this is supraumbilical incision where we did a fundal delivery. Conserving the uterus. See, till now, dictum was remove the uterus. Now we are thinking 10 years back, Professor Arul Kumaran and his team published the first paper on PPP approach. And that is where, okay, I'll share with you one interesting case. Here you can see that once you open the abdomen, this is the bladder, here is the placenta projecting. So what you do is ligate all the vessels around the bladder and then dissect the bladder away so the lower segment is open. Then don't deliver from here. Go higher up, fundal delivery of the baby. Identify that this area has placenta. Dissect it, find the healthy area of uterine tissue and remove the placenta with the overlying uterine wall. And then suture it. Always go for total hysterectomy if S2 segment, as I mentioned, and deep dissection is required between bladder and vagina. Two things many times people ask for. One is the uterine artery embolization. Till date, data does not support that it works. Similarly, methotrexate after uterine conversion also does not work. Just now I had discussion with Chaitanya Bhai. Unfortunately, data does not support this. The triple P approach, perioperative placental localization and delivery of the fetus via incision above the placental level. You can do a transverse incision if you have a very good idea of where the placental edge is. Deliver the baby and everything from that part down, try and take it out. Pelvic devascularization, non-separation of placenta with myometrial excision and reconstruction of uterine wall, same as I showed you in that picture. Like this. You are removing the myometrium along with the placenta. Russian people have conducted this long-term trial of triple P and they found it to be useful. But I want to share with you this another aspect. Jose and his team has given another temporal classification. That one was depth of invasion. This one is location of placenta. Type 0 placenta reaches the serosa through a uterine wall defect. This is coming out through the scar, but without true placental invasion or presence of new vascularization. This is a false placenta. Placenta reaches to or beyond the serosa with presence of newly formed vessel between uterus, placenta and bladder, but only in the upper posterior bladder, which I said as S1 segment. That is okay. Type 2 is in the parametrium, lateral invasion. Type 3 is the lower part of bladder. Posterior wall of bladder, in the lower part, bladder, cervix and vagina may be involved. And type 4 is the fibrosis. So this is type 1. This is type 3 and 4. If fibrosis is there, it is 4. And this is type 2, where lateral, and data tells us that following MTP, if pregnancy occurs, lateral bulging has been noticed more. Now, this group has found an extensive data, and what they found was type 1, they could conserve the uterus to 80%. Type 2, 47%. Type 3, 20%. They could save the uterus. And type 4, they could not save the uterus. Large series. And they have gone one step beyond. Whatever uteruses they saved, they have a pregnancy outcome. Following this, next pregnancy, out of 202, 89%, when type 1 was there, they could achieve pregnancy full term. But then type 2 significantly low, type 3 significantly low, type 4 0, as we mentioned, there was no uterus saved. And interestingly, none of them where they ligated the uterine or ovarian vessel. Because once you ligate the uterine, the blood flow to the uterus gets compromised. And then next pregnancy, the placenta will go deeper to find the adequate blood because blood supply is reduced. And then you will have more placenta accreta, IUGR, and all those issues. Now, I just want to share two things. One is American College Guideline of Center of Excellence for Placenta accreta. What they said is, even if you encounter this kind of placenta on table, your ultrasound had said there is no placenta accreta. But when you open the abdomen, they say stop. Wait for a person who can handle this, or else close the fascia, put the skin staplers, transfer the patient to tertiary. If this is the guideline for American college, think about it for our situation where small nursing homes are dealing with it. And Center of Excellence, what it should have, multidisciplinary team, not only obstetrician, but entire team, surgeon, gastroenterologist, urologist, ICU care and blood services. So if you have this kind of a thing, only then one should attempt this. So placental adhesive disorders are more frequent of late. They cause life-threatening hemorrhage, severe morbidity, loss of uterus, some part of bladder, ureter trauma. New understanding helps managing cases. S2 segment requires experienced person and a team is vital. High quality setup is necessary. Now, I would like to share with you this case. Maybe I'm doing it for a second time or third time for some of you, but it is worth noting. This is that gentleman, Jose from Argentina. He wrote this to me 10 years back. Dear Parul, I would like to comment this case with you. He is a Spanish man, so his English is like mine. It is obviously a consequence of uterine scar dehiscence. So what he said was that patient had bleeding. Patient went to the hospital. Patient just went as a hypotension. They just treated her as a UTI, sent her home. Middle of night, she went back with hypotension. Ultrasound showed hemopericardium, and they opened up. And they showed this kind of a situation. So he said, what would you do? I wrote back that if I would remove this baby, and then if patient is settled, childbearing is not complete, I would repair it. Otherwise, I would do a hysterectomy. So he wrote back that, no, this baby is also important. So what he did was, he stitched up this area, all the vessels he stitched up, and then he put a mesh. This mesh was between upper segment and lower segment. He said this will prevent further separation. Both segments are going away and placenta was getting separated, and he allowed the pregnancy to continue. Every 2 weeks, he used to send MRI and such pictures. And then at 34 weeks, he did a fundal cesarean, removed the mesh, just a minute. And this case was subsequently published in British Journal as a uterine repair and successful pregnancy after myometrial and placental rupture with massive hemopericardium. So you can think of it that how people can think beyond already placenta accreta, bleeding, and he salvage even that pregnancy. So this is more for the youngsters to think out of the box like a Gordian knot, what Alexander did. I called him, Baba, other than me, what others were saying, you must have sent this to others. He sent me replies from 20 people, few of them from Europe, Japan, various countries. And barring me, only one more had said that we may salvage the uterus if patient is stable. Otherwise, all of them had said hysterectomy. So you can think of various options and do help to the patients. Well, thank you very much for patient listening.
Wonderful presentation, sir. As usual, you have covered almost very important issues. I think full day conference should be kept on this area because more and more cesarean sections are coming. But if you want to have any comments, we are eagerly waiting for oration of Dr. our Fox President. So, Kamini Ben, I think we will just, sir, anything else you want to add on, Parul Bhai?
For me, I just
you almost
highlighted-
covered everything. So I think we should.
But I can say this, Dr. Ajit Rawal is sitting here. Between two of us, he attends almost 2 emergencies every month. I attend 1 emergency every month, SOS calls. And the shift which we have observed is previously more of them were atonic PPH. Now with carbetocin and oxytocin, atonic component has declined, but placenta accreta and adherent placenta has come.
Yeah.
And that is something which is more worrisome.
Yeah. Wonderful. Yeah. Wonderful observation and tips that you have given to all of us will help a lot. Thank you very much. Just give a big applause to Dr. Parul. At outset, I thank Alpesh Bhai for this opportunity. Thank you.
Yes, thank you very much. The session was really great and much appreciated. Thank you very much, all the chairpersons. And now, most awaited oration, Madam President. I would like to invite our chairperson, respected Dr. Chandravati and Dr. Nandita Palshitkar. Dr. Chandravati, ma'am, She is the head of the Department of OB Gynec at Kiri Medical College, and she is a director at Krishna Medical Center, Lucknow. Introducing Dr. Nandita. She is a present president EMOX, and she was past president FOXY 2019. Welcome, Dr. Nandita and Madam President.
फुल स्क्रीन कर पहले आई थी फुल स्क्रीन करना है आई थी ग्रीन पर
Hello, hello. Good afternoon, everybody. Is this working? Okay. We can't hear. I think it's a real pride and privilege to be chairing this oration with my co-chairperson, Dr. Chandravati, and we would like to invite our FOXY president, Dr. Shanta Kumari. Shanta Kumari, has the privilege of being an honorary FRCPI from Ireland. She's also received the degree, and also from UK, the FRCOG. She's the president FOXY. We all know her for, I think, one of the few presidents, along with Alpesh, who's been there for 1.5 years in FOXY, which is quite a record of sorts. She's a senior consultant and laparoscopic surgeon at Yashoda Hospital, Hyderabad. And she served as a FIGO member for Committee of Human Rights, Refugees and Violence Against Women in 2018-2021, and has been elected as the treasurer of FIGO unopposed completely. I think that deserves really applaud. She was the chairperson of the FOXY ICOG 2018, secretary of the ICOG, vice president of FOXY 2013, IG managing committee member 2012 to 2018, secretary of the TCOGS, FOXY chairperson, and the national corresponding editor for Jogi. She's really served a lot of positions in FOXY, and her major awards and achievements are, as I mentioned before, the FRCOG and the FRCPI, along with the DHERA, which she initiated in 2016, a socio-medical campaign very close to her heart, violence against women, and especially the launch in FIGO was something that was something that we will remember forever. 2020 OGSH Lifetime Achievement Award, 2021 MOGS Dr. Ganatra Charitable Medical Center Award, 2020 MOGS Dr. N.A. Pandit and Shailaja Pandit Award, Pride of FOXY Award in 2019, FOXY Star Award in 2017, Young Scientist Award, CL Javeri Award, lots of awards.
Thank you.
And today she's going to speak on a very, very important topic, auditing of maternal mortality in India.
It is a pleasure to chair this session, Shanta, for you, and I've come all the way from Lucknow to be here present. Thank you. And thank you, Alpesh, for having us here. Thank
you. Okay, good morning to everyone. I bring greetings from Hyderabad, and it's indeed a pleasure to be here at Ahmedabad. Thank you, Alpesh. And thank you, Chandravati Madam and Nandita. And as I always say, I love you, Chandravati Madam. Thank you very much for being here with us. Of course, you, Nandita, what you are to me and what I am to you is, I think, something entirely different. Yes. Rajal told, yes, we are all sitting to hear you. And somebody else also told we are sitting here to hear you. Let me be very honest. In the beginning, friends, maybe about 15 years back when I started my journey in midway when I started, then I was reaching the positions in FOXY. We used to have a lot of conferences, and let me tell you, in the beginning, whenever there were any topics which were related to maternal health, maternal mortality, the halls used to be empty. Now, why is it so? And then there was a time when I became the vice president of FOXY. I had to deliver an oration in Hyderabad at a conference, which was a very prestigious oration. And my team said, now you're the vice president of FOXY, now you are in the leadership role. You shouldn't be speaking something which is general obstetrics or gynecology or infertility or endoscopy. You should be talking about what is very important issue relating to women's health. And friends, that day I delivered an oration on maternal mortality and India, the way forward. That time it was the MDG goals, which was still there. And by then, let me tell you, many of our obstetricians, gynecologists actually did not know what Millennium Development Goals were. That was the time, because everyone is busy with every other topic which was of interest. Very happy, yes. That day I was very lucky. The hall was full and I got a lot of compliments. And friends, let me tell you, maternal mortality or maternal death audit. Why is it important? It is very important because we as FOXians care for women. We are dedicated to the service of women. If there is any doctor who is taking care of women's health, that is an obstetrician gynecologist. So it's the core of our heart. So no obstetrician gynecologist can ever say, now this is not a topic for me to be sitting in the audience. That is the importance of maternal mortality rates, be it maternal audit or anything else related to this so very important aspect, because that's the core of our profession. That's the core of our commitment as an obstetrician to the health of the mother, to the country, and to the world. I think that is so very important. And I'm very happy to say over the years, I have noticed that our obstetricians, gynecologists, our FOXy members are so very committed. And whenever we are having these discussions in the conferences, the halls are quite full. And that shows that we are actually moving from what we need to do and what can be prevented. Sanjay Gupta sir agrees with me because that was in the AICOG 2011. We started seeing the sea change in the people's mindset, in the FOXians' mindset. And that's the reason, friends, I have to congratulate each one of you, my own FOXy members. It is the effort of all of you which has made it possible for India to reduce the maternal mortality rate to the lowest rate as it is today. It is not only the health minister or the IAS officers or all the officers in charge. It's the hard work of all obstetricians, all the doctors across the length and breadth of the country, which has made it possible today, that shows that we are on the right track to reach the SDG goals. And thank you for that. When I took over as the president from Alpesh, I came with my team and vision, FOXy for all always, and Dhira, stop violence against women. FOXy for every mother, to reduce the maternal mortality rate, achieve SDG goals, and let no mother die in childbirth. For every woman to be able to live with courage, Dhira, to say no to violence against women, because violence also contributes to the maternal morbidity and mortality. And FOXy, for every FOXy and for each one of us, to be able to practice with safety, dignity, and protocols. This again goes a long way to save mothers. That is so very important, I think. That is the core of us to be the FOXy members. What we do not measure does not exist. Absolutely right. What you don't know, just don't know. It doesn't matter. There is so much of meaning if you're not talking of maternal mortality rate, if you're not talking about maternal audit, then what will you understand of maternal health? What is it that you're giving back to your society? What is it that you're taking care of your women? I think that is the most important aspect which all of us have to remember. Measuring is the first step of acknowledging that a problem exists. If you're not ready to accept that there is a problem, how are you going to find the solutions for maternal death, for maternal near miss, or domestic violence? That is the reason why we have to know what we are talking about. If you can't measure it, you definitely can't improve it. This was told by Peter Drucker. A management thinker, Peter Drucker, actually often quoted as saying that you can't manage what you can't measure. If you have no idea of what your maternal mortality or morbidity, how is it that you're going to take care of your women better? I think that is so very important. And you can't know whether or not you are successful unless it is defined and tracked. I think that is the most important essence of this. Well, friends, do our mothers and children count? Why should we care? Well, because the MCH indicators is a human development indicator. Maternal mortality is a proxy indicator of the functioning of the health system. It's an issue of human rights. That was the reason why it is so very important that every mother and every child's birth and monitoring has to be counted. Look beyond the numbers. Whose faces are behind those numbers? Is it only 170, 113? We are less than 60, but just imagine for that family, that one death is the end of everything. What are their stories? What were their dreams? They left behind children and families. They also left behind clues as to why their lives ended early. And it is for us to actually look at those clues and see that it doesn't recur or repeat itself. Maternal and infant mortality are two critical indicators that measure not only the health conditions, but the overall development of a country. No prime minister or president of a country can talk or boast of economic development unless the maternal mortality rate is reduced to a single digit. I think that should be the commitment of the politicians. That should be the commitment which we as the citizens of the country should ask our politicians to give when they come and ask us for votes, because they both are the key goals in the National Rural Health Mission and the Millennium Development Goals, which we couldn't achieve. And now we are on the way to the SDG goals. Well, when we're talking about the MDG goal, we were talking about the goal 5, and we were looking at all the targets, all the contraceptive prevalence, adolescent birth rate, antenatal coverage, the unmet needs for family planning, all these issues which actually reflected in us to get the SDG goals. So we had to see where we were standing, what went wrong, what has to be done, and look at the strategies. And friends, only when you see what you have done, you can plan the future. You need to have your strategies in place to plan your future. So that's why way back in 2004, when WHO decided it's time that they come into force, and they decided that it's not just enough to know the numbers. We have to see beyond those numbers. So reviewing maternal death and complications to make pregnancy safer. Now, why do maternal deaths occur and what can be done to prevent them? Where are the things going wrong and what can be done to rectify them? Now, answering these questions are so very important, knowing the precise level of maternal mortality. About 20 years back, nobody used to like to actually be asked these questions. I still remember as an undergraduate, or I'm a third generation obstetrician. So in my house, sometimes they used to talk, oh, the chief was talking, there was a patient who died, and then the unit chief was so angry, she was blasting, and also that time I used to wonder why. But that showed the commitment of that HOD, that obstetrician who has made a point very clear even before the government actually was looking at this. Was about 30 years back, 35 years back, when I was in school. So those were the days which showed that obstetricians were always committed for looking into the maternal death. And it is a bit later when the government started looking at the policy makers started looking at it. And that's where the difference started. So we have to look at the new approach of why mothers die. Is it because they're unaware of the need for a care or unaware of the warning signs of problems in pregnancy? Or is it because the services do not exist or are inaccessible for other reasons, such as probably distance, cost, or the socio-cultural barriers? Or are women dying because the care they receive is inadequate or actually harmful? Answering such questions and taking positive action on the results is often more important than knowing the precise level of magnitude of maternal mortality. The right question leads to the correct answer. In an organization, I was in a meeting, some international meeting, and somebody said, Shanta, yes, I think you asked the right questions. I didn't understand the meaning of that, but then I realized for me to know the answers or know what is happening, I should be putting the right question. And I think that is the most important aspect of maternal audit. So asking the right question, getting the right answer so that you can do a remedial measure. So don't get worried about the maternal audit or think, why should we do it? So when you look at the history, 1960s to 90s, it were all target oriented, all the 5-year plans which we read, the family planning, the antenatal care, huge private sector was never utilized. We have here, P.K. Shah and C.N. Sir and all, they were all secretary generals over the years. In those days, I still remember how much they worked to make the government realize that you cannot actually achieve many things unless you involve the organization, unless you involve the private sector. And synergy, that was lacking, the lack of synergy and quality supervision and close monitoring. That's why, we were stuck at 300s for a long time till we actually came to 200s. Then we were looking at the cause of maternal death and all the issues which everyone knows. And then look what constitutes the maternal death. The maternal mortality ratio is the number of women who die from any cause related to or aggravated by pregnancy or its management, excluding accidental or incidental causes during pregnancy and childbirth or within 42 days of termination of pregnancy, irrespective of the duration and site of pregnancy per 100,000 live births. So that is the reason why anything surrounding the death of a pregnant woman has to be looked at carefully. It can't be just taken for granted. The death of a woman while pregnant or within 42 days, actually, we know when you look at it, this was stated by the WHO, and the maternal mortality ratio is, of course, what is per 100,000 live births. Now the question is, how do we audit? I still remember about 15, 20 years back, there were some very high-flying obstetricians in our own city who used to come and talk about audit and things like maternal death review and all. But none of my society members were happy to hear to that meeting. Why was it? Because there was blame game in that talk. Whenever she used to talk, she used to blame. She used to blame the private sector. She used to blame the public sectors. So that is not the way we are going to approach it. I can't sit here and blame, okay, Rajal, Preeti, you are responsible. You are in the pub, you are working in the medical college. 2 patients are lying on one bed and you have not given blanket for her and all. And then you look at it. Are they responsible for 2 patients lying on the single bed? You should be asking the government, the health minister, the chief minister, not the obstetrician who's working there. At least she's trying to care for the patient lying even 2 at a time. So they're overburdened. So that is the most important point. Remember, maternal audit cannot be approached unless you actually don't think or do this blame game. You have to take everyone into confidence, see how we can do something to get the best result. So be it the maternal death audit, the SRS sample registration surveys, the birth and death registration data, the maternal death review, the maternal death surveillance and response in 2018, maternal and perinatal death surveillance and response in 2021, and maternal near miss audit 2018. So very important, the maternal near miss audit. This will teach you lessons how we can avert a maternal death. So those are the important aspects. Maternal audit is not something to catch somebody by the neck, to make somebody responsible or a scapegoat. That is the reason why I think people shy away from this maternal audits and things. It should be something which we should be doing to see how we can be better, how we don't have the situation in future. So way back in 2004, Kerala, of course, they had a lot of this thing with the UK confidential inquiries, and they started out. And that time the KOFOG started doing a lot of CMEs and books and all that. And we did find that they had definitely reduced the maternal mortality rate in Kerala. So we are very proud that they have reduced it less than 50. They are the ones who have reached SDG goals. But then don't become arrogant. Now, what is happening? The maternal death mortality rate is increasing there. So you should realize that you can't get arrogant. You can't think you are holier than thou. Now the ministry, health, everyone is worried because they thought that they have reached. Now we are ultimate. We only need to look at the top. That should not. We should be always grounded. Think what is it we have achieved and how to actually continue the pace and how we can be better. So these are very important lessons we should learn so that we don't become callous. And they were good teachers. They did teach everyone. We're talking about maternal mortality and audit and all. That definitely was helping our other members to learn from them. Then this maternal death audit, the NHM, the Government of India 2010, was a strategy that has been spelled out clearly in the RCH2 National Program Implementation Plan document. It's an important strategy to improve the quality of obstetric care and reduce the maternal mortality and morbidity. So there were different approaches to investigation of maternal death. The community-based maternal death review, so very important, the verbal autopsy. Facility-based maternal death review. Confidential inquiries into maternal deaths. Surveys of severe morbidity, near miss, the clinical audit. Then Government of India actually decided to take up community-based maternal death review and facility-based maternal death review, which would help in identifying the gaps in the existing healthcare system delivery and prioritize plan for the intervention strategies and to reconfigure the health services. That's so very vital for development. Then the MDR guide in 2010, the objective was very simple: to establish the operational mechanism, modalities for undertaking the MDR at selected institutions, to disseminate the information on data collection tools, and to develop system for review and remedial follow-up. Then there was a timeline, the activity timeline, then incentives, everything. Unless you incentivize, sometimes you don't get the result. So it was all the needed opportunities were tried to utilize in this audit. Then this is just a chart how the MDR guide to 2010 and how the training cascade right from the Delhi to the different meetings. So that's what we have now. We have IT colleagues from Delhi and all. So they used to be represented the whole of the country. Then we have realized that if you want to reach, it's not only Delhi, you have to reach out to all the parts, nooks and corners of the world to make the difference. The government has also realized, and that's how all the state level, district level, and block level, all the trainings were done. For the in-depth analysis data, state may take support from experts from medical colleges, universities, and other specialties. Then use the analyzed data, which will be actually used for developing the annual maternal death report of the state. And community awareness and action. Before 2010, there used to be a vague meeting. Sometimes they used to call the Hyderabad Society representatives, and it used to be very distantly paced. It was not given much of importance in the early 2000s. And towards after 2005-06, and slowly the government and all this started being put into place, and people became, the government and the administration became very proactive to bring about a change. And that started actually bringing out a lot of results. The CBMDR process indicators, the proportion of maternal death investigated in district and reported versus expected and estimated. Investigated versus reported. Sometimes maternal deaths are not reported. So they're actually utilizing other means where they can get, they have some, like how the police has those informers, they have the community-based informers who will inform them about the maternal death, which could be actually be audited and try to see how best it could have been averted. Then the facility-based, the maternal death MDR process indicators is a proportion of institutions that conducted this facility-based meetings, and the number of meetings if there are facilities, and the percentage of maternal deaths notified within 24 hours, and the proportion of maternal deaths investigated. So all these indicators are so very vital for actually knowing what is right and what is not. Then the district level process indicators, the proportion of deaths and meetings conducted by the district magistrate. And I'm very happy, now the government is so proactive. The government has involved Foxy, and actually from Foxy in Mumbai, Madhuri Patel was attending this MDR review meeting, surveillance and all. And they actually wrote back and asked, can you give one or two more names? That shows that they also realize that unless you actually have a liaison with the organization, you will not be able to get maybe the correct information. The cause of death classification, we have to see, look at the direct obstetric causes, the indirect obstetric deaths, non-obstetric causes. Sometimes death of a pregnant woman resulting from accident or incidental cause, suicides, accidents, assault, burns, snake bites, all these are very important, which are actually attributing to the maternal mortality. So we got the formats in place, and then all the annexures where the indirect, direct, these are all the forms for the maternal audit. And probably we can look at even the private sectors or medical college. I'm sure all of you have the medical audit and all. It's so simple. And you start putting it, and when you analyze it, you will know what is going wrong. And you can look at remedial measures. You have the modules like collection, the module 2 used for deaths occurring during the antenatal period, and the third module during delivery or postnatal period. Now, this is where we realize that the most important period is the birthday. The day of delivery. That is the most important day where you need to take care to reduce the maternal deaths. That's why after this only the realization came, and then people started talking about the Lakshya. The government started this program about the high risk obstetric care unit, which Alpesh was talking, and the Lakshya and all. So that is the most core. After doing this stepwise, then they realize the most important is the birthday on the day of delivery, where the maternal deaths are more. So that's how you know where you're wrong, and you start your remedial measures. And then the case summaries, when you look at it, these are all the guidelines. And of course, the delay in seeking care, all this were there before, whether it was unawareness, illiteracy, then poverty, and beliefs and customs, and of course, delays which were there in the previously. And now, after looking at that there is a problem in delay, then we know 108 came into picture. Delay in receiving, and after reaching the care, you don't have the doctor, you don't have the blood bank, you don't have the anesthetist, you don't have the OT facilities. So knowing all this makes it easier for the government to put in place what is needed to avert a maternal death. Then 2013, this MDSR, the Maternal Death Surveillance and Response, Technical Guidance. The FIGO with UK aid, the CDC, the UNFPA, the WHO, and the International Federation of Midwives, the information for action to prevent maternal death. That's the maternal death surveillance and response. Now, moving from maternal death review to MDSR is so very important. The MDSR system is a continuous action cycle that builds on the established approaches such as the maternal death review. The MDR has actually led to local policy changes and improvement in the quality of maternal health services, even in challenging settings. MDSR builds on the work already done to implement MDR and helps us to understand the events which are surrounding the maternal death. And it stresses the need to respond to each maternal death with actions to prevent similar death in future, to collect the data on all maternal deaths using clearly defined data, sources and process for identification and notification. How much time I have? Over 4. So the key components in the technical guidance, a maternal death should be made notifiable event and incorporated in the notifiable disease reporting system. Identification, reviews, analysis, response, MDSR implementation. But remember, the no blame policy, the Government of India, March 2018, guidelines for maternal death surveillance and response, new robust guidelines, MDSR in all the states. Remember, no blame policy. So when you're standing on the stage and talking about something, if you're talking about respectful maternity care, if you're talking about maternal mortality rate, talking anything, don't have this blame game. In my institute, this is done. In the public institute, this is. I think that is something which nobody accepts. And that is the beginning and end of the situation. I think that was what was needed to be corrected, and I'm very glad that we have been able to do it. The purpose of the guideline is very important to strengthen the mechanism and process for maternal death surveillance and response. So very important. And all these points about how abortion, anticipated complication, when you put everything down, it becomes very easy. MDSR system is a continuous cycle of identification, notification, and review of the maternal death. Confidential reviews are so very important. Multidisciplinary anonymous investigation into the line of management. Sometimes people may have some sort of scores to settle in between. So let not those come when you do a maternal death audit or the MDSR. I think those are the important things which should be averted, because somebody is trying to get even with someone and you get a chance. Okay, this is the right thing where I can hook or catch this person. I think that is not what is needed. So national nodal officers, all the state nodal, these are all the, what is the setup of this audit, and the quantitative indicators and the qualitative indicators, the pathway analysis depicting the multiple reference. So what are the effects of results of the MDR or MDSR, the confidential review? We have to look at the cause of maternal mortality in India. Historical review, we're looking at antenatal care risk screening, then current approaches, reduce unwanted fertility, skill attendance at delivery, emergency obstetric care, and the most important, the government has increased the age of marriage, because we have realized that the adolescent teenage pregnancies, all this, the child marriages, all these are also attributing. So this is all a way forward, trying to look at the holistic approach. So we need to understand old slide, 2004, when you look at it by the World Bank, that with access to emergency obstetric services, you can avert maternal death. So the maternal deaths averted through access, simple thing, improve access to abortion services will reduce the maternal mortality. Very simple. Family planning services, reduce the necessity for abortion, reduce the necessity for an unnecessary delay. So all the delays which were all addressed, which we have seen in the 90s and all that were taken care. And there was a huge halagulla when a patient will reach the facility, nobody is there. So when we used to look at it, how Thailand, Sri Lanka, Malaysia have achieved, why we have not achieved. They're all small places, not even half of Ahmedabad or Hyderabad. So it's very easy, but our country is so big. Millions of women delivering, thousands of obstetricians and nurses, and so many people taking care. I think that is a very important. The National Rural Health Mission was a turning point which addressed all the problems, and that actually we're focusing on the low performing stage, and that made a difference. So the key strategies, the 108, these, all the yojanas were all very important. In fact, we used to wonder why government is giving doles, why government is giving money to the pregnant women. But that's so very important. Bihar has seen this, has increased the institutional deliveries, that has reduced the maternal mortality. So we may have to address these by using some of the techniques to attract the women. So historical review of intervention, the flawed assumption, most life-threatening obstetric complication can be predicted or prevented. Antenatal care, maternal death prevent 11%. So all this we know from the BMONC to the CMONC approach, multiple initiatives we have taken up. We have seen we have a long way to go to reduce, and of course the SDG goals, we are nearing it 2030, and I'm sure that we'll be able to reach it. Unfortunately, COVID has put a little checkmate, but still India records 22% drop in the maternal mortality rate, which was very good, friends, and major drops when you look at many of the dips in the states. Ministry of Health actually was found to tweet about how the maternal mortality rate is coming down and the healthy rate is there. A woman who survives life-threatening condition during pregnancy, termination of pregnancy, childbirth, or within 42 days of pregnancy termination, irrespective of receiving emergency medical surgical intervention or otherwise. So we know about the maternal death review, and friends, FOXY at the service of women of our country. I think that's the core. And national, international collaboration for knowledge and setting the skills are so very important. No one can ever get to the top of a mountain in one giant jump. Challenges can be overcome, goals can be reached, but it can only happen one step at a time. I think that's what we have been doing. And I'm sure that we'll be reaching the top where we'll be reducing or preventing every preventable maternal death. Thank you very much.
Thank you, Shanta. I think it was a wonderful oration. It was probably awakening everyone and giving thoughts into their minds. I remember when we were residents and lecturers, we used to have a departmental inquiry about the maternal deaths. But still today, I'm really at times shocked that there's no sort of maternal audit at the level of the CMO or someone who could do it and see to it. But I'm sure people are awakening, people are coming to it, and people are thinking about it. And your wonderful talk has put so many thoughts in everyone's mind. Thank you for a wonderful oration.
So Alpesh told me, give a topic for your oration. I said, I was thinking, then he told, okay, this, I said, fine.
Thank you very much, Santa Kumari, Foxy President. Thank you for covering this topic. This topic is very, very essential. And thank you very much for sensitizing our members regarding this. You have, I will say, you were emotionally connected with the topic in your oration, and you spoke from your heart. You also covered non-obstetrical causes, and you also spoke about the role of politicians along with role of obstetricians. So thank you very much for covering all these things. And Dr. Jignesh Deliwala, AOGS President, who is also organizing chairperson, youngest president of Ahmedabad Gynec Society. Will also like to
Thank you, ma'am, for a very good oration and the strategies to reduce the maternal mortality in India. But as you said that in your oration that the health worker like us is the most important role of to reduce the maternal mortality. And I think along with all Foxians, we could achieve that goal in near future. Thank you, ma'am. And as a team AOGS and I from the Ahmedabad Obstetric Gynec Society, a warm welcome for this ICCOB conference, and I hope that you all have enjoyed the hospitality from Ahmedabad. Thank you so much.
Sunil. Munjal. Sunil. Munjal.
मुझे रूम मेरे को देना है
ने बुला लो आएंगी तो अच्छी चीज देंगे नहीं नहीं हम अभी
No? So I'd like to introduce our first speaker, Dr. Uday Thanawala. Are you going to, do they flash the CV? Dr. Uday Thanawala, as we all know, is Chairperson ICOG, and he's a very senior practitioner person from Navi Mumbai. He's been the past president of the Navi Mumbai Society. He's been the vice president of FOXI, and he has special interests in PCOD, gestational diabetes, and also ultrasound. Yeah, I said no, I Chairperson ICOG. Didn't I say it? Didn't I say ICOG Chairperson? I think I said ICOG Chairperson right in the beginning. They're telling me I can't say it. Yes, that's the most important thing.
Yeah, so I was wondering where Preeti is. How do I open this? It's not. How are you? So thank you very much, Sarita. Thank you, Preeti, Dr. Dolly, and thank you for chairing this session. And we've been working a lot on diabetes and GDM for the last 10 years, as Preeti is also one of the frontline workers, if I say, of GDM and in India. And we have worked and come to some consensus, but there are still problems which can occur, which can take a woman directly to the ICU for a critical care. So basically, let's talk about diabetic ketoacidosis. And this is the case which started making me think, because we had this about 6-7 years back of 31-year-old girl, a gravida 4, para 0, abortion 2, ectopic 1, who presented at 26 to 27 weeks with intractable vomiting and upper abdominal pain. RS-CVS was normal, the blood pressure was normal. So when you get a patient like this with upper abdominal pain, obviously you feel, oh, it could be acidity, it could be hiatus hernia, etc. So we give her all the symptomatic treatment. Her BMI was just 23, but instead of all the symptomatic therapy, pain in the upper abdomen did not decrease. She became breathless and she had tachycardia. The recommendations of blood sugar testing is not yet followed, because as now we all know, and it's a very crystal clear thing, that there has to be universal testing for all our Indian women to be done for sugar, because the incidence is very high. And the FIGO guidelines also recommend the DIPSI test to be done first at the first antenatal visit, and then repeat if it is negative at 24 to 28 weeks. And that is a 2-hour OGTT, where we, irrespective of the fasting state, we give her glucose to drink, and after 2 hours draw the sample. If it is more than 140, we label her as a GDM. So that is what is the guidelines are. But if it's not followed, sometimes you may land up with the sudden emergencies of diabetic ketoacidosis. Diabetic ketoacidosis is an acute, major, life-threatening complication of diabetes characterized by hyperglycemia, ketoacidosis, and ketonuria. It occurs when absolute or relative insulin deficiency inhibits the ability of glucose to enter cells for utilization as metabolic fuel. And the result is that the liver rapidly breaks down fat into ketones and employs this as a fuel source. The overproduction of ketone ensues, causing them to accumulate in the blood and the urine and turn the blood acidic. And this mainly occurs in patients with type 1 diabetes, but it is not uncommon in some patients with type 2 diabetes. And the normal clinical presentation is the early signs of DKA in a woman would be polydipsia, polyuria, malaise, generalized weakness, fatigability, nausea and vomiting, which may be associated with diffuse abdominal pain, decreased appetite, and anorexia. History of failure to comply with insulin therapy or missed insulin injections due to vomiting or psychological reasons. And there can be altered consciousness or frank coma. Now, this is important because these clinical presentations, one has to make sure your diabetic patient knows that if she feels these things, she must report to you immediately, because then it could be a sign that she's going into diabetic ketoacidosis. We got our patient a little bit late at that time, but here it is important to know these early signs. Patients, a diabetic patient complaining of malaise, polydipsia, polyuria, make sure to do the investigations, make sure sugar is under control, and she doesn't go into a diabetic ketoacidosis. What can precipitate the condition? One is protracted vomiting, hyperemesis gravidarum, which is very common. And many women who are even on insulin, they feel that if they are vomiting, they can miss their doses of insulin. So that even propagates and makes the patient, pushes the patient into ketoacidosis. Another very common thing which happens is any infection in the body can do it. And of course, we have insulin non-compliance or some medications like corticosteroids, which we give for lung maturity. Sometimes in a severe diabetic, it can push the patient into this. And of course, things like insulin pump failure are there. Now, on clinical examination, what do you see in these patients? They look very ill. They have a dry skin. They have a labored respiration, dry mucous membrane, decreased skin turgor, decreased reflexes, and characteristic acidotic ketonic breath odor. They have tachycardia, hypotension, tachypnea, and hypothermia. And we have to search for any signs of infection, because that could be the causative region of a diabetic ketoacidosis. What is the diagnostic criteria? Blood ketone levels more or equal to 3 millimoles per liter, or urine ketone level more than 2+, blood glucose level of more than 11 millimoles per liter, or unknown diabetic mellitus, the bicarbonate levels less than 15 millimoles per liter, or a venous pH less than 7.3. The blood sugar level is there because there are some cases which have been reported where the blood sugar has come normal, but even then the patient has been in diabetic ketoacidosis, and I'll talk about it a little later, what is known as euglycemic diabetic ketoacidosis. But some differential diagnosis could be acute pancreatitis, appendicitis, or septic shock, things like that, which you can think of. But laboratory studies, we have a list of studies to be done, like glucose level, electrolytes, bicarbonate, amylase, ketone, the blood gas measurements, CBC, BUN, and of course ECG, etc. The management goals, this is important, is the treatment of ketoacidosis should aim for the following. One is fluid resuscitation, reversal of acidosis and ketosis, reduction in the plasma glucose concentration to normal, replacement of electrolytes and volume losses, and identifying the underlying cause. So basically, when you talk about management of diabetic ketoacidosis, let's say intravenous fluid therapy, intravenous insulin therapy, electrolyte correction, evaluation of the need of bicarbonate administration, and identification and treatment of any precipitating causes, and of course, monitor the fetal condition also. So the important thing is that we as obstetricians who are in our small maternity homes, when we get a patient like this, what can we do in our own setup before we transfer the patient to an ICU or a high dependency unit? We can obviously give them IV fluids, and we can give them IV insulin, and this management we can start. The fluid administration, if a systolic blood pressure is less than 90, she should be resuscitated with 500 ml of normal saline infusion over 10 to 15 minutes. And if the blood pressure does not improve, this can be repeated. After stabilization of the blood pressure above 90, the patient can be maintained with normal saline infusion of 1 liter over 1 hour, and then 500 ml per hour for the next 4 hours, followed by 250 milliliters per hour for the next 8 hours. And then the infusion rate can be reduced. So that is the IV management, which we all should be knowing as obstetricians when we deal with diabetic patients. If we get a patient, we should start the IV fluid, normal saline 10 to 15 milligram per kilogram per hour in the first hour, and then adjust the rate. So you may give 1 liter in the first hour, 500 ml per hour in the next 4 hours, then 250 milliliters per hour. So that is how the IV fluid has to be started. The infusion helps to improve tissue perfusion, decreases stress hormone levels, and causes hemodilution. This in turn lowers the hyperglycemia and increases the response to insulin therapy. Adequate perfusion should be ensured, taking into account fluid losses, though one close monitoring of urine output. Now, what about insulin? Insulin therapy with regular insulin should be commenced promptly in patients with serum potassium levels more or equal to 3.3 millimoles per liter. So if your potassium levels are normal, one can start giving insulin directly. But if insulin administration should be postponed, if serum potassium is low, until it is corrected to more or equal to 3.3 millimoles per liter, because the insulin pushes the potassium into the intracellular space, which aggravates the existing hypokalemia and may precipitate fatal cardiac arrhythmia. So it's a very important point to be remembered. Don't blindly give insulin to these patients. Give them, start the fluids, do the serum electrolytes. If the potassium is about 3.3, yes, start off on insulin. If the potassium is low, first give potassium and then think of giving insulin. For patients with a good urine output, at least 0.5 milliliter per kilogram per hour, the serum potassium level and less than 5.5 millimoles per liter should receive potassium chloride in order to maintain the potassium level in the range of 4 to 5 millimoles per liter as the potassium starts to return to cells with the ongoing IV fluids and insulin therapy. But it is recommended not to transfuse more than 20 millimoles for potassium per hour. What about the rate of insulin transfusion? Regular insulin infusion should be commenced at a fixed rate of 0.1 unit per kilogram per hour, and it is recommended not to exceed 15 units per hour. If the metabolic targets are achieved, like primary blood ketone levels, if metabolic targets cannot be achieved by the current infusion rate, the infusion rate should be increased by 1 unit per hour until ketone reaches a desired level. And the metabolic targets to be achieved are decrease in blood ketone levels by 0.5 millimoles per liter per hour, increase in venous bicarbonate by 3 millimoles per liter per hour, and decrease in capillary blood glucose by 3 millimoles per liter per hour. So the laboratory test should be scheduled, like glucose should be done every 1 to 2 hours until the patient is stable, and then every 4 to 6 hourly. The electrolyte determination should be done 1 to 2 hours until the patient is stable, and then again 4 to 6 hourly. Then initially BUN should be done. Atrial blood gases measurements should be followed with bicarbonate if necessary, and repeat laboratory tests are critical, including potassium, glucose, electrolytes, and if necessary phosphorus. Initial workshop should include aggressive volume glucose and electrolyte management. Now, recovery from DKP is defined by a blood ketone level of less than 0.6 millimoles per liter, a pH more than 7.3, and a bicarbonate more than 15 millimoles. Now, one can switch over to subcutaneous insulin. The fixed rate infusion can be discontinued after DKP resolution and after 30 to 60 minutes from the first dose of subcutaneous rapid-acting insulin. So start the subcutaneous rapid-acting insulin, and after 30 or 60 minutes, then switch over to total, stop the drip and switch over to subcutaneous. This will prevent rebound hyperglycemia or recurrence of DKP. What about the fetus? What is the effect of ketoacidosis on the fetus? Now, ketoacids as well as glucose readily cross the placenta. Maternal acidosis, hyperglycemia, severe volume depletion, or electrolyte imbalance all have a detrimental effect on the fetus. The fetal mortality associated with GKP ranges between 9 to 36%. And the mechanism of fetal loss, it could be because of massive osmotic diuresis, dehydration, reduced uteroplacental blood flow, maternal acidemia causing reduced placental blood flow, or maternal hyperglycemia causing fetal hyperinsulinemia and increased fetal oxygen requirements, or maternal hypokalemia can cause fetal hypokalemia and fetal arrhythmia. So these are suggested methods why the fetus can get affected when the patient is actually in ketoacidosis. The long-term effects on the fetus are not really known. Some studies have shown a direct relationship between plasma ketone levels in pregnant diabetic women and a lower IQ in the child. So basically, we need to prevent the occurrence of diabetic ketoacidosis in every pregnant patient. But once it has occurred, how do you monitor the fetus? The fetal heart tracing performed in DKP may often demonstrate fetal acidotic changes. That is often corrected with maternal hydration and correction of maternal acidosis. Means when the woman metabolic condition is improved and corrected, even the fetal changes may come back to normal. So normalization of fetal heart tracing after correction of DKP may require 4 to 8 hours. Fetal biophysical profile and Doppler studies may also reflect fetal acidotic stosis. Even if you do the Doppler, the middle cerebral artery may show you an abnormal Doppler when she is in ketoacidosis. So the question is, if a patient is in ketoacidosis, do we deliver? Subjecting a patient in diabetic ketoacidosis to emergency cesarean section could cause further maternal deterioration while offering minimal, if any, benefit to the fetus. Interestingly, once hyperglycemia and acidosis is reversed and maternal stabilization is achieved, fetal compromise may no longer be evident. However, the decision to deliver should be individualized and should be primarily based on the evaluation of the maternal clinical status to ensure a safe labor, delivery, and of course, you to take the fetal gestational age into considerations. So basically, the complications, the maternal complications can be severe if it is not really corrected. The patient can have acute renal failure. The patient can go into adult respiratory distress syndrome, cerebral edema, coma, and even death. So imaging studies may be helpful in patients, especially the chest radiography, to rule out pulmonary infections such as pneumonia. The CT scan and the MRI is important in patients where you're suspecting cerebral edema, if there's altered consciousness, etc. Order 1, because cerebral edema is a very dreadful combination of diabetic ketoacidosis, but do not delay administration of hypertonic saline or mannitol in those cases where cerebral edema is suspected. So if we continue pregnancy, how to monitor? In the majority of the cases of diabetic ketoacidosis, the aim should be to monitor the fetus until the maternal metabolic state is stabilized and continue the pregnancy with complete resolution of DKP. Here then, you have to educate the patient to avoid further recurrence of the diabetic ketoacidosis. She should not have another episode of DKP. So basically, to prevent the recurrence of DKP prior to discharge, it is necessary to educate the patient about how to identify and rectify the precipitating factors. She must realize she's a diabetic. She must monitor her blood sugar levels. If she's going in having any infection or the sugar levels are fluctuating, she must report to you if you want to prevent another episode of diabetic ketoacidosis. Review the pre-admission diabetes control injection technique, injection sites, glucometer reliability, and storage of insulin with the patients, because sometimes she says everything is fine, I took the insulin properly, but there must be some fault somewhere why she's landed up in this condition. In addition, give her a written plan of care. In addition, future fetal monitoring should also be planned prior to discharge, and follow-up should be organized to review both maternal and fetal antenatal progress and ensure continuation of care. So what is the prognosis? When DKA is treated properly, it rarely produces residual effect. The prognosis of properly treated patients with diabetic ketoacidosis is excellent, especially in the younger patients. Before the discovery of insulin, however, and before 1922, the mortality rate was 100%. So it is such a dreadful complication. The overall mortality rate is now 0.2 to 2% with persons residing in developing countries. So we need to be very careful, and we need to really pay attention to this, that it does not happen. The presence of deep coma at the time of diagnosis, hypothermia, and oliguria are signs of poor prognosis. The fetal mortality rate as high as 30% is associated with this condition, and a rate as high as 60% in diabetic ketoacidosis with coma. If your patient comes in coma, it is really bad. Fetal death typically occurs in women with overt diabetes, but it may occur with gestational diabetes also. So this is the last one tip. Euglycemic diabetic ketoacidosis in pregnancy. Why should the sugar come normal? If your patient is in diabetic ketoacidosis, why should her blood sugar come normal? And sometimes it happens, and there have been cases documented. And the explanation given is the use of glucose by the fetal placental unit with decreased maternal glycogenesis and gluconeogenesis, and an increased renal loss of glucose may be the reason why the blood sugar is not high. A dilutional effect of blood glucose because of increased plasma volume during pregnancy. It is notable that the management of euglycemic DKP follows the same principles. However, IV fluid therapy should involve the concomitant administration of 5% dextrose with IV saline via a separate line from the start of treatment to avoid hypoglycemia caused by IV insulin administration. This is not necessary to stop the production of ketones. So basically, DKA in pregnancies is a preventable complication. And if we are more aware and we make our diabetic patients more aware of it, we can definitely prevent it. And if we do get it, we can treat it to the best of our ability before transferring to the high dependency unit, which all patients will require. Thank you very much.
Thank you, Dr. Thanawala, for that lovely presentation. I have one practical question, and that is, how do you tell your patients who are diabetic in pregnancy to monitor sugars? You know, if you tell them do 8 sugars a day, pre-meal, post-meal, they're not going to do it. The compliance is low. So what's a practical way to tell them?
So what we normally do in practice is when we discover the patient is a diabetic and we want to monitor her sugars, we definitely tell them self-monitoring of blood sugar. We sit and explain to them how it is to be done with the glucometer. And initially we draw a chart and give it to them that they should do at least 6 readings in a day for at least 1 week. And especially if they are on insulin, we need to know how well the sugar is controlled by insulin. Only once the sugar is well controlled, we say, okay, now instead of 6 readings, you do any different 3 readings in a day. But most of the patients don't want to do a post dinner. So no, that is very important because at least once in a while do a post dinner or so they have to do different 3 readings in a day. And if we get all that normal, then we say, okay, you switch over to alternate days, but do at least 2 readings in a day. So that is how we manage it in patients. In all diabetics, whether they're on insulin or not on insulin, we generally have this protocol because now self-monitoring of blood sugar is something which is, I think, highly recommended for these patients. When you come to know that they're a GDM patient or the type 1 diabetics, sometimes are a little better to deal with because they know how to monitor the sugars. Only thing you have to be a little more strict with them, you tell them that pregnancy is a very different situation what you are dealing with. So, your regular levels of 140, 150 postprandial will not do in pregnancy. We need a better control.
Thank you, Dr. Ray. It was an excellent lecture.
Thank you. Thank you so much. Thanks.
Now, next talk is by Dr. Sanjay Gupta. He is the ex-chair of Ethics Committee of FIGO, Foxy Ambassador to FIGO, Secretary General World Diagnostics Organization, has been awarded FRCOG by Royal College in 2010, President Foxy 2010, President DIPSI 2013, Chairman Technical Research Committee of the Indian Council of Medical Research, author of 8 books and chapters in more than 40 books, has more than 150 publications, ex-honorary professor and postgraduate teacher of OBGYN, Director, Gupta Hospital and Center for Research and Reproduction, Director, Green Array Genomic Research Solutions. Over to Sanjay Gupta, sir.
Thank you, Dr. Ajit, and thank you all the chairpersons for being here. Preeti, she's the great champion of gestosis, and so we are very close. Well, when people see this topic, and I'm sure when you saw this topic, you must have thought, well, I'm an Afghani person. What has I got to do much about it? And this is something fancy that developed countries should talk about and do something. But believe me, if you care for your children, and I'm sure you do, and especially if you are at my age and you care for your grandchildren, this is something that you need to listen, and not just to listen, think and worry that can you not do something about this particular problem. So let's start with this. I'm sure you recognize this planet. You know that we had an impact on the environment. We have managed to acidify world's oceans. We have managed to dissolve much of the coral reefs, the beautiful ones as you see here. We get violent hurricanes and deluges of rain. We get wildfires. We have changed the world's atmosphere and environmental drastically. And what has this done? This has actually, created the changes, and this has led to creation of huge amount of toxic environment around us. Well, now we have the scientific evidence which says that all this toxicity affects the pre-pregnancy and prenatal exposure. And that can have an effect on a reproductive health for the future generations. And the toxic environmental agents can range from population-based exposures that we just saw, air pollution, water contamination, but to be very specific, individual exposures such as personal care products that we'll be talking about and the various kind of packaging, and the food packaging and everything that we encounter in a day-to-day life affects, all these issues. So what do we know now? There is a surge in global chemical production. Global chemical production is projected to grow at a rate of 3%. So that means it's going to double from what it was in 2000 to 2024. And we talk of global warming, but do we know what is global warming? According to NASA, average surface air temperature has increased from 1950 to 2020 by 2 degrees centigrade. So you'll say, wow, what is 2 degrees centigrade? You know, every day it goes up by 2 degrees centigrade. It's now quite cold here, but it makes a difference, you know, when it comes to global warming. And all put together, the fetus is vulnerable. And that is what it matters to all of us. There are windows of tissue plasticity during pregnancy and in early life. And now the studies have shown that they may occur due to toxic chemicals, environmental pollutants, and maternal life and lifestyle changes. And what are these changes? These are epigenetic changes. What do we mean by epigenetic changes? That we all come with our own genes, but whether which genes are going to be expressed depends on the epigenetics, and that in turn depends on the environment that we are going to talk about around us. And that's why they're important. So if we take the critical periods of vulnerability, look at this, you know, blastocyst, embryo, fetus, infant, child, right up to adolescent, you know, all this is going to, you know, affect in various different ways. In the gamete quality is affected, embryo development is affected, puberty, you know, timing is affected. We see that, you know, every day in our practice. And given the intrauterine gestation is critical and particularly susceptible window of human development is there, we as obstetricians, we have to be in the forefront. We are the ones who can actually tell our patients, make them aware and decide what actions also can be taken. And that's why we need to be knowledgeable about all these toxic environmental agents. When you think the toxic environmental agents are not around us, they're absolutely there everywhere. You take personal care products, food packaging, household materials, as well as air and water. And what is again important is, you know, the pharmaceutical at least are tested, you know, when the, you know, companies bring the products in the market, they have to be tested. There have to be certain standard mentioned, but most environmental chemicals have entered the marketplace without comprehensive and standardized information regarding their reproductive or other long-term side effects. So what are these? You know, there are a lot of examples. Endocrine disrupting chemicals. You will say, what is this? You know, why do I need to worry about it? But they are there in our, you know, everyday surroundings. You know, there are these environmental contaminants, then plasticizers, BPAs, you know, pesticides, parabens, and sanitizers. And you will be surprised where we find those. Air pollutants, of course, we know of, and heavy metals. And how do we get exposed to those? Ingestion, inhalation, and of course, transdermal contact all matters. So you take our patients right from young girls, you know, then the young adults, fertility, pregnancy, everything is affected, decreased fertility, increased miscarriage rates. We are seeing now, you know, endometriosis, you know, more. We are seeing, you know, infertility more. We are seeing asthenozoospermia more in, you know, the males. All this is related to the environment. Even we are seeing cancers more, and that also actually matters, you know, when it matters, you know, all these things that we do. And there is a lot of evidence for this. You take, you know, now, you know, go for searches on the net, you will find that thousands of papers have now come up, but we still worry about what can I do and what should I do. But temperature rises with global warming could have major implication on perinatal health. This is what it says. Then ambient fine particles matter, PM 2.51. We know every day there is on TV, we say what is the level of pollution in Delhi and everywhere. So the exposure is for risk factor in preterm birth. So that's why we are getting preterm births more, we are getting repeated pregnancy losses more. And we think that, you know, we can make a difference, but not unless we, you know, try to change this environment around us also. So abundant research evidence, all these papers will keep on telling you that at every aspect of women's health, these toxicants matter. Then how do they really work? Let's start from workplace and occupational exposures. So the employment sections are very important, including agriculture, manufacturing, dry cleaning, and look at the last one, especially the healthcare. We don't realize that we are, deal with biologics, radiations, and so on, and so we ourselves are, affected by these occupational exposures, and that's why questions and counseling about environmental exposure should be included in the patient history during pre-pregnancy visits and prenatal care. We have to ask them, if she comes to you with bad obstetric history, or if she comes to you with, probably possibility of cancer or infertility, to find out, is there any other reason for, this? Then food-related exposures, patients should be advised. We know that, large fish, especially from the sea, contains high levels of methyl mercury, but artificial transplants are, everywhere. The snacks that we have, they contain a lot of artificial transplants, especially the way they are prepared commercially in our country. Then polycyclic aromatic hydrocarbons, grilled and smoked meats are high in pH, and which can increase the risk of cancer. And of course, added sugar. Dr. Uday just told you about the, this ketoacidosis and diabetes and everything, and that's where it actually starts. Then leave aside all this, but whatever the personal products that we use in everyday life do matter. And especially when it take to, some of these toxins are there in products marketed to make people fair and lovely, particularly the skin lighteners and hair straighteners, which are used every day. They have been found to contain mixtures of endocrine disrupting chemicals like parabens and phthalates. But these chemicals often are not even listed on the labels. Now, these snacks appear extremely, mouth-watering. But believe me, they can all contain parabens. And parabens can lead to a lot of trouble. They can cross placenta, they can accumulate in blood and of the growing baby. 94% of newborns have parabens in their blood, and more than half have more than their mother. So, and prenatal exposure can lead to learning difficulties and autistic behaviors. And that's why in Western countries now there are so many autistic kids, and they're worried about this autism now. Many of our patients, also, keep on worrying that, and this autism is definitely on the increase. Now, soaps we use for cleanliness and, sanitization and everything. But remember, the overuse of the soaps also can create trouble. Triclosan, look at all the, toxic chemicals these soaps also have. So whether to use them or whether we should traditionally clean or maybe use them sparingly is an issue. Most important thing for, our patients, here, the butylene, glycol, lead, mineral oil, coal tar, this is there in the lipsticks that you all use. And believe me, it is calculated that if you use lipsticks for a lifetime, then you consume as much as 1.5 kg of lead, through that lipstick, this thing, and that can lead to even, precancerous situations. Toothpaste, again, toothpaste is supposed to keep us, our mouths clean. But look at this, triclosan, it's linked to concerns over antibiotic resistance, used to create foaming action. Aspartame causes, methylene toxicity. Plus, there are good bacteria in our mouth, which are called a good microbiome, which is destroyed by, many of these toothpastes. And maybe that's why our traditional cleaning methods probably are better than, what we use now. And of course, there are regional exposures. If you are from Delhi, you have to worry about the stubble burning. If you are next to any river, leave aside wonderful, riverfront here, but in most of the other river, you see the water pollution and domestic smoke. Of course, again, it is now reduced by the Ujjwala movement, but where gas, this thing are provided to everyone by the central government. but it's still very much there. So why these are important? Because the importance of early start applies to virtually all body systems. Adverse condition in early life can have lasting effects on all aspects of growth and development. And these very early effects on both structure and function shape our physiological, immune, metabolic, and even psychological behavioral response patterns to the environment, and can have lifelong effects. Most importantly, these effects can influence our susceptibility to diseases decades later. So what are these epigenetic changes? Contrary to common understanding, we think the genes are there, the genes will do whatever is our fate and we can't change them, but they don't act alone. The genes and the environment act together, and sometimes the genes may remain the same, but they may or may not be expressed, and that's how these environment becomes very important to us. So there is also evidence that epigenetic changes can be inherited. This means that the experience of parents or even grandparents can be transmitted across generation and contribute to non-genomic transmission of disease risk across generations. And that's why I said what you do is important not to your children, but also your grandchildren too. So, when parents have been exposed to adverse experiences like undernutrition, environmental toxins, abusive behavior, and social stress that have produced changes to their epigenome, these changes can be passed on to their children and with powerful effects on their metabolic and cellular functions. And this occurs because the children receive the genes that are in active or switched on state rather than dormant or switched off stage. Thus, the long-term consequences of adverse environmental conditions during first 1,000 days may not be limited to one generation, but may lead to poor health in generations to follow. And even if these individuals develop in optimal conditions themselves, so that's why environment is so important to us. Take maternal nutrition, for example. Junk food can affect, and that's why traditionally, if you see always, in our older people used to say that a pregnant woman should take care, should particularly take proper things. They had some wisdom, their own wisdom, which we have done away with. We think, nothing is important, but the junk food does matter. Maternal smoking, it is seen that alteration in the fetal DNA, methylation is there, and especially this AHR pathway, signaling pathway changes, and that's why you get smaller placenta and FGR. We will talk about alcohol consumption syndrome, and that again is related directly to changes in the fetal epigenome. Exposure to endocrine disruptors, I already mentioned to you. But so can we make a difference actually? And yes, we can make the difference. And how do we do that? They did actually, close down the coal and oil power plants in California, and that actually they saw, and this is a scientific research, that the preterm births were reduced. In Scotland, public smoking was strictly banned, and that reduced the preterm birth in Scotland. And that's why Intergovernmental Panel on Climate Change is now getting very active, and they're saying that change has to occur. That's what this recent Glasgow COP26 conference was all about, about the positive actions that we have to take, like recognizing the emergency, accelerating the other actions on carbon dioxide and moving away from fossil fuels. Forests are to be expanded, methane is to be reduced, and the cars should be now zero emission cars, and that is what at least been decided in this COP26 Glasgow meeting, and hope people have awakened to it and will take action. But moving forward, what is important to us that now so many animal models are showing you the effects. So we have to take the cues of this, and we have to tell our patients and our colleagues, our relatives, that it's time that early life supplements of certain foods can also be beneficial effects on developing fetus. Now, if you're somebody elderly like me, then it's important for you to look at this, because even aging, can be affected and halted to a certain extent if you go for these foods like, these what we call epigenetic diet. Is these include isothionates in broccoli, genistein in soybean, resveratrol in grape, ascorbic acid in fruits, folates in green vegetables, and DHA in almonds. So there are epigenetic diets which can actually improve your health also, and in turn that will improve the health of all your family. So this will appear very simple, advice to be given to the patients, but we have time to give this advice to our patient? That's what we have to think, and even to our, our family members. These are very, very simple things, most doable things, but we must tell them that this is important and please do that. It doesn't matter if you don't give any curative treatment, but advise this preventive treatment, and this will go a long way. So in conclusion, what I would like to say that it is important for obstetricians to be knowledgeable about toxic environmental agents in relation to environmental health risk assessment, exposure reduction, and clinical counseling. We as obstetricians should include questions about environmental exposure in the patient history during pre-pregnancy visits and prenatal care. Typical elements of an environmental health history include assessment for exposures from workplace, home, or recreational activities, and it will be beneficial to integrate environmental health into obstetrics and gynecology training and practice. And we should vociferously advocate for policies that will reduce harmful exposures and protect the health of pregnant women and their children whenever and wherever we can. And fortunately, our new FIGO president also has taken this as a theme of the next 2 years. And I think we all have to actually heed to that, wake up to this idea that no, we can change things around us, and that is going to benefit our children and our grandchildren. So thank you very much.
Thank you, sir, for the excellent thought-provoking talk. Even though scary that we cannot eat, but there are the concept of epigenetics and how it can be transmitted to the future generation, and even the use of this epigenetic, how we can manipulate it so that it will be useful for the future generation.
We are worried about lipsticks.
So lipstick manufacturers will have to change.
Yeah, thank you so much, sir. Thank you so much. It is always pleasure and honor to listen to you. Thank you so much. If there are any questions, we will take it at the end of the session. So with this, we come to the next talk, and it is my privilege and honor to introduce our Vice President of FOXI, Dr. Bipin Pandit, sir. He's a direct Mukund Hospital, past Executive Council member of Maharashtra Medical Council, past President of MOGS, past Joint Secretary FOXI and Treasurer AICOG Mumbai, past President and Trustee of Association of Medical Consultants Mumbai, received Lifetime Achievement Award from AMC, Trustee and past President of Association of Fellow Gynecologists, Committee member of Indian Education Society, many publications to his credit, and he's a wonderful orator. And after listening to these wonderful talks, now it's a time to hear to Dr. Bipin Pandit how to protect ourselves from the mob violence. Thank you so much, sir. Thank you.
Thank you very much for a kind introduction.
Thank you so much, sir. So he will be talking on mob violence, how to prevent and protect. Thank you so much.
Thank you. At the outset, I would like to thank Dr. Alpesh Gandhi and the team of Ahmedabad OBGYN Society. I don't know whether Dr. Sanjay Gupta's lecture was more scary or mine is going to be more scary. This medico-legal word was absolutely unheard of. It's okay. This medico-legal word was absolutely unheard of when I started practice in 1982. Today, we are all troubled because of this, and every day we think that something might happen. And doctor bashing has become a favorite pastime. Today, we are bogged by all these things: attack on doctors, rising cost, illogical regulations, and medico-legal cases. These pictures are very scary and unfortunate. And it is not only the physical violence, it is social, verbal, and so many violence attacks which we are facing today. Dr. Sanjay Gupta and myself, we were in Maharashtra Medical Council. We had so many cases of social abusing. Look at these last 4 lines and read them carefully. People are going to any extent to abuse the doctors, and this trend is very, very scary. So what are the reasons for attack on doctors? These were not heard 30 years back, 40 years back. Why is it happening and the incidents are increasing? The media, the internet, television, newspaper, magazines, people's expectations have gone high. Everybody thinks that however sick or old patient is, he has to come home very safely. Is it because of increased media coverage, both electronic, print? Is it because of, they think that, because of the TRP rating, the media is doing hyper things. I remember one incident when one gynecologist left a mop during the operation cesarean, and the another gynecologist, which is another problem, opened the abdomen, took out the mop and showed everything. She called the media. The TV people came with the camera. One of the Hindi channels said, patient ke pet se tawaliya nikala. And it was shown, the news was shown 38 times. This is what is happening. And these are the reasons why there is a distrust. Even the movies, you have seen so many movies in Satyameva Jayate where there's a lot of doctor abusing is going on. Patients are thinking that today doctors are projected as villains in the movies. So that's why there is a reason for distrust between the doctor and the patient. Politicians and so-called social workers, for their personal benefit, they instigate people to attack. So what are the provisions in the law? How do we prevent this violence, and what we can achieve and what we can do as an individual, as an association? There is a Medicare Act of 2010 for protection of doctors and clinical establishments was made to prevent crime against doctors and their properties. At present, 19 states have passed this act state-wise, but this implementation of law has not become central. During the pandemic, only one act was passed. So you know that no attack against doctors will be tolerated during the pandemic, but otherwise there is no central law. Actually, if the 6 states concur for such an act, a common act can be passed in the parliament. So we are fighting for this. In fact, we had made the health minister at the central level. We made the health secretary. Their answer was, if we pass this law against the doctors, why not against the lawyers? Why not against the chartered accountant? Why not against the government officers and so on and so forth? We need to protect everybody. So this cannot be, you cannot be discriminated. I talked about antisocial element. So we should demand that the changes should be made in IPC and CRPC, similar to changes made to prevent crime against women. Because even in war, hospital doctors and paramedics have immunity against the attack. So we need special protection because we save the life of patients and community in general. So what is this act? Basically, the punishments are very severe. There is a 50,000 fine, 3 years imprisonment if you destroy the property or harm the doctor. Double the cost is recovered from the damaged property, and it's a cognizable, non-bailable offense. Yes, all are good things on paper, but the implementation is very poor. And there are reasons, because the police itself is not aware of it, media is not aware, public is not aware, and many of you are also not aware about this. This is one reason. And secondly, we have not taken any measures to publicize this. In one case of Panvel, sir knows that the bail was refused because of we made a lot of efforts at the police and commissioner level. But otherwise, most of the culprits, they get bail and they are scot-free. And what happens to so many cases who are booked and not given bail? The doctors only get scared because they have to practice in the same area. So they cannot afford to fight against the gundas and the so-called social workers to attack their properties. Very rarely you see a news like this as a breaking news. And this is only one case which was punished and Saza was given. Otherwise, I don't remember or I don't know any case where it has gone to the logical end. Now, is this a global phenomenon? Yes. Even in China, doctors have been stabbed. In USA, they have been gunned down. So, in general, it is happening a lot all over. And at present, there is no solution found to protect us. So this was one of the thing in British, this thing. Many cartoons are drawn and many this thing, but still there is no solution. The biggest problem here is communication. Lack of communication can lead to unanswered questions, anxiety, aggravation, anger, advocate searching, social worker help, media help, medical legal problem, and ultimately, if nobody listens to the patient's relatives, they resort to the doctors, violence. So we operate under closed doors. So only another doctor can cause harm to other doctors. So we need to be very careful when we utter any word. When we talk bad about other doctors, we should try to avoid this. This communication gap with the patient and the relatives is extremely important. And we all feel that we are excellent in communication, but we all fail sometimes. You may be excellent surgeon, but if you don't have communication skill, it's a failure basically. Today, it is extremely important to learn this communication skill. And in communication skill, the body language is important, the tone of your voice, the how you talk. Your words carry very little meaning, and your facial expression extremely important, because that connotes, even you move your shoulders like this, it gives a different meaning when you talk to the patient and relatives. Look at this, the facial expression is extremely important. It says 1,000 words, then yes. So what doctor is supposed to speak? Suppose there is a mishap. How to prevent violence? Breaking bad news is a real art, and handling the aftermath of the operation theater mishap requires a protocol has to be there in place. We cannot think that way, that time, what to do. We have to have standardized protocol in your nursing home, in your hospital, in your institution. When you explain to the relatives, suppose the patient has died in the, or serious or in coma in your operation theater, never go alone. Create a team right in the beginning. If something happens, what is to be done? 1, 2, 3. Who is best to communicate with the relatives? So this has to be learned, and many a times patients' relatives, they provoke you, and the situation get aggravated. So you have to keep cool, calm, and if you are not good in communication, like many of us are not good, then you need to have somebody in your hospital, institution, who is specially trained to talk to the relatives and calm them down. So here it's very important that you talk less and say more, because words reflect your attitude. Words can heal. Sometimes with anger, or we also get provoked and we say something that triggers a problem. People really do not care how much you know unless they know how much you care. So be concise, be brief, and use short words, sentences. Sometimes it is better to keep quiet and listen to the relatives. That will help to calm them down and not provoke them. So it's really a testing time for all of us breaking the bad news. And I'm sure with all of you having heavy practice, this incidents either you might have experienced or you might experience in your lifetime. Yeah, I wish you don't have to, but yes. Both patients and doctors stand to benefit if the doctors are better trained for this difficult task. The time is short, that's why I'm rushing to the thing. So just to give a few take-home messages. So there is a time to speak, as I told you before, and there is a time to be silent. Many a times there is a mishap, and then just listening to the grievances of the relatives and patients will calm them down. Even if they are arguing, you just keep quiet and it is better to be silent than say something or have a bad tune. I don't wish to have this uniform for me afterwards. What can the doctor do when they are subjected to violence from the patient's relatives? These news today, which were not seen previously, like gynecologist assaulted, face blackened, hospital ransacked, they were not common in, today they are becoming quite common. And today they don't spare municipal government hospitals. Small nursing home, of course, are the target, but even the big institutions, they are attacking the RMOs. So what are we supposed to do? We had a lot of discussion. Dr. Alpesh Gandhi has started a lot of things. And at the association level, what can we do? Now, if there is a violence in Karad or Sangli or Ahmedabad, I cannot do anything from Bombay, right? So at the local level, you need to have this small team, what we call task force, and train them to help each other. Today, we don't have to compete with each other. We have to have unity among ourselves. Now, even Ahmedabad and Mumbai is a very, very big city. So if I have to form a team, I have to form a team in Andheri, where I'm practicing. The Kothurud will have one team, Ahmedabad, one sector will have. So there is a rush team. If there is an imminent attack on me or my hospital, I need help. I need help. Even if 6-7 doctors, my colleagues, come and stand next to me, it's a great thing. Legal help, FIR, everything is all okay. But today, the time has come to protect yourself physically, and that's very, very, very important. Rest of the legal help and advice and everything association can give. Another thing I want to tell you is at the local level, you must have panel of lawyers. Identify good lawyers, which Dr. Nikhil Dattar is here. We have to have good lawyers panel at every district level or local level. Task force. This is what I told you. We must have task force and try to help each other in case of distress. For example, if there is a problem in Andheri or Goregaon, local area, even the traffic is very bad. So to reach that, it's going to be very, very difficult. And we need to use modern technology like mobile, WhatsApp, to communicate with people. And we have formed 3, in case of distress, 3 codes: yellow code, red code, and green code. Green means all clear. Yellow means come to the incident site, but don't rush hurriedly. It should be given in cases where the victim doctor is apprehensive of the situation and he needs moral support. Like once I got a call from Andheri that patient's relatives are from one political party, I won't name them, and they're going to bring the morcha to my hospital. So please come. Now this is something code yellow. I'm just giving example. Code red, of course, and very little time is there to respond to code red. And code green, if everything is okay, you can. So this thing has to be, you have to decide among yourself in your task force. Of course, I don't have to tell you, never give a fake call. CCTV cameras are extremely important because that's a proof. Alarm bell and hooter at strategic place, you must keep the button in your consulting room. If something happens, a big hooter can deter the thief and the attackers also too many times. And we have done in Mumbai a tie-up with hotline. This is a security force where, and I have experienced it myself in my hospital. My hospital is on the main road. So we get so many cases like Chakumari and bullet and talwar and whatnot, many times. Day before yesterday, we got a case with rickshawala, his throat was cut. So such time the crowd comes. So that time you need little protection otherwise also. So this hot tops line, if we call, they send within 8 to 9 minutes on motorbike to what I call bouncers. So even if they stand next to you, even if you have a security officer in your hospital, he will run away first. By the time you call police, it is very late and they are busy with Ganpati Bandobast and Palana Adhikra. They will not come in time. So basically you need some moral support with you. So even if they stand, and they stood next to me and I felt little comfortable. Doctors Association, of course, this protocol has to be formed. And we have done one protocol like this. You can take a photograph. This I had made when I was a chairperson of the Violence Against Dr. Foxy cell. So what is to be done? This is a basic thing. You can improvise on it as per your need, what you want to have. And this is what we have done, what is to be done. And most of the important, your staff. Your staff has to be trained properly. Most of the problems occur because of staff. If there is something wrong in your operation theater and patient is serious, staff is going in and out of the operation theater all the time. And the relatives outside, they ask, क्या कुछ हुआ है, क्या हुआ? तुम्हारा patient बहुत serious है. बचेगा नहीं. Anything nonsense they talk. So they are not supposed to talk anything. Doctor से बात करो. Because that gives a very bad impression or that triggers the problem. This is one in Rajasthan, they put IMA give this. This is also worth doing it. It's a nice explanation. We can put it on every nursing home. And Alpesh sir, Foxy can do it. You can print and distribute it to everybody. Kanuni saza, everything is written. How far this gives impression to the patient and prevents violence, I do not know. Police, I don't know. My experience is very bad with police as far as help is concerned in these cases because they come late. And I've seen in one of the Jogeshwari case, even the police was hit. And trust me, in Mumbai, even the lady doctors are not spared. In one case, in one hospital, Ruby Hospital, the female gynecologist was pulled by the hair and bitten very badly. So things are getting bad to worse. I'm not here to scare you, but this is a fact what we have experienced in Mumbai. FIR and all is all legal, that can be explained. Most important is keep lawyers panel and whether doctors should form a pressure group in their town or district with politicians, media, your district-wise, area-wise, basically make friendship with these so-called social workers and politicians. You can't have enmity or this thing, this is the best. They can also help you in case of distress. And media is absolutely against us. Another doctor can do maximum harm. So please be careful when you say something bad. Don't say bad about your neighbor doctor. Say something good. Unity is not only strength, but it's a very powerful weapon. We must. You see lawyers. Can anybody fight them? They have tremendous amount of unity. You see chartered accountants. They are also professional like us. And you see our body or association or our district. We don't have that much unity. Sad to say, yes. My advice. If you feel unsafe, always keep an exit door and run away, be underground. No, I'm not joking. This is what absolutely serious. Your life is more important than anything else. Most of us, we don't have exit route in the hospital. Create one. And what is the after effect of violence against doctor? Doctors' children are not becoming doctor. Thank you. Have I scared you enough? No.
Thank you, sir, for a very eye-opening lecture. I'm in a real dilemma. Dr. Sanjay Gupta said we have to have a stress-free life, and this shows that we are 100% stressful.
No, the time is less. Otherwise, I would have given you more stress.
But the most important thing is that we should be very polite. We should speak less. We should be empathetic. We should counsel them well. And we should have friends like Dr. Dilip Balke and MC Patel sir to save our skins.
You take interview of patient, they will say doctor community is the most rude community. They don't have time to talk. They don't have time to explain. They are so busy. They say, "Our assistant se baat karo." I'm not joking. Now things are improving. Yes, But, you know, they don't have time to talk to us. In USA, they did a survey by American Association that when they said that if you talk to the patient for minimum 18 minutes, they are satisfied. Here, how can you talk for 18 minutes? Thank you.
Thank you very much, sir. And I request Dr. Gupte, sir, please come on the stage. And Dr. Alpesh is here. And Dr. Uday Thanawala was our first speaker. We can take a nice group photo. Come. Sorry. Very nice. Come, let's keep this down. Yeah. So I think with that we will conclude this session, and I hand over to the Master of Ceremonies to begin the next session.
Thank you, ma'am. All right, we're moving on to session 6 for today. The session topic is obstetric HDU or obstetric ICU, the vital backup. For this, may I invite to the stage the chairpersons, Dr. Tushar Shah. Dr. Deepa. And Dr. Radha. Is ma'am here? Just to introduce the chairpersons for today. Sorry. Dr. Tushar Shah is the consultant obstetrician and gynecologist here in Ahmedabad. He's the ex-associate professor of OBGY at NHL Medical College and is the winner of Foxy Corion Award 2002.
Good afternoon, friends. Now, our next session is very, very important to improve the obstetric care in this country. Obstetric HDU and ICU, which are a very vital backup for each and every delivery. I just want to tell you one thing, that except in India, almost all over the world, deliveries are conducted in a hospital where ICU and ICCU are available. And that is reason for reduce in maternal morbidity and mortality. In our country, still we are not having a proper setup of ICCU or ICDU in our normal pregnancy backup. So today we are discussing on that problem. Our first faculty is Dr. Jyoti Bindal. She will speak.
Not here.
Okay. Okay. So Dr. Jyoti is not here. So we'll start with the Dr. Prakash Mehta. He will tell us about the role of critical care in obstetrics for achieving SDG target in 2030. Dr. Prakash, please. Biodata. We have to biodata. Okay. Dr. Prakash is a professor and head of the maternal fetal medicine at Bhagwan Mahavir Jain Hospital.
Very good afternoon to you all. I think HDU is something that is really important, and we definitely need to know a lot more about it and ensure that every hospital, however big or small it could be, can have a support of an HDU in their place. Now, in today's topic, we are going to talk about the laboratory investigations that are required in HDU. What do you do? How do you do? How often you do? And what is the importance of doing these investigations? Now, once a patient comes to an obstetric HDU, what we need to do, we initially do a bedside clinical assessment. a thorough daily review of the investigations and monitoring. But at the same time, we others need to have a detailed knowledge and understanding of the data, and there have to be an important training and practice part for our day-to-day management of patients in HDU. Now, we should never forget that the normal physiological changes of pregnancy affect almost all investigations, and therefore, unless you're careful, the underlying disease may be improperly. It could be overdiagnosis or it could be underdiagnosis. Now, why do we need the investigations? Because the strategy for interpretation of the lab values will benefit more in a contextual, probabilistic kind of an approach. And we should never forget that pregnancy alters lab values. There is nothing what your physician colleague or your intensive care colleague calls it as normal will be jolly well be abnormal in our setup. There are many causes why the patient is there in an HDU. There could be an obstetric cause or it could be a non-obstetric cause. And all your investigation should be tempered according to what is the possible diagnosis that you have come across. Now, the next question is why test? Why should we test? So screening, identify asymptomatic abnormalities. Quite often a hyperkalemia or a hypoglycemia is not identified before. Or it could be for a homeostatic purpose on a recurring basis to ensure that the levels of these tests remain within the normal range. It could be for case finding, like an ITP. You have a patient who comes in with thrombocytopenia at 36 weeks, platelets are being done for the first time, and you find that the platelet count is 6,000. Now you're worried whether you're dealing with an obstetric cause for thrombocytopenia, like health syndrome, or is it due to some pre-pregnancy cause, which could sometimes possibly come or present for the first time during pregnancy. And ITP is one such cause. Believe me, I get many cases of ITP and health syndrome, and every time the patient is referred to me late without any previous values of platelet count, I invariably have to literally break my head to determine whether it is ITP or whether it is health syndrome. We know that health syndrome requires delivery. ITP, I can be conservative. I can take her to 36, 37, 38 weeks, and I need to give her steroids so that her platelet counts improve. Whereas health syndrome, immediate delivery. So it's very, very important that we do our investigations properly and serially. Now, diagnostic. If there is a severe blood loss, or if the patient has got some kind of a fever, we do our test for diagnostic purpose. You could do your test for therapeutic purpose, like for treatment of anemia or response to the drug treatment. And the utility of the test and its potential to influence the further management. To give you an example, yesterday, all those who were in the workshop, I told to you about a patient with PBM and pregnancy who had come. I discussed regarding that. Now, we have been following her up with the liver function test. She's on AKT4, rifampicin being one of the drugs. Now, the moment we have started doing her liver function test, we find that the liver enzymes are gradually going up. Today, they have already reached 150, 160 of SGPT, SGOT. So, this kind of, it gives us a follow-up. Supposing tomorrow it becomes 200 and day after tomorrow it becomes 300, then I know it's time to stop rifampicin. So that's the kind of help I get with my investigations. Now, the test tool, there is a mnemonic called as eye test. Now, the eye test, there are various factors. We start with the eye. Is this condition preventable? T, will the test tell us about what is the diagnosis or what is the likely outcome? E is your examination. Does your physical examination contribute anyway to understand the investigations that you're doing? And finally, the clinical signs and symptoms would be the S. So you analyze the test result and treat based on what you find in the test. So eye test is one of the, it's a common tool that we use. Now, whenever you get the patient into HDU, we need to triage them. Now, when we do to triage them, we need a set of profiles. That could be hematological or a cellular profile, biochemical or a metabolic profile, a microbiological profile, and of course the radiological profile also have to be done, which is not the topic for today. I'll be discussing only the laboratory part of it. So you have to, it can be used for monitoring or for diagnostic. And you have prognostic tests and we have the point of care tests. Point of care tests are now becoming more and more important because you get it immediately within a few minutes at the bedside. Now, the next question comes is why there are so many different tests and why they are so often. Now, we need to remember that to identify, optimize, and alter treatment, we need a wide variety of tests in the various body fluids. Again, to come back to the example of my TBM patient, which I discussed yesterday, unless we did the CSF, where we found that there was a severe drop in sugar and a lot of lymphocytes present in the CSF, the diagnosis was a little confusing because a patient was already being investigated for rickettsia, for EB virus, and so on. So that is why you need to do certain body fluid tests. And you need to do them definitely on admission and then on a daily basis. You have to do it on a daily basis, but some tests need to be repeated 3 or 4 times a day, depending on circumstances. Now, some of the common tests, we know the hemoglobin and hematocrit. Now, please remember, if you're not doing hematocrit, which is what I found when I've gone, almost in any city in the country, is that hemoglobin is done, but hematocrit is not done. So you just can't do only hemoglobin. It should be with hematocrit. And we know the normal ranges. I'm not going to go into details about it, but it helps us to evaluate the severity of anemia or the blood loss, and a transfusion trigger can come in based on it. Now, for obstetrics, the basic transfusion trigger would be less than 8 grams. Okay, and now decrease in the hemoglobin and the hematocrit can explain the subjective dyspnea, pallor, new blood loss, or derangements of oxygen delivery. You do one test, you get an idea about all these 4 factors that are happening in your patient. The WBC count is absolutely important because what is important is the WBC count should include both the total count, that is leukocytosis or leukopenia, and the notation of the type of circulating WBCs, whether it is polymorphs, it's an immature PMN, are there band cells, are there a lot more lymphocytes, and so on. These factors are all very important. And of course, we all know the causes of leukocytosis, leukopenia that could occur in an HDU. But what we need to remember is that WBC count is non-specific and relatively insensitive. In pregnancy, the WBC count will definitely increase. And if you have a syndrome like HELLP syndrome, also you could have a leukocytosis coming in these patients. So what is important about is that the absolute level is less useful than the trend. In any investigation in HDU, trending is the most important thing. What I do today and what I do maybe in the evening or what I do tomorrow morning and what is the change that is occurring is more important. Now, a differential count indicating a shift to left increases sensitivity. Whenever I've gone as a postgraduate examiner or even a fellowship examiner, I take them to the absolute basic. I ask them just about WBC count. Tell me what is shift to left and what do you understand by it? Very unfortunate that many of the people don't understand what is the shift to left, because the shift to left indicates that more and more new polymorphs are coming in, which in turn indicates that your infection is very active. So that will help us to manage our patient in a much better way. Platelets, of course, we know are very, very important for us. Now, there are certain rule of thumb. Doesn't mean it is all the time correct, because if the platelet count is greater than 100,000, there would be generally no increase in the bleeding. Between 59 and 100,000, you will have a minimum bleeding unless a platelet dysfunction is present. Unfortunately, most of us do not have facility to identify if a platelet dysfunction is present. We generally go only by the platelet number. Now, 30 to 50,000, there will be an increased bleeding with surgery or delivery. And if it is less than 10,000, there would be a life-threatening bleeding. Now, there are various types of thrombocytopenia. Just because your lab tells you that the platelet count is 40,000, your work doesn't end with it. You need to identify if it is a pseudothrombocytopenia. We'll go in the next slide. Whether it's a gestational thrombocytopenia, is it an immune thrombocytopenia, or is it a thrombocytopenia of our favorite disorders like hypertensive disorders of pregnancy or AFLP or HUS, or whether it is due to infections. And finally, is there bone marrow failure occurring? Our patients are women. I keep on repeating that our patients are women. Our patients are not just pregnancy. Okay, so as a woman, she can get any kind of disorder which could come or which could be identified for the first time during pregnancy. And the peripheral smear is absolutely important. Quite often, again, this step is missed out in most of the places. Please ensure that a peripheral smear is done. Now, this is an example of pseudothrombocytopenia. Now you can see that there is a clumping of the platelet count. And if you're using an automated machine, the automated machine cannot count these platelets and it will just miss it and you get a pseudo thrombocytopenia. So the answer to this is, if you find that the platelet counts are low, ask for a manual platelet count. Old chamber, test that we are doing, the Newbar chamber, and count the platelets manually. Okay, and of course, you'll be able to identify the parasites, or you will be able to see the toxic granules of infection and so on. Coagulation test tells you about the abnormality of the clotting factors. It's very important. We have to do an INR with a PT, a PTT, a D-dimer, a fibrinogen, or an FTP. Now, please remember that the deranged coagulation is very common in obstetric HDU. So we need to identify and treat this very well. And remember, no single test establishes the diagnosis of DIC. You need the battery of tests to identify whether DIC is present or not. And again, a serial clotting assays are more useful. And whenever you find that these tests are abnormal, repeat them every 6 to 8 hours. Now, if you have the various lab parameters and your patient is bleeding, then if only PT is abnormal, then it indicates a factor 7 deficiency. Now, it could be an inherited kind of a factor 7 deficiency, or it could be a vitamin K deficiency, or your patient could be on warfarin. If APTT only is deranged, then you must think in terms of factor 12, the kininogen, and the other smaller factors. If both PTT and APTT are abnormal, then we need to think of mainly factor 10, factor 5, factor 2, and fibrinogen deficiency. In these patients, look out for a liver disease, look out for DIC. If there is a prolonged bleeding time, it indicates thrombocytopenia or a platelet dysfunction. And if all tests are normal and still your patient is bleeding, think of factor 13 deficiency or think of increased fibrinolysis. Now we have certain bedside tests which we could do, like the bleeding time, the clot retraction test, the clot stability test. Quite often, even though I'm in a tertiary care center with all kinds of facilities available to me immediately, I still do bedside tests. Just draw the blood, keep it in a tube right next to the patient, and in the next 10-15 minutes, you will really know what is happening. So to identify platelet dysfunction, we have a test called as thromboelastography. Still not very commonly available, but I'm sure in future we are going to see more and more thromboelastography being done. There are of two types, what is either called as a TEG, or it is called, the other type is the thromboelastometry or the ROTEM. Okay, now it helps us to reduce the morbidity in the patients with bleeding. Now, the next common confusion is D-dimer. If you are dependent on your physician to look after these high-risk patients, they will invariably order for a D-dimer. The D-dimer in a pregnant patient, the D-dimer in a post-cesarean section patient is invariably high. And in spite of whatever reason, they tend to put you towards the path of pulmonary embolism. Now, please remember that during pregnancy and in the post-delivery period, the D-dimers have to be high. So what is important is that if it is negative, it cannot rule out CVT. But if it is a positive, then you do a referral for an MRI or MRV. That is all. And you cannot recommend it as a screening test. So don't go only by your D-dimers for any further management decision. Urine analysis is very, very important. You know, we know what all we do on the urine, but for screening of systemic disease like diabetes, diagnosis of UTI, and management planning for the monitor the progress of disease and treatment. The important point is small amount of urine is sufficient for accurate testing. I'm sure all of us will be having now the bedside urine test, the strips which tell you everything in one go, and the abnormalities including infection, dehydration, abnormal kidney or liver function. All these four could be identified by the simple test. Do a bilirubin on the strip, do a ketone on the strip, do a protein on the strip, and your answers will be there. Metabolic tests are also important. Most common include the serum sodium, potassium, bicarbonate, and so on. A complete comprehensive metabolic panel should be done, including calcium, albumin, phosphorus, and so on. And assessment of electrolyte is useful to review water and acid-base balance as well as renal function. Urea and creatinine are a direct measure of how well the kidneys are functioning. I think these are how the uric acid and creatinine change from normal during pregnancy and how they differ during pre-eclampsia. So you can see how the values are, because anything in pregnancy of uric acid more than 4.5, beware. Although your lab will give you a value of 4 to 6 as the answer. But if it is more than 4.5, beware, follow up that patient very carefully. She could have a bad kind of pre-eclampsia. Blood sugars are very important. Hyperglycemia. We need never forget that AFLP causes hypoglycemia. So if you're a patient with blood pressure, mild blood pressure shows low blood sugar, think of acute fatty liver of pregnancy. And of course, you need to do blood sugars as often as required. The liver function test, the same thing, how they change during pregnancy and what are the changes during pre-eclampsia. Some values are altered. But what we need to remember is that increased ALT is more specific than AST for liver injury. So between the two, if my ALT is much higher elevated, I would be more worried than only if the AST is altered. Increased bilirubin can be due to sepsis, hemolysis, and cholestasis. So keep all these three factors in mind. And serum amylase, which we could do for pancreatitis, if the patient has got epigastric pain, along with maybe HELLP syndrome, you need to look at pancreas also. And serum amylase, we need to remember, is neither sensitive nor very specific for pancreatitis. But if serum amylase is increased, I tend to follow this patient with more frequent monitoring along with serum lipase. So this is just a chart to show how the values differ between HELLP, TTP, and AFLP. Now, there are certain special markers that we need to do, the CRP and the ProCal, which tells us about the inflammation and the chances of sepsis and septic shock coming in. Lactate is very, very important to identify anaerobic metabolism, and an elevated lactate gives us a poor prognosis. ABG is very important. You go by this simple step. Review the patient, analyze the oxygenation, assess the pH, assess the respiratory diseases, and assess the metabolic changes, and finally you interpret. So these are the ways, and you can see one ABG which I put up in one of my patients, and you can see the values, how abnormal they are, telling us that the patient is in metabolic acidosis, and definitely this patient will not do that well, because look at the lactate levels, they are grossly in the sky. Cardiac enzymes are again very important in our patients, both for sepsis patients as well as for cardiomyopathy patients, and NT-proBNP or a CKMB or a troponin 1 has to be done in this set of patients. Now, point of care test is very important. You can either do an split PLGF ratio or you could do a glycosylated fibronectin. This is a point of care test which can be done bedside. And if the value is more than 600, when it is highly positive, you know that this patient is going to give you trouble. Cultures are a part of our HTU care, and you must collect from all potential sites: blood, wound, urine, high vaginal swab, or tracheal tip. Now, no growth does not exclude infection. Culture to be taken prior to starting antibiotics, and broadband antibiotic therapies commenced before the actual results are back. Biopsies are sometimes important. This is one of my patients with lupus nephritis was referred to me as severe preeclampsia, and then somehow all the tests pointed out towards something that was more abnormal than preeclampsia. We did a kidney biopsy during pregnancy. You can do it, although you should not do unless it's absolutely required, and we picked up lupus nephritis. Now, just quickly, we go through this patient who was referred at 35 plus weeks, severe preeclampsia. She had AKI, anasarca, oblique lie, FGR, PPROM, and she also had a failed induction of labor. Now, this is the kind of abdomen she had, and this fluid that is coming out is not amniotic fluid, but it's acidic fluid. She did have a lot of bleeding when I was doing surgery. I needed to do an embolization on her, and finally the patient went home quite all right. But I'm bringing this case to show how the values change over a period of time and why it is important to do a trending rather than single value. So same thing with other parameters. Look at the way the PT has changed over a period of time and how it became normal a little bit later. The way the electrolytes have changed. Now we have done a serum magnesium level in this particular patient because she was AKI. So in conclusion, good lab support and interpretation is important in obstetric HDU care. Lab results are useful to identify organ dysfunction. Corrections for pregnancy alterations and values are imperative. Lab values are included in the SOFA score, especially the lactate. Glucose is often elevated even in patients without diabetes. Our instinct and training as clinicians is to normalize abnormal values. However, there is no evidence that this approach is correct in all cases. So don't overdo it. So remember, our HDU care is like gymnastics, and any help that you require is absolutely important. And thank you all very much for a patient hearing.
That was a fantastic, elaborate talk. Very rightly said, I think laboratory workup is the backbone of ICU care. And as you very rightly said, trending of the values is more important towards prognosis, identifying patients who are on the recovery road or who are deteriorating, and 24/7 lab workouts are very, very important in getting these patients out. And as you said, we need to repeat the tests every 3 or 4 hours to really guide us on both which way the patient is going. So very beautifully presented, sir. Thank you so much. We welcome some questions from the audience.
I think what we need to do is all of us need to strong up our lab background.
Prakash, which minimum investigation you would advise for before normal delivery without any medical disorder, or a normal cesarean for obstetric purpose without any medical problem? Which minimum investigation?
Yeah, see, the minimum that we definitely need to do a CBC.
Yes.
Of course, the urine examination and the sugars have to be done, because in spite of the fact that there have been normal sugars before, at least 3 values, 4 values, quite often you find that in the 9th month, just before the delivery, the sugar values go up. So we need to be careful about these patients, because you tend to deliver sometimes them a little early, then the baby lands up with RDS. You know, the late preterms are the most dangerous preemies, those born between 36 to 37 weeks. So we need to be careful about that. But I think just a simple CBC should be fine. But if you have a patient with pre-eclampsia, please do not deliver them without an RFT and LFT added on to this test. And when we say LFT, it should include LDH. When we say RFT, it should include uric acid, because quite a few of them are not doing uric acid. Uric acid will not give you any diagnostic idea, but it gives you a prognostic idea. So uric acid and LDH both have to be added, because unfortunately, many of the labs, when you say liver function test, they'll give you everything except LDH.
Would you advise APTT and PT in all cases before surgery?
Now, unfortunately, what happens is, when you have not done for such a patient, then APTT, PTT, and the patient has a bleeding, you're always questioned why an APTT, PTT was not done. Now, to be honest with you, in my practice, every single patient gets it, because I don't see normal patients. I see only high-risk patients. But to do a PT, APTT in every normal patient, I feel would be a little bit of waste of resources. You do a good CBC. If you see that the RBCs are normal, if you see the platelet counts are normal on the smear, and plus your platelet counts are coming normal, I think 99% of the time you would be safe. Could you come to the mic, please? I hope we have some time. I'm not delaying any lectures, no?
No, we have some time, sir. Normal values, it differs in a pregnant value. The normal values in a pregnant value values differ. So can you tell something about this? Because yesterday madam was telling that in a pregnancy, if we get PS 7.45, then we should be cautious. So the normal values differ in a pregnant lady, normal ABG value.
I thought I showed on one of the slides what are the normal values during pregnancy, but see, APTT values, that's why trending is very important in that. Because what do you mean by a normal patient? Okay, how do you know that patient is not going in for a pre-eclampsia next week? So any abnormality if you find on APTT, you definitely need to follow up that patient. Now, as I told you, we are in a country where I have to choose between investigations. I'm not talking about my own center. My own center, as I already told you, all tests are done for every single patient. But that cannot be applied generally across India, because we need to do certain tests on them and then take a decision. Supposing I've done a CBC, I find my peripheral smear is normal, the hemoglobin is normal, the hematocrit is normal. Then the chance of having an abnormal PT-PTT in a patient who is so-called low risk would definitely be very, very minimal. So we need to, prioritize our patients in that way.
I think wherever the facility is available, coagulation profile might be useful, especially in this era of litigation.
I agree, but what happens in most of the institutions, which especially, let's say a government institution, or let's say in a smaller hospital of the APTT adds on a bill of about 350 rupees. I know it's not a very big sum when there is a complication, but in an absolutely normal patient, I don't think any guideline anywhere across the world asks for it. Yes, ma'am, we have our most interested and the youngest delegate in the audience. I've been watching her from yesterday. She's always there, always listening carefully. Yes, ma'am, what can I do for you?
See, first patient had a first normal delivery, and second time she is pregnant, and she is keeping borderline, blood sugar level, borderline reports. So how many times we should do it, and what precautions we should take during pregnancy? Or whether we should, and third, whether we should go for elective cesarean or we should allow her to go for normal labor.
Okay, ma'am. If the patient has had a first normal delivery and this time she's going in for normal blood test, the first thing I would think of is whether she's going in for a health syndrome. Because unlike Pre-Eclampsia, which is the disease of primary gravida, health syndrome, AFLP, are all diseases of multigravida. More frequently seen in them. Not that they can't occur, they do occur in primary gravida, but more frequently in a multiple. So if I find abnormal values in these patients, I would definitely repeat them. What I do in my practice is I repeat every 24 hours. And to that, I add on tests like either a split PLGF or a glycosylated fibronectin. Glycosylated fibronectin could hardly cost about 800 rupees. And if the values are abnormal, you definitely know that this patient is going to go into problem. I could monitor her. So I rule in and rule out using this kind of tests. And these are bedside. My nurse does in the hospital, the glycosylated fibronectin. It's a very simple bedside spot test it is. So if we can do some such test add on, then possibly your level of stress and the patient level of stress will come down. But once a value is abnormal, I would just not put it blindly to, oh, lab has done a mistake. No, I would definitely follow up this patient, maybe repeat the test at the end of 24 hours. Meanwhile, monitor the blood pressure, monitor a urine output, which can be done even at home, and then call her back tomorrow, see what the values are now.
And what about
the type of delivery, of course, would depend on whether she's getting any complications or not, because if she has had a previous normal delivery, I'm sure this time, if the things are not that all too bad, we can allow her for a normal delivery.
Thank you.
Once again, I express my appreciation to you, madam, because as I told you, I've been observing you from yesterday, and I find that hats off to you. Thank you.
Thank you. Thank you, Prakash.
Jamnagar, Vadodara, at many places. Surat. And still practicing senior most from Ahmedabad.
Pranam, madam. તમને મળીને બહુ આનંદ થયો.
A great source of inspiration, madam.
Actually, at present, where I am working, that institution is 200 years old. One thing, it is the first hospital of the city of Ahmedabad for the female, means obstetric gynae. Then one consultant left, and I don't know what they must have done. she says, I will see that this institution gets closed. So with that circumstances, I was invited just like Dr. Alpesh Bhai, somebody gave my name. And they invited me and they said, this is the situation. Then I said, don't give my name, I will work. And I worked without giving my name. And I gave them 55 lakhs first year and completely, abolished their debit. And now since then, they are just telling me, you come as far as you are able to come. So I am going. At present, I am not. A big clap for her, please. At present, I am not operating. At present, I am not operating, but during the whole COVID period, I was always going to the hospital, keeping all the norms of the COVID, and I was carrying out the OBD work and labor duty and everything because others were not coming.
We are very much encouraged with your presence, madam.
Amazing, madam. I think I wonder how many of us can work like you. Thank you so much for that wonderful interaction, Dr. Prakash, and thank you so much, audience, for the wonderful interaction. So as we move on to the next topic, our goal for 2030 has been to reduce the maternal mortality rate to less than 70 per 1 lakh, and all of us are working towards that goal. I welcome the next speaker, Dr. Syed Hubi Ali, who will be talking to us on role of critical care in obstetrics for achieving the SDG targets of 2030. Dr. Syed Ali. It's a pleasure to introduce Dr. Syed Hubi Ali. He's an MBBS and MD Community Medicine from SAGS Medical College and KEM Hospital, Mumbai. He has to his credit postgraduate diploma in hospital and healthcare management from Symbiosis Institute of Management, Pune, and a diploma in human resources management from Wellinkar Institute of Management, Mumbai. He's a health system strengthening program graduate from the University of Melbourne, Australia, and has done certificate course in WASH in healthcare from the Center for Global Safe WASH, Emory University, Atlanta, Georgia. Dr. Ali has been working in UNICEF since 2007 in various capacities in the states of Bihar, UP, and Madhya Pradesh, and he carries an extensive field experience of RM, NCHA, and immunization. Currently, he is working as a health specialist, UNICEF India Country Office. Welcome, Dr. Ali, to this stage. The stage is all yours.
Thank you very much. And thanks to the organizers of this conference for inviting me on behalf of UNICEF. Thank you, Alpesh sir, for this. In the next 10 to 15 minutes, I will be deliberating on the role of critical care in obstetrics for achieving the SDG targets 2030. This particular slide is a gender inequality marker. Colleagues, we all know that India is doing probably good on the Human Development Index, which is a marker of life expectancy at birth, education, which is measured in mean years of schooling, and also the living standard of living, which is measured by the gross national income per capita. Although the study recently done released by IIPS in October 2021, it mentions that the life expectancy has reduced by 2 years in India, which was 70 because of this COVID pandemic. Also, we are not bad in the social institutions gender index, which measures the discrimination of females in social institutions. But the point of worry is gender inequality index, which is a composite measure of reproductive health, women empowerment, particularly measured by the parliamentary seats occupied by the females, and the labor workforce, particularly occupied by the women. Now, the reproductive health in this GII is measured by maternal mortality ratio and adolescent birth rate. Now, although the maternal mortality ratio of India has been decreasing at a rate more than the global level, the current annual rate of reduction is 5.5%. But if India really wants to achieve the SDG target of less than 70 per 100,000 live births, it has to be accelerated to reach the level of 6.1. Also, another point of worry is the adolescent birth rate. The recently released World Health Statistics, it shows that the adolescent birth rate in India has increased between 2019 to 2020 by 10.7%. Now it is currently 12.2% as per the recently released World Health Statistics 2021, although it has reduced from 28% compared to 2018. So these are the 2 points of worries for India. At the global level, two countries, India and Nigeria, contributes to 1/4 of the total maternal deaths. Now, why we are talking about this maternal mortality? Looking from the United Nations point of view, MMR particularly measures the socio-economic status of the country. It measures the resource allocation. It measures the quality of maternal and the child health care at the time of birth in a particular country or a region. Now, if we talk about India, although the maternal mortality ratio has decreased, but as I mentioned, the pace needs to improve. Now, coming to the point, the MMR of India has reduced by 61% as per the global burden of disease between 2000 to 2017, while the global reduction was only 38%. But the actual annual rate of reduction needs to increase. Now, what does this mean? It means 91% coverage of at least one antenatal care visit, which we are struggling at 80-85% as per the recent data. It means 78% of the 4 antenatal care visits. Last month, NFHS 5 was released. Still, our 4 antenatal care visits is only 58%. Now, one of the Lancet studies, it says that early registration of ANC and quality ANC care has a potential to avert maternal mortality by 25%. Although this has been done, but what about the quality of care? The government of India has introduced a program called Laksh for improving the quality of care in the labor room. Currently, UNICEF is having a partnership with Foxy under leadership of Dr. Alpesh for this Lakshya facilities. And I am pleased to share that with this partnership, before the start of this partnership, 54 of the 260 UNICEF supported facilities were state Lakshya certified. Currently, we are at 88. And with this support, we aim that by the end of this next year, at least 60 to 70% of these health facilities will be Lakshya certified. Another program Government of India has launched in 2018 was midwifery care to provide women-centered, compassionate, respectful maternity care. But still it is struggling to actually improve. And also now we have Surakshit Matrutva Ashwasan for this antenatal care. One of the studies in biomedical reports, it mentions that hypertensive disorders of pregnancy and hemorrhage are particular causes for admission in the obstetric HDUs, ICUs. This is a slide from SRS. The states towards the left, we are still struggling with a high rate of home deliveries, particularly Jharkhand, Bihar, where the home deliveries are still by the unskilled birth attendants. Now, the middle 3 states, West Bengal, Jammu Kashmir, and Rajasthan, are having 70% deliveries in the public health facilities, which means we need to improve the quality of care in the public health facilities. Now, coming to the states at the right-hand side. Now, here, the deliveries in the private hospitals are increasing, but the cesarean section rates are also increasing at the same time. States like Kerala, Tamil Nadu, and Telangana, every alternate delivery is by cesarean section. But Andhra Pradesh and Karnataka, every 3rd delivery is by C-section, and Maharashtra and Gujarat, every 4th delivery is in C-section. So please try to avoid the elective cesarean section, which actually poses a harm to the care of the newborn by the mother who has undergone the cesarean sections. Now, WHO has come out with a term called maternal near miss in 2009, particularly to identify the causes of those mothers who have averted the maternal death and work upon it scientifically to further reduce the maternal deaths. The term, to mention it as maternal near miss, has some clinical standards, laboratory standards, as well as the disease management standards. This slide is taken from a study in China, which mentions that admission in obstetric CCUs and ICUs has actually helped to avert the maternal deaths from 1.8% in 2015 to now 3.3%. But if you talk about India, a very vast country, we have more than 1,000. It's totally 1,003 district hospitals. We have 83% of the district with special newborn care units, but only 2% of the districts with obstetric HDUs and ICUs. And we all need to work for it for further improving these conditions. Now we are in the COVID pandemic. Colleagues, we all know that pregnancy itself is a high-risk condition for COVID, which has particularly impacted the maternal deaths, stillbirths, newborn mortality. If we talk about India, during the first wave, institutional deliveries in India reduced by 30% because of the lockdown measures. In the second wave, institutional deliveries reduced by 35%, and it will have its own implications in the maternal mortality, morbidity, as well as the newborn morbidity and mortality. This is a slide from the Lancet study, which was released early in 2020, early estimates of the indirect effects of COVID-19 pandemic, where the study mentions that there will be addition in the maternal and child deaths anywhere between 8.3% to 38.6%, depending upon the severity of the COVID waves and the lockdown imposed. This FOXI itself was a part of this COVID pregnancy register, and we all know that during the first wave and second wave, the symptomatic cases doubled among the pregnant women from 14% to 28%, and also the case fatality rate has increased to 5 times from 0.7% in first wave to now 5.7% in the second wave. This is from the biomedical reports. What are the indications? You all know better than me. What are the indications for the obstetric admission for the obstetric ICU, CCU, obstetric conditions? Now, obstetric complications and comorbidities tend to increase in a person who has already underlying disease, making the management of the indirect obstetric causes much more complex and sometimes out of coverage of the obstetrician, particularly heart diseases, neurological problems, including epilepsy. A study was done in China between 2013 and 2016, and the study is published in the biomedical reports. It mentions that only because of the heart attack during the delivery services, it rose from 1.8% in the pregnant during the delivery time, maternal mortality, to 3.3%, which still mentions or give us the indication for having the obstetric ICUs and HDUs. Now, Government of India has embarked on the way to open the obstetric HDUs and ICUs. Operational guidelines has already been released by Government of India with the aim to have obstetric HDUs and ICUs in all the medical colleges, to have the HDUs in all district hospitals and the state hospitals and high caseload facilities. All in all, the target is to establish 500 obstetric ICUs in India and another 1,500 HDUs. For this, a committee has been formed last week, in which many of you are already a part of this committee working together with Government of India for this great endeavor. Thank you very much for this opportunity and the time.
First of all, congratulations on that Lakshya program successfully being done by FOXI under Dr. Alpesh and the UNICEF. I think it's a great step forward. It was a very nice and enlightening talk, Dr. Syed Ali.
Dr. Syed Ali, I have one question. That could we transfer a normal patient which undergoes some complication to obstetric ICU in a common setup? I mean, for common people.
No,
is
sir.
it any Government of India scheme to prevent maternal mortality, the immediate transfer to ICU or HDU nearby for any delivery?
It should be ideally done, sir, transfer, but the referral currently is very poor. Moreover, now Government of India is working on the midwifery-led care units, which have started in Gujarat and also in Andhra Pradesh, where they want to have the normal patient looked after by the midwives, and the doctors can further focus on the complicated or cases. You rightly mentioned that currently we don't have the obstetric HDUs and ICUs, so the referral to the tertiary care hospitals, the rate of referral, once the doctor refers it from the any facility, XYZ facility, to the higher facility, how many women particularly reach there? My topic is not that, but
it is very difficult.
70% people does not actually come out to the referrals, only because there is nobody to accompany them. The woman is alone. Father does not want to accompany them. One of the studies in Lancet mentions that only the husband accompanying the woman during ANC care have positive outcomes for the pregnancy, both for the mother as well as the newborn. So these are some facts.
See, there is one very interesting fact that Sri Lanka has reduced the maternal mortality just like a Western country, and their president has a private jet, and it is only for 2 people. One is for a mother who is delivering, and second is for the president. So their plane is also available for the woman to transfer the patient.
Definitely.
So that should be the
We have now introduced a system of birth companion
Yeah.
as part of the Lux
system.
But one analysis was done. Only 20% of the obstetricians actually allow the birth companion into the labor room. So these are some
Yeah.
facts, sir. Thank you.
Okay, thank you very much.
I would like to highlight a few points with regards to Dr. Ali sir. He is from UNICEF. We know him as the Foxy has first affiliation liaison with UNICEF with Alpesh Gandhi sir and leaders from UNICEF like Ali sir. Honestly speaking, Foxy did not know a lot about the particular UNICEF partnership reporting system and all the structure. UNICEF usually, all across India supports 280 centers with regards to certification of Lux, that is national certification, and they have agreed upon having our Foxians to lead or mentor those centers as well. Along with that certification process, the smoothing the process, and the reporting metrics, which is actually difficult for Foxian to understand. He has made it possible, just like एक बच्चे को जैसे उंगली पकड़ के ले जाता है. He has been always there for all of us, and thank you so much for such a huge contribution each and every time. And I can say whenever the reporting day nears, you are always available for us 24/7. So thank you so much, sir, for everything, sir, you have done with regards to Foxy UNICEF partnerships. Sir.
Thank you.
With UNICEF, we have done one contract, of course, it is not the word MOU, but something like MOU. And with UNICEF, Ministry of Health, Government of India, and Foxy have started this activity so that the centers can get the certification from government, Lux certification for labor room. So this is the quality care in obstetric. And under this, we are training doctors, paramedics working in those centers. And Foxy took responsibility of 260 public hospital for the first time. This is not private hospital, public hospital supported by UNICEF and government hospitals. And we are working so that we are hand-holding, we are mentoring, we are training them so that they can receive Lux certification from state and then central government of India. Thank you very much for this massive work, massive support to Indian women, Indian mothers. Thank you, for the joint work. Thank you.
That's a great step forward, Foxy, as well as UNICEF.
All these centers are in aspirant districts. This is a pan-India project in 23 states, and where the maternal mortality is highest.
Wonderful, sir. I think best wishes. We look forward to achieving the target by 2030. So moving on to the next session.
Next speaker,
Dr. Rajal Thakare. Yeah. Next again is a very interesting session, infection prevention and control in obstetric HTU and ICU. The speaker is Dr. Rajal Thakare. Especially in ICU, infection control is very, very important because there are specific ICU bugs. These patients are usually on IV lines and central venous catheters, urinary catheters, tracheal tubes, and all those contributing to a lot of nosocomial infections. And there is also this issue of cross infection by the paramedical staff from one patient to the others, the so-called nosocomial infections. And one cannot take this lightly because we will be creating resistant bugs in the ICU. So infection prevention and control is a very important part of obstetric ICU management. And we have Dr. Rajal Thakare, who's going to be talking to us on this subject. Madam is Professor of OB-GYN, Srimati NHL Municipal Medical College, Hospital, Ahmedabad, India. She's a National Coordinator, Adolescent Health Committee, Foxy. She was a past president, AOGS 2018 to 19 and 20 to 21. She's got a lot of research publications, 27 research publications, state, national, and international journals. And she's been author of chapters and course materials of many publications in Foxy. She's won several awards and prizes. Of special interest is in safe motherhood and adolescent health. More than 1 lakh adolescents have more than 1 lakh adolescents covered through lectures across India. And a lot of other interests she has are writing, travelogues, and health education articles, nature, education, photography, etc. I think Madam is a multi-talented personality with diverse interests. Welcome, Madam. The stage is all yours.
Thank you, Deepa, for a kind introduction, and thank you, Dr. Tushar Bhai, for chairing this session. Good afternoon, dear all who are here in the post-lunch session. And I'll be also quick, just as my previous speaker will finish before time for sure, because we are running late. I welcome you all on behalf of AOGS and Ahmedabad. I am part of the AOGS team, past president. And I'll be talking about on the infection prevention and control in OB, ICU, and HDU. The healthcare associated infections are shortly known as HCAI. It occurs during whenever the patient is in the process of care or once it is not present when the patient is admitted. And later on, once she is discharged, again, there is an infection, and also the occupational infection amongst the staff and the facility. The global burden remains unknown because it's difficult to gather the data, and it's a hidden cross-cutting problem, and no institution or country can claim that they have conquered this or they have solved this. So this is not the staff, but this is the staff infection everywhere in our surrounding. The risk of getting this hospital-acquired infection is about 30%, maybe 25 to 30%. And in high-income countries, about 17 episodes per 1,000 patient days. And in low-income settings, it may reach up to 42 to 43% per 100 patient years. And it is mainly because of invasive devices, central lines, urinary catheters, and ventilators. An impact is very, very great because of high cost to the patient, prolonged hospital stay, readmissions, additional test and treatment, long-term disability, increased resistance to several microbials, additional financial costs to the nation also, and more number of deaths. The burden is more in the developing countries, and also because of the problems of poverty, inadequate infrastructure. We have been talking about OBS ICU and how it should be, but even in our setup, we are having the infrastructural problem. So we cannot maintain the guideline which has been prescribed by our own government. There is a shortage of equipments, unfavorable social background, crowded living condition. Even if we discharge the patient at home, there is no problem with the local setup. Poor hygiene, poor sanitation, large population, and population that too is also very much malnutrition, anemia, and other type of infections. And in addition, as rightly said, in previous talk by Dr. Gupta sir, the environmental impact, environmental degradation because of the air, water, and the soil pollution. So we need to have that policy that no one should catch an infection while having it in a treatment. But we need to take care of certain steps so that we can at least reduce it. So infection prevention and control is a practical evidence-based approach which prevents the patient and health worker from being harmed by the avoidable infection and as a result of antimicrobial resistance. So at any given day, 1 in 25 hospital patients can get this type of infection. And obstetric units and obstetric HDU and ICU are not an exception. Most infections are caused by the microorganisms of the vaginal flora. And we are having more and more number of HDUs and ICU. The problem is there also. Major indications for admission in tertiary units is because of the septicemia, as stated in one of the studies in 2012. So we need to take certain steps. So first is the universal precaution. Just as we consider all patients as HIV positive, we just consider that all patients and persons can be potentially infectious, and we need to take care of certain precautions of environmental cleanliness, hand hygiene, personal protective barriers, aseptic techniques, waste management plan, and proper instrumental processing. So how do we do the environment? So we need to take care of our outside environment also, but in the planning stage, we need to take certain effective steps. We need to have a specific area layout and protocols for the HDU, designing and planning of the location and adequate toilet facility, not only for the patients, but staff also. And also we need to take care of the facility of our medical and paramedical and class 4 staff. So these are some of the operational guidelines for the obstetric ICU and HDU that has been laid by the Government of India. The HDU should be near labor room or OT, and other areas like we need to have the lab and the radiology and blood bank should be nearby. There should be a single entry and exit point, and as well as there should be an emergency exit, and isolation room should have a separate entry. Depending upon the number of deliveries, the bed of the HDU and ICU should be different. More than 1,000 deliveries, there should be 4-bed ICU and 8-bed HDUs, and then less if there is less number of deliveries. There has to be adequate space per bed in HDU and ICU, and there should be some extra space for the nursing station, storage, patient movement area, etc. And the movement of the manual of the equipment, beds, trolleys, etc. Bed should be at least 2 feet from the back wall, because if we need to access the head of the patient, then there has to be space and space for the bedside movable lockers. So this is about the planning. There has to be a privacy, so the curtains are there, has to be there. The curtain fabric should be fine and waterproof, washable, clean. The height should be determined by the floor ceiling height, approximately 8 to 10 inch above the finished floor, because whenever there is some cleaning, the curtains don't get damaged or wet. And it should have a mesh at the top so that the light can come out, but otherwise the patient feels claustrophobic. And should be hanging from the overrailing range, so we can just remove it and then we can close it whenever required. The flooring, walls and ceiling also has to have certain specifications of the color. It should be stain proof. Walls should be double glazed. There should not be any joints, otherwise the dust can remain inside. Everything should be light color of the white or the off-white, and ceiling should be leak proof. No lines, wire should be hanging around, and easy to explore in case the repairs are required. So this is all about in the planning. Then comes the air quality. The air conditioning system should be proper, should have appropriate filters. All should be filtered by 99% efficiency down to 5 millimicron. All should be, air movement should be from the clean to the dirty area. Have minimum of 6 total air changes with 2 air changes per hour composed of the outside air. So this is all about the movement of the air. Ideally, provided if we have this facility of either positive and negative pressure room should be there in the hospital. So negative pressure room, especially if the patient is having active tuberculosis. So the air inside the room is negative so that the outer air doesn't come inside. And then that if that air circulation should be there, either it should go out or it should be recirculated with the HEPA filter. Whereas the positive pressure room, it's ideal for especially having the neutropenia or post-transplant or in OT. So it forces air out of the room. Here is the positive pressure, and these are considered as the cleanest room. But this has to work. Sometimes what happens in the initial setup, everything is working fine. But as there are few months or years pass by, there is some other problem in this system. So it has to work properly. All areas must be cleaned with the high quality cleaning and the disinfections, and we have to take care of long periods of, certain pathogens can remain for the longer time of the staph, that are the methicillin resistant staph aureus, and then vancomycin resistance, enterococcus, Clostridium difficile and other. So it has to be, the cleaning process should be there. There should be surface cleaning of the wall twice weekly, floor cleaning 2 to 3 times per day. And once the patient is supposed discharged of the dead, there has to be the terminal cleaning. So this is high quality cleaning also be there. The wash basin in that area is not proven very, very useful, because every time there is a leakage or there is a water seepage. So it is not even very popular in the ICU area. It has to be outside. or it has to have an elbow or the foot operated, if at all we are putting it. One of the study done has shown that this, once they have removed the sink from the ICU, it reduced the bacterial colonization. So better not to keep this inside this area, in the ICU area. The dirty and the soiled linen material should be allowed to stay, should not be allowed to stay there. It has to be taken out. Otherwise, it will create a bad odor, infection, etc. So it should be disposed as fast as possible as per our biomedical wastage disposal rules. Regular linen should be replaced regularly, and even in the government hospitals, we have a color coding system of the linen. So Monday is a different color, Tuesday is a different color, Wednesday. So every day there is a different color. So that shows that, okay, the linen has been changed, and separate area for the clean storage. All entrants coming or going, going inside the ICU should wear cap and mask. Apron, which should be replaced daily. Proper instrumental sterilization. The alcohol gel dispenser should be there at the ICU entry, ICU exit, every bed space and every workstation. It has to be there. And in this COVID era, I think we are also keeping the same alcohol base with us also, and separate medical preparation area. So this is all about the environment where we are keeping the patient. Second comes the hand hygiene. It is the single most effective means of preventing horizontal transmission of infection among the hospital staff, hospital healthcare professionals, and the patients. So we have been celebrating World Hand Hygiene Day, and that is on the May 5th. Clean the hands by using either hand washing, the soap and the water, hand wash, antiseptic hand rub, that is on the alcohol-based hand sanitizer, and surgical hand antisepsis. So it's a simple, cost-effective, important, and often neglected method of hand washing. We have to take care of our hands and cleanliness. So WHO has suggested at least five times, different moments where we have to go for the hand wash before touching a patient, before clean and aseptic procedure. Third, after body fluid exposure or the risk. Fourth, after touching a patient, and after touching a patient on the surroundings. So 5 times, this is minimal patient zone healthcare area, and we have to do it. We are doing it also after using the restroom and before leaving the work, because we are then going to home. So with COVID era, we have been taking care of our hand hygiene quite seriously, and that is very good part of it. So in a general hospital, like we have about 200 patient OPD, how many times we have to clean the hands? I ask myself a question. It is too difficult because 100 times for 12-hour shift, even more than that. And before touching the patient, after touching the patient, before doing any procedure, after doing, leaving the works area. So it is very difficult. And even the CDC has shown that all healthcare professionals clean their hands less than half the times they should. So I think this is the most important thing, and we have to, again, teach ourselves and remind ourselves to do the single most this thing, that we need to clean our hands. We all know 7 steps of cleaning, but again, we just do like this. So whenever I take a session, at least for the school children, or then I ask them to sing a song. So at least 15 to 20 seconds, we are washing it. So while cleaning, at least ठंडे ठंडे पानी से नहाना चाहिए, गाना आए या ना आए, गाना चाहिए. We just sing these 2 lines, that will make about 17 to 18 seconds. So we can do all the, 7 steps of hand cleaning. So 15 to 20 seconds, as per the CDC guidelines, we have to wash our hands. With the soap and the water, there is a dryness. So to prevent, there is another option we have, that is an alcohol-based hand sanitizer. And again, for that, different formulations have been suggested by WHO. Even for the COVID, a minimum concentration of ethanol and 2-propranolol is about 80% weight by weight, volume by volume, and 75% volume by volume, respectively. We have to, it is available in the gel form, liquid form, or in the foam form. Again, this has to go for 20 to 30 seconds. So every time we clean, it is just not like this. We have to rub our hands for at least 20 seconds. And we have to remind ourselves that still 20 seconds are not over. Then and then we can clean our hand and we can protect ourselves, our family, and our patients. Minimum requirement is about 2.4 ml. That is an average solution we need to take in at least 20 seconds for good efficacy. And for the greasy substance, again, we have to go for the soap and the water. Fingernails need to be cut, trimmed. Long sleeves, no. Tie should be tucked in. House coats are discouraged. Wearing scrubs is encouraged. And all these things are no. But then again, I have to tell my residents that you remove this every time I have to. So again, we have to check for all these things that these are all the source of the infection. Even the hand hygiene during surgery, minimum 2 to 6 minutes are recommended. Long scrubs are not required. Third and important is the wearing of gloves. We all know how to wear gloves and to remove gloves. So we are having surgical sterile gloves. We have got the single-use exam gloves for the, at least when there is a mucous membranes are intact or provided risk exposure we want to reduce. Third is the utility or heavy-duty. Whenever we are using, contaminated items or the medical chemical waste is there. And discard the gloves after single use and never reuse. Most of the time in government setup, it happens that it has been reused. Even in our hospital now, this practice is not there. So we are just throwing off the gloves that we are using. Double gloving protects all of us. We know that, and we all are using this technique for prevention of infection to us also and to the patients as well. COVID era has also taught us how to wear, the use of the mask and the face shield. So I don't go much into detail. Again, the PPE kit protects us also. So we have to wear this and to prevent the infection to the others. So safety goggles, mask, shoe cover, face shield, and the gloves are there. There are certain guidelines, recent updated guidelines also for the infection prevention. And whenever there is a aerosol generating procedures, then we have to take care of the respirator also. That is the new recommendation. So certain recommendations are also from the Government of India. Proper waste disposal is mandatory, and we have to follow the biomedical rules. And as per the color coding, we have to dispose of the waste. Sepsis has to be managed, and antibiotic timing is very, very important. Just before the surgery, we have to give the single dose antibiotic has been recommended. So choice of antibiotic, usually first generation cephalosporin before surgery and just before the skin incision. Additional dose only whenever there is a long surgery, otherwise it's not required. And in double the dose in obese patient. So take home is early screening of high-risk mother, vigilant antenatal care, and proper maintenance of asepsis during delivery and postpartum period can reduce this ICU utilization rate. So we take care of all these so that the patient don't enter into ICU and can result into healthier outcome. So we have to have a proper feasible environment for the making of HDU. And it should be also again to the local condition of the rural or the urban areas we can make as per the teaching or the non-teaching hospitals. And these are the final slides. So we have to have a better patient and nurse ratio. Policies to control the traffic flow to and from the unit that will reduce the infection. In government hospital, we have a very major problem of controlling the patient's relatives, because every time there is a patient, at least there are 10 patients around. So this visitor policy is very, very important. Waste and disposal policy should be there. Educating and training ICU staff about the prevention of nosocomial infection. ICU protocol and SOP has to be maintained. Again, the audit and the surveillance. If whenever there is some infection or every month there are the samples and are taken, we have to do the audit and we can prevent infection. Infection control team comprises of multidisciplinary approach of the hospital staff, antibiotic stewardships, control whenever, we have to restrict our prescription of the antibiotics and vaccination of the healthcare personnel. So this is all, if we take care of it, we can always surely able to reduce the infections. These are my references. Thank you very much.
Thank you very much, Rajal, for a very, very nice elaboration of, and you have covered almost everything to control infection, not only in ICU or HDU, also in routine gynec and obstetric practice. I have observed one interesting thing, that commonest infection in OBGYN practice is upper laparoscopic surgery. And particularly in private practice, the mobile gynecologists, I mean, laparoscopic surgeons are using laparoscope. They are doing about daily 10 or 20 laparoscopic surgery at different places. And they just put a laparoscope in side X and all equipment in side X. Usually it is not a proper way to sterilize it. And so sometimes, even though you are giving prophylactic antibiotic in very high large dose, still septicemia does occur and they get admitted in ICU. So every month I hear somewhere some patient is admitted after laparoscopic surgery.
And secondly, sir, the hand washing.
Hand washing is the most important thing. It is the most important thing. Second is in ICU, central air condition is a culprit because same air is moving us around.
Absolutely, that's what I told.
Yeah.
Initial setup, it might be working.
Mhm.
And then we have just closed everything because it's
So
a
in a
DC.
now recent guideline, they are not advising central air condition, they advise split air condition. So same air only for the cabin,
I just-
localized cabins.
Share my experience. My dad.
Yes, ma'am.
Amen.
About washing the hand and getting ready, there should be, I mean, something like photographs, how to wash, and just for everyone, not like that. And it should be just near the washing the hand, so that at least whenever somebody washes the hand and getting ready, at least they should know what they have to understand.
Madam, now with the Lakshya guideline, the washing technique posters are always kept in the washing area. The hand, I mean, foot operated, and then with the elbow operated taps are there. Everything is there. But then, and we all know that we have to wash. But again, because of the hurry, we just clean and then we just go. So 20 seconds, that's why I told કે ગીત ગાવાનું એક એટલે ત્યાં સુધીમાં હાથ સાફ થઈ જાય. Thank you very much, sir.
Now, fortunately, I mean, usually in our hospital, we have a minimal, I will say, sepsis rate. There is no sepsis, I will say like that. But every time one has to remain very careful. Well, as you said about the washing the hand and getting ready, that how to, I mean, minimize the infection. So that is, I mean, acceptable.
I just share my experience. When my papaji had a severe neutropenia and he was admitted at one of the corporate, and that time this positive pressure room was not available. So we were on the top floor, there was no other room, and then I used to open the window so that I can get the sunlight. And I used to make him sit in the sunlight. You sit in the sunlight. So we are blessed with sunlight. So we have to take care, I mean, utilize the sun at the maximum.
What critical specialist was telling me that minimum infection in ICU is in VS hospital and maximum in a multi-speciality hospital in private setup. Why, I don't know, but usually it is because of more interference. In VS, there is a minimum interference because patients are very poor. They are giving a minimum antibiotic and they come up nicely.
No, sir. Antibiotics are given. There is proper care. Even when we had a trauma center, that time we used to admit our patient that was in the medical ICU.
Yes.
But maybe the patient's general immunity is more.
Maybe, yes, maybe.
Because we have seen that even in COVID, the socioeconomically deprived
Yes.
population, they were, you know, because they were more exposed to the sunlight.
Yes.
So their vitamin D3 level was high.
True.
Compared to those who remain inside and they don't get exposed to sunlight.
Yes.
So maybe that is. So vaccination.
Okay, Rajal,
Thank
thank you
you.
very much.
Thank you.
And we conclude the sessions.
Thank you.
Thank you very much. That was a very nice talk and discussion also, madam. Thank you.
Thank you.
We invite them for Can we have the speakers on board for the photograph?
Chalo, aa jao, Rajal.
Dr. Prakash and Dr. Ali.
Yeah, just 3 of us. अम्मा भी ले लो, अम्मा ले लो
All right, we're moving on to the last session of the day. That is the panel on pregnancy and cancer and trophoblastic diseases. May I call Dr. Sarita Bhalerao Madam on stage. She is the president of the Mumbai Obs and Gynae Society, chairperson AICC RCOG West Zone, and member of Governing Council RCOG. Ma'am, please take over.
Hello. Yeah. Thank you, Aarti, for that kind introduction. And at the outset, I'd like to thank Dr. Alpesh Gandhi for giving me this opportunity to participate in this wonderful conference. And the first question you'll say is that why is this part of an obstetric conference? But it is really a very, very important part of the obstetric conference. May I now invite my panelists? I'd like to invite Dr. Anita Sabarwal. Dr. Anita Sabarwal is a champion of public awareness. She's from South Delhi, and she has been on the public awareness committees of the AOGD, also of the ISCCP, and she's working very, very actively in the areas of cancer prevention and adolescent health. Welcome, Dr. Anita. May I invite Dr. Kalpana Khanderia. Dr. Kalpana Khanderia is a senior gynecologist. She's also a very active Rotarian, and she's from Jamnagar. She has done a lot of work on maternal and child health for the Rotary. She has also been the president of the Foxy Jamnagar branch and Health Forum of Jamnagar. I'd like to now invite Dr. Harshad Parasnis. Dr. Harshad Parasnis is a consultant gynec oncologist from Pune, and he has been trained at Mumbai at the Tata Memorial Hospital. He's now a professor at Bharatiya Vidyapeeth, and he's also attached to Sassoon Hospital, and he's been the president of the Pune Obstetric Gynec Society, and last year had a very, very interesting conference called Just Tumors. He's also been the chairperson of the Oncology Committee of Foxy. So with that, we're going to go straight into the panel discussion, and I welcome a warm welcome to all my panelists. So let's first take a few preliminary questions. And my first question is, Dr. Anita, to you. And do you think that this problem of cancer in pregnancy has become more of a problem now, and why? Would you like to take the mic? Yeah.
Thank you, ma'am, for asking me this question. And before I answer your question, I must thank Dr. Alpesh Gandhi, sir, for giving us the opportunity to be part of this great conference here, and especially this panel discussion on a very, very important subject. So, ma'am, as you asked, it's really right that now it's on the rise because of the, I think, rising pattern of the marriage, which is happening at a later age.
Women are delaying childbearing. Yes. So that is the reason
and
that
postponing the childbirth also.
So that's why it's becoming more of a problem.
Yes.
And why is the cancer in pregnancy such a big dilemma? Dr. Kalpana, would you like to comment on that?
Pardon, ma'am?
Why is cancer in pregnancy such a difficult topic to handle?
Of course, the delivery is a difficult one, and we have to handle two, mother and child. And the third one is cancer. So it's a trio. And so it is very much detrimental to the mother, to the fetus, and all.
Yeah. Harshad, coming to you, in your experience, what are the cancers that you have seen in pregnancy?
Yeah, see, the commonest cancers normally that nowadays you see is actually the breast cancer.
Now, the reason for that is now breast has overtaken cervix as for the incidence part. And then is the cervix, cervical cancer. And nowadays we are getting a lot. Also, another thing is that we are getting is the ovarian cancers. Now, it need not be that every time it is actually a malignant, but ovarian adnexal masses in pregnancy, especially because we are doing lots and lots of sonographies at various stages in pregnancy.
Yes. So see, these are the three main cancers. What about other cancers? Any other cancers, non-gynec cancers?
Yeah, you tend to get, but that number is quite minimal as compared to these three, because if you can take these three, it will actually amount to incidence wise also it will amount to nearly 70% of 60 to 70% of all the gynec cancers.
Okay. So now we come to, let's go into the management of these cancers in pregnancy. And this slide says that there are not so many options in diagnosis and none of them are ideal. So Dr. Kalpana, would you like to just go through what are the options in management? What can we do? You have a patient who's come to you, she's in early pregnancy, she's diagnosed with cancer. What would you like to do?
Yes, the mother poses the risk that may be hard to quantify. It also means that she will have to care for a very premature baby while coping with the side effects. Because as such also, we have the threat of the prematurity. And in these cases, with cancer, the prematurity will be there. This option is more viable the lower the risk posed by the cancer, the more advanced the pregnancy. Usually, in the first trimester, some of the cancers, ovarian cyst will be diagnosed. But in the treatment is suitable in the second trimester, if the surgery is the option.
So in this option, we delay the treatment until the child has been safely delivered. Harshad, any example you can tell me where you can delay the treatment, let the pregnancy go through?
Yeah, actually, when you have cervical cancers, especially when the patient is diagnosed as a cervical cancer in the third trimester, that is the time when many times we say that let us actually go till the age of maturity, where viability, or rather at 36 weeks is what we would try to go towards, 34, 36 weeks, and then get her delivered, get the pregnancy delivered, and then go ahead and give her treatment. That is one. Second also, which I feel is a breast cancers also. Sometimes in breast cancer, it does happen that when you you can do the surgical part. But when it comes to giving the chemotherapy part, maybe we just delay that till she has finished her pregnancy.
Yeah. Dr. Anita, now the second option is to terminate the pregnancy and then do the treatment of the cancer. So in which situation would you think that this would be the best option?
Yeah, this would be the best, especially if the patient comes in the first trimester and she doesn't want to continue with the pregnancy also.
Or if she's a multi maybe.
Yeah, and she's already completed a family maybe.
Yeah.
And so she can go for termination because that will be really good, both for her and also the toxic effect to the fetus.
Yeah. And the third option is the more difficult option where you treat the cancer and continue the pregnancy. Harshad, any comment on this?
Yeah, I think here you must understand that especially when you are doing some surgeries, or rather if it is a gynec cancer, especially the chemotherapies. There are some chemotherapies which are very less. See, most of the chemotherapies are basically gonadotoxic. So if you are giving a chemotherapy which is very less toxic to the fetus, then maybe I think you can actually also give it an option. But here again, counseling plays a very important role. You need to counsel the patients and tell them about the possible side effects and what she is going to go through.
Okay. So Dr. Kalpana, coming to you now about the diagnosis. Now, suppose, for example, you have a patient who comes to you, she's come with a lump in the breast, she's in the second trimester. What would you advise?
In some cancer, there are tumor markers, but not for all. And there is a hindrance that we can't do frequent CT scan or PET scan or like this.
Right.
So our hands are main thing. Then the sonography, it will be added, and still some tumor markers.
Okay.
They help in diagnosis.
What about the role of MRI? Dr. Anita, anything you'd like to say?
MRI is safe, ultrasound as well as MRI, they both can be done. They are safe. Also, in certain situations, if we need chest X-ray by shielding the abdomen of the woman, we can do that also because minimal radiations are given.
I think your sonography and MRI play a very important role, not just about to understand which is the type of the disease. Many times, where is the tumor, location of the tumor, the size of the tumor, whether it is actually impinging onto the pregnancy, whether it is going, the tumor characteristics. All these will be much better seen if you're doing a sonography or doing an MRI. Especially these two investigations will help you in the staging. Imaging wise staging to know how much is the spread and what to take a decision on it.
What about now a patient who has a lesion on the cervix? Would you advise a cervical biopsy in pregnancy and any precautions?
Yeah, we can actually, first and foremost is after you have done your pap testing and now that you've seen a lesion there right away, yes, you can take biopsy. Only thing is that you have to be a bit more careful about the bleeding part. That is one.
But it should be done intrapartum, I feel.
Yeah, so if you can,
you can do biopsy.
No. So if you can delay it till the pregnancy is over, then nothing like that.
That is what.
But if you see, you have a patient, you've got an abnormal pap smear, she's become pregnant. Sometimes it happens that while patients are being evaluated, they miss the UPT positive. They become UPT positive. Then you need to do a biopsy. So how will you do the biopsy?
Yeah, in these cases, actually, you have to be more careful, as I said, regarding the bleeding part, number one. And secondly, now when you're doing those biopsies, you can just take a very small, the amount of tissue that you have to remove has to be very small. You do not take a very big tissue from that, especially. Now, if you have a frank malignancy there, I think many times even if you just scrape it, you get a good chunk of tissue out there. So there is, Now, if it is a pre-invasive lesion, now that is where you need to do a colposcopy. You need to address it, see it, and there is also if you are going for conization, then conization along with os tightening. Now, these are multiple things that can be done in these patients.
Okay, so let's go ahead now, and these are the diagnostic modalities that are safe in pregnancy. As you said, ultrasound, and you said MRI. These are safe, and this slide tells us about organogenesis. Dr. Kalpana, anything you'd like to say about organogenesis? When is it dangerous and when is it safe?
See, up to 2 weeks. Is we all know that blastocyst is resistant to teratogens, but in the between 3rd to 8th week, maximum teratogenesis will appear and ends by the 13th week.
Yeah, so ideally, if we want to do, we should push a little bit till we reach at least cross the 10th week or by the 3rd.
Yeah, of course, we should pass this limit.
Yes. Okay, so now let's go ahead. As Dr. Harshad said, that the cervical cancer is the most common one. Then we have the ovarian tumors and the breast. And coming to you now, Dr. Anita, you tell us about cervical cancer in pregnancy. How will you manage?
Since cervical cancers are the most important cancers, because as you just mentioned, they are the most common and they're the most preventable. As we always talk, I think even while managing them, we must again inform them about the vaccination part during the adolescent and again the screening part, and then now come to manage them.
Yes, but now let's take a scenario where you have a patient, she's pregnant and she's come to you with a cervical cancer. How would you proceed?
Yes, now if the patient has cervical cancer, we have to first stage the patient and we'll have to know which stage she is. First on the history we'll come to know, and then on pap smear, and then after screening, if we know which stage she is, then accordingly we'll manage. If she is stage 1A or maybe up to 2A, we will manage her differently. Because in that case, if the patient wants the pregnancy, or second scenario would be if she doesn't want the pregnancy to be continued. So if she doesn't want it to be continued, then straight away we can even go for a hysterectomy.
Okay, so Harshad, I'm coming to you now, saying that this patient is in the first trimester, maybe diagnosed cervical cancer, and she wants to terminate. How will we terminate? Because even termination is difficult when you have a cervical tumor. What would you suggest?
Yeah, now again here, what is the stage of the disease? First and foremost, which is the type of the tumor, which is the stage of the disease, what is the parity? Because all these things are going to make a difference as to for the treatment. Now, as far as possible, we try to actually do these procedures. Now, again, a gestational age. Now, all these things are actually going to influence your decision. Now, if you have a patient who is in the first trimester, patient doesn't want, she's parous and she doesn't want further children. Yes, and she is an invasive cervical cancer. You can have opt for a surgical treatment.
So you'll remove the pregnancy at the same time, hysterectomy, or what would you do?
No, you can do if you have an invasive cervical cancer clinically, which is operable stage. You can go ahead and do a radical hysterectomy also
with the pregnancy in situ.
Yes, in situ.
With the pregnancy in situ is what you're recommending.
Yeah.
Okay,
Yeah.
okay.
Now, in case she is
For radiotherapy, say.
No, I'm talking of surgery. Just we finished off the surgery.
Yeah.
Now, in case it so happens that you want, she has a very early pregnancy, early tumor, which is stage 1B, 1A. 1A1 or 1A2, where you could again go in for, you could actually terminate the pregnancy, and she could actually go in for a trachelectomy also if she need.
If she wants future children.
Future children.
Yeah. Okay.
And if it is a very early, as I said, in a pre-invasive lesions, then you can safely wait, let the whole pregnancy get over, then go ahead and give her a definitive treatment.
Okay. So would you like to comment on this? What is the ESCO recommendation?
Yeah, that's what I was just now saying, was if you have stage 1B1, that is less than 2 centimeters tumor is there, here you can actually go ahead and do a large conization. Now, when you do this large conization, along with that, 2 points to be remembered. One, the tumor margins have to be negative. When you do the conization, you have to keep the frozen ready at that time, because you want to know that your margins are negative.
Right.
Because if your margins are positive, it is going to be inadequate treatment.
Yes.
Second thing is that now with a cone which is large, depth is going to be more, and if it is a large cone, you also need to do a cervical encirclage for these patients.
Right.
So both these points.
But would you do both together?
Yes, at the same time.
Yes, you do the conization first and then take the cerclage at the same sitting.
Yes, and when you do the cerclage, believe me, the whole bleeding also stops.
Okay.
And if you do trachelectomy, they say that it's going to have lots of complications and also a lot of pregnancy loss, early pregnancy loss.
Okay. And what if it is
at the same time will help to control the bleeding also.
It will control the bleeding also. Yes. And if it is at stage 1B onwards and it's a little bit advanced, then what would we do?
Yeah, if again, as we are seeing here, if it is more than 24 weeks, or if depending again further, what is the tumor size and whether she needs further children or not. Now here you can again consider conization and lymphadenectomy if you want further childbearing. If you don't want any further childbearing, then surgery can become one option. If it is an advanced stage disease, a bit advanced, you can also think of neoadjuvant chemotherapy also in these patients.
Right.
And also even vaginal delivery can be then opted after.
Yeah. So here we again look at the delivery aspects.
Yes.
Dr. Anita, would you like to comment on the delivery aspects?
Yes. Then because after doing, because since we've already done this conization and we've checked upon the lymph nodes also.
Of course.
Yes, this is what.
Yeah, that is why the problem with conization is going to be that you are going to have abortions later on of preterm deliveries.
Early pregnancy loss.
And that is why you put in a cerclage.
This is what we mentioned. Yeah.
The program, dekho.
So we can opt for vaginal delivery in the first case.
Yeah.
Especially when we've done the conization and we've taken care of the lymph nodes also. And but in the other case, if the size was more, then we could even go for corporeal cesarean section.
Okay, so let's move on now to ovarian tumors and adnexal masses. And I'm going to ask Dr. Kalpana, in your experience, what are the ovarian tumors that are commonly seen in pregnancy or the adnexal masses?
Most of the time, functional cysts are there. Adnexal masses will be there. 1 in 1,000, it is the incidence. But ovarian cancer for birth is 1 in 10,000 to 1 lakh.
Okay, so you feel that the functional cysts are the most common. Yeah, and after the functional cysts, what are the next things? I would think that the benign cystic teratomas, dermoids are the commonest. No, what do you think, Harshad?
Yeah, I think dermoids. I can just tell you about one of my patients where we had dermoid, which was diagnosed at around 18-20 weeks. Patient said because the dermoid was small, around 3 centimeters, we decided that not to do anything about it. Wait for her. She chose for the other option that we should go ahead, deliver her, and post delivery we treat her for that dermoids. It so happened when she came for delivery, she had 2 huge dermoids on both sides around, and she came with twisted ovarian cyst in acute pain. Both the dermoids had grown to around 20 centimeters, and at that juncture we could not actually save the ovaries also.
So you had to remove bilateral oophorectomy in pregnancy?
Yes, at the time of C-section we had to do that.
At the time
and
of
at the time
cesarean?
of, that was when she was 36, 38, 37
So
weeks.
she was, because she was 36,
Yeah.
38 weeks, you could remove the baby, but
Yes.
otherwise it would have
Yeah,
been
so but this is just a experience that I'm narrating to you.
Yes.
Most of the time it was just a incidental diagnosis.
Yes.
During the
sonography, right? So they don't
You miss also if you don't do TVS. For abdomen, many times the radiologist, if he does, he would write fluid in pouch of Douglas.
Yeah, but
So
Yeah,
I had experience with one patient, so I remember that.
Again, here the point to remember is that in case you want to do the surgery for removal of these cysts, that can be between 16 to 18 weeks after you have done the anomaly scan and seen to it that the fetus, the baby is there is no anomalies in there.
Okay. Now, how often have you seen epithelial ovarian cancers in pregnancy? I think that's really very rare, isn't it? Yes, very rare. What do you think, Harshad?
Yeah, it is. They're not very common actually. But they're diagnosed sometimes on routine sonography. When you talk of epithelial ovarian tumors, I think benign appear to be much more
Serous
commoner
cystadenomas, yeah.
than the malignant ones. And here again, you could go ahead, do a unilateral salpingo-oophorectomy. Surgical staging can be done. You can save the uterus if she's stage 1A, if she's stage 1. And you have to do a pelvic parotid node dissection can be done.
In pregnancy?
Yes, it can be done. Pelvic node dissection can surely be done in the second trimester.
Okay. And then we follow up the pregnancy as usual
you can
and give
follow
the chemotherapy later?
Yeah, in case you need, chemotherapy can sometimes be given, but the instances of chemotherapy being given because patient accepting the fact, as I said, counseling here, she has to accept the fact that you are going to give her chemotherapy. To accept that and go ahead and continue the pregnancy, that itself is quite a bold decision.
And have you ever given chemotherapy during pregnancy for any tumors?
Yes.
You have?
We have.
Which ones have you given?
But this is very rare. It's not very.
But breast, sometimes for breast, maybe.
Breast, yes. For breast is where we actually land up giving these chemotherapies, not for not an NACT. I have not given an NACT, but breast, yes.
Breast you've given.
Yeah.
Okay, now coming to germ cell and sex cord tumors of the ovary, would you like to comment on that?
Yeah, again here, if you have a germ cell tumors, they are very good chemo responsive. Here again, if you have, they're usually seen in stage 1. So you can go ahead and safely do the unilateral salpingo-oophorectomy. Limited surgical staging can be done. That means you don't do a hysterectomy, and then let her actually deliver, and then you can give her chemotherapy post delivery.
Yeah.
In case you land up giving bleomycin doesn't cause so much of problems for the fetus as much as your cyclophosphamide does. So bleomycin based chemotherapy can still be given.
Okay.
But the bevacizumab we usually don't prefer to give the patients.
Yeah, it causes
I think,
lung fibrosis.
Yeah,
that's true.
Lung fibrosis.
And I think I have seen a few patients, and they have been come from Tata Hospital to Wadia Hospital with chemotherapy, and there have been fetal complications. In fact, I know that IUGR, maybe it is the situation as well as the chemotherapy which caused the IUGR.
IUGR is very common.
Very common.
Yeah, very common.
Yes. Preterm labor
can
also be a problem. So now, Harshad, coming to breast cancer, what would you, any pointers for the gynecologist?
Again, here that if you feel a lump during the pregnancy, if the patient says that she has a lump, please examine it, number one. See to it what type of lump it is. do a imaging on her if possible, do a sonography, which is sonomammography. Yeah, see what is it. If it is a cystic lesion, there is no, you could just aspirate it and leave it. But if it is a solid lesion, you need to go ahead and do a core biopsy, which is called a true cut biopsy.
Right.
And under local anesthesia, and that should suffice. Ascertain that this is not malignancy, and that's it. In case it turns out to be malignancy, now then is the comes the question of whether what treatment should be given, because then you have to actually see whether there is any spread to the axilla or not. And here, in the olden days, we used to do mastectomies,
right?
Radical mastectomies.
Yes.
So now, initially we used to do level 3 dissections. Then has come to level 1, and now we have come to simple lumpectomy,
wide excision.
yeah, lumpectomy and sentinel lymph node biopsies.
Right.
Is what we do.
Breast-sparing surgery.
Yes, and then you
can
finish
this
off the
breast-sparing
pregnancy.
surgery be done in pregnancy?
You finish off the pregnancy, and then post pregnancy you can put her on
chemotherapy.
Yeah, chemotherapy.
So you do the surgery in the pregnancy, you deliver her at 36 weeks or 37 weeks
Yes.
or whatever, and then you go for the chemotherapy later.
Yeah.
But
Now-
here, what about chemotherapy during second trimester? Are these drugs?
Yeah, as I said, see, there are the medical oncologist actually rates those drugs into 2 or 3 types. One is one which causes severe toxicity. Second is one which causes mild, moderate, and mild. So, like methotrexate or bleomycin, these are going to be the milder version. Cyclophosphamide, yes, it not only actually affects the fetus, but also it will also remove or rather kill all the oocytes also. Follicles also which are there are going to be killed. So cyclophosphamide is on a, we would not like to give as much as we would like to give the 5-FU or the epilubusin. Trastuzumab, if they are, then once we take out the tumor, we see whether it is a ERPR HER2 new status.
Okay. Before we end, 2 more questions I have, and that's for Harshad. If a patient has had breast cancer, how long should she wait before planning a pregnancy?
Yeah. Now, if she has had, here there are 2 questions, sub questions that come up actually here. First is that if she is a ER positive, or she is, what is her ERPR and HER2 new status? In case she is a ERPR positive, that means she is going to be put on tamoxifen.
Yes.
Now, you should not allow her to actually go ahead and have pregnancy when she is on tamoxifen.
Right.
Because that is going to be teratogenic also, number 1. So there is a big trial which was taken place, which is called as a positive baby trial, which was done by the North American Oncological Society, where what they did was, they gave a leave. After you finish the surgical part and the chemotherapy part, now you give, because look at it, if your patient if the patient has malignancy at 35, and if you're going to give tamoxifen for 10 years, for 10 years, which is what is advised, then she'll be 40, 45, and how will she conceive by that time? So what now the new trial they're doing is that after 3 months of finishing the initial part of the surgical and the chemotherapy part, give her a gap of 2 years, and in that 2 years allow her to conceive. If she take help of ART consultants.
Yes.
Let her conceive, let her deliver, and then you can take ahead the rest of the chemotherapy. This is one scenario. Second is in case you have to allow, when will you allow her to conceive? So you have to give her at least 2 years.
After the tamoxifen is over?
No, after the chemotherapy is over. If she's a ERPR HER2 negative, let's assume she's a negative. So she doesn't need tamoxifen. So in that time, she can actually go ahead and wait for 2 years, because studies there's a big Danish study here, which shows that at least 2 years you have to wait.
Okay.
Before we can actually embark upon, because if you do it before 2 years, they have found the incidence of fetal anomalies to be much more higher.
Ma'am, before 10 years, I had one patient of breast cancer. She is at that time 28 years. One female was there, and she diagnosed breast cancer. Before 10 years, breast-sparing surgeries are not
there.
Yeah, and so mastectomy was done. And after the chemotherapy, after 2 years, I allow her to be pregnant. And with some 3-4 months treatment of sterility, she conceived and delivered the male vaginally, normal.
Okay. Now, what about lactation after breast-sparing surgery?
lactation after breastfeeding.
Yes.
She can still go.
She can?
Yeah, she can. The opposite side breast is obvious.
Opposite side.
That breast
Not
is
from that side?
No, that side also she can.
Only some of the ducts may be destroyed.
Yeah, if she has good amount of milk coming on that side, she can still go ahead. And
But there's no contraindication.
No.
Why I'm asking you is because also in pregnancy, estrogen levels go high. And is it detrimental in any way?
no, actually, no. She can still go ahead and
she can have the pregnancy. And because some patients say, doctor, is it safe for me to conceive? Is there a risk that my cancer will come back?
If she doesn't have, when she comes to you, if she is a cancer survivor,
yes,
she has to wait for 2 years before she actually embarks upon pregnancy number 1. In case she is on trastuzumab, that is Herceptin.
Yes.
On Herceptin, after stopping Herceptin, you have to wait for 7 months.
Right.
Before she can again embark upon pregnancy, because it is found that you should not actually allow her to conceive on Herceptin, that is trastuzumab, because you can have fetal anomalies. You will have, as she rightly said, that fetal kidneys can show will not be developed properly. You can have oligohydramnios and you can have fetal anomalies.
Right.
So we would not want to start this, allow this patient to conceive in that phase.
Okay. So I think any questions? Dr. Meg, you were going to ask some questions. Dr. Meg,
No, she is finished.
She's going to ask some questions.
She's finished asking questions.
Any questions? You were going to ask some questions. You asked? What is the conclusion?
Yeah,
so let's take a conclusion from each of our panelists, and that's starting with Dr. Kalpana.
As such also, second trimester is best for the surgeon.
Dr. Sunil Shah. So you can speak on mic. It's a big hall. For the audience.
We can hear you otherwise. सब बंद किया आपको लगा उन्होंने भी बंद किया
Hello, yeah. So she has a breast discharge. So she is around 52 years old. So we decided, my wife was examining her and she said, okay, go for the mammography and we'll see. It can be infection or something like that. So we'll give you some antibiotic. Since you are old age, go for the mammography. And in mammography, there was nothing significant, no mass, no retraction, nothing like that. But somehow my wife feels that let us take a cytology of this fluid.
Yes,
right? Good. And in the cytology, they found some abnormal cells, right? So, and they said it can be a malignant cell. We cannot tell it very clearly. So go for mammosonography. Then she was also advised for the MRI also,
yes,
right? And in MRI also, they said that there is some ductal dilatation.
Right.
So that was the thing. Ultimately, sonographic guided that biopsy were taken. That also says that clearly we cannot say that it's a malignant cells or non-malignant cells. Then ultimately mastectomy or the lumpectomy was done. And in that, it turns out to be a carcinoma in situ ductal carcinoma.
Interesting.
So what will be the treatment? Whether it is a simple mastectomy
but
or
she is 52-year-old, no?
She is 52 years old.
Yeah. So yeah, you can, if you have done some lumpectomy, if there are no lymph nodes,
clear,
then I think this treatment is going to be more than sufficient for her.
More than sufficient. Yeah. So I think Dr. Anita, you are going to give a closing comment.
Yes. Because as we say, it is very, the incidence is not so much, it is less, though it is rising, the happening of this cancer during pregnancy. But still, I think it can still be prevented if at this stage, we counsel these patients, inform them, educate them, and tell them, especially for the cervical cancer, as well as for breast cancer. Because for breast cancer, they can do their regular screening and their regular self-examination, palpation. And for cervical cancer, they must go for the vaccination as well as for the screening. So that is
yes.
Yeah.
Harshad, yeah?
Yeah. My take will be that if this, first and foremost, there is no way that most of these cancers can
Go ahead.
Yeah,
you
most
go
of
ahead, then
most
Shri.
of these
Come here.
cancers can actually be diagnosed, except for cervical cancer. Rest of them you just come to know that is a cancer. That's number one. So you need to have a disciplinary approach to this, because not only do you need a good obstetrician, you need a medical oncologist, a surgical oncologist, and more important than at present day, you need a good pathologist. Because the pathologist who's actually more because the oncopathologist is actually going to dictate, because he's going to, when he gives you the actual diagnosis, that is also going to, so it's, as I said, along with it, when we are dealing it in our institution, we also have neonatologists in this, because many times you have to deliver these babies beforehand, and that is when we have to take their opinions as to how long can we prolong or what else to be done.
Correct.
So, as I said, some multidisciplinary is number one. Second thing is that in case you land up in such a situation, it is the whole situation is not hopeless. Actually, you can still get a good outcomes out of it. Most of these patients who conceive and have an early stage cancer, you don't see, and very rarely you see an advanced stage cancer and patient still pregnant. So because she's at an early stage, always the prognosis are much better. So give a ray of hope to these patients rather than telling them that.
Yes. Very often they feel cancer ho gaya,
Yes,
they're going to go and they don't care about the pregnancy.
No.
But
don't do
today
that.
things have improved.
Yeah.
Yes, doctor, would you like to introduce yourself also?
Yes, ma'am. I'm Dr. Bhavya Doshi. I'm senior resident at AIIMS Raipur.
Okay.
It was a nice talk, ma'am. I just had one query, ma'am.
Yes, sure. Go ahead.
Ma'am, so we see many patients with ovarian cysts, since ours is a tertiary care center, so many patients with pregnancy with ovarian cysts get referred to us.
Yes.
And then since it is pregnancy, so with ovarian tumor markers are not very reliable, like CEA and beta HCG, and all of those becomes unreliable. CA125 we have, but still
I think the ultrasound features are the thing that you can rely on most.
Yes,
What do you say? Yes, you have to go by the imaging technique, and since you can't do any other imaging except ultrasound, I think the ultrasound is the most important. And fortunately,
And
these are young.
MRI is also required for
we
them.
can do.
Yes, ma'am. So that is what I wanted to ask. That should we frequently do MRI for such patient? Like if it's a 3, because there are many times simple cyst only.
When your sonography is going to tell you that this is a patient where you have a high index of suspicion, then only as a second line are you going to look at
There is an IOTA guideline also for the ovarian cyst, ovarian lump. So go through this one, and then if required, then MRI will be advisable. Otherwise, sonography and color Doppler is
More than
sufficient.
enough. More than enough. So I think with that, we'll conclude this session. And I'd just like to say as a concluding remark, we are very happy that oncology is included in obstetrics, and that it's a very important part. And for all of us as practicing obstetricians, we must think cancer sometime along the line. Yeah. I'm very happy that we've had excellent audience interaction in this session.
Yes.
Quality audience, rather.
This question is for the panelist. Like suppose a woman comes, a short married life at the age of 32 with the breast cancer, and she wants to go for a gamete preservation, her oocyte preservation. What is your call? How would we proceed ahead?
If she
oocyte preservation.
Yeah, you can. We have had patients where
after the surgery, before starting.
After this, once you have confirmed the diagnosis, if you're going to do a breast surgery, we can have it here so that we'll have that background. Yeah, if you can go ahead and actually do the oocyte
before chemotherapy,
before giving chemotherapy,
right?
Yes.
So after surgery
and in
before
case also,
chemotherapy.
in case you land up into chemotherapy also, you can give leupride and actually suppress the ovarian function.
Yes. Yeah. Okay, and the gonadotropins are safe when we do the stimulation.
You shut down the ovary. Sir, एक minute.
Done, chalo. We have got the answer. With the audience also, we have got a very small audience.
Sarita, I'm saying on this background.
Which one is that? One said we want with audience also, yeah.
Yeah.
First, come on, yeah.
Dear audience,
नहीं एक लेके नीचे
one.
Yeah.
Come, Dr. Bhavya, you're also audience.
Please come. You are so very pertinent. I know.
Come. Now we can go down.
We have
a very big audience.
I know. Patient nurse ratio is 1:1 and panel is very
I hope you answered all your questions.
very attentively listening to them.
Whenever patient nurse with the audience बोला ना, patient nurse ratio बोला ये patient
ये panelist और audience ratio
मेरा बहुत important है इधर center
मैडम के लिए जरा
हाँ हाँ थोड़ा
लोग आ रहे हैं अरे मेरा निकाल मेरा वाला नहीं निकाल Send it to us.
हाँ हाँ એટલે મોકલું પછી
Thank you.
किसी की आंख बंद नहीं तो कट गया
Thank you. एक अभी मशीन WhatsApp हाँ ये आपको ग्रुप में डालना पड़ेगा Don't take it. I'll put it in the group.
Dr. Meg will send you everything. I'll put it in the group.
We interested more audience.
Thank you.
Doctor will help you.
Okay, fine. Let's go offline.
It is not important.
somebody has written that it's like very interesting
Yeah.
રાજન જોશી તમે માસ્ટર ઓફ ધ સેરેમની છો છે અચ્છા એટલે જાયો હોય ને તો શું કરવા આવે you made a show એટલે જાયો હોય ને તો શું કરવા આવે
Thank you. શું કરીએ તું કે
अच्छा था क्या? हमारा डिस्कशन चल रहा था ना ऊपर, बहुत लंबा चौड़ा खींच गया वो 1.5 घंटा।
Yeah, I was there in that panel. It was nice. Postpartum hemorrhage, bilateral uterine artery cut, and declare as postpartum hemorrhage and hand over the body. And later, come. That is why we should be very careful with our hospital staff. We should never talk about
highlight, madam, anything can happen. Unusual.
Yeah,
You should be careful.
very careful. Yeah, that point was very nice.
We have come across these cases. These are exact cases which happen. Okay, go to final. At least October, शुरुआत में September.
So you are waiting for the inauguration. Yes.
मैं समझा आ नहीं चाहते, मैं समझा पर जो आज पर मारे आम नीचे मर पर क्या क्यों लागे साथे काम करो हमारी बैग खुश होती है फिर आ जाओ करके वो आया सारे मैं दिखाई नहीं कहाँ बैग खुश हमारी मुक्ति लोग ने आज बैग की कोई ये बंदे अपन आए पे बड़ी बोलवा मास्टर सेरेमनी डैमेज बोलवा ये नो सेमीकंडक्टर का तो गेस मार हमें यहाँ कभी बोली तो बबली
मैंने तो सामान यहाँ रखा हुआ है। वो एक पूनम गोयल की अपना बैग छोड़ गई।
પગાર આપણને ઇન્ક્રીઝ નો કરવું હોય પછી એક સાથે અને દિવાળીનો પગાર જો કમ્પેરિઝન લોકોનો કઈ નથી હવે તો બધા ઓલરેડી થઈ ગયા છે પણ એટલે એ બધું જે આપ્યું હતું મેં બધું એરિયાસ આપ્યું છે આપી દો પાછું ચાલો બાય
હોતા નથી
નહીં આ કે ચેન્જ
ના પણ એમાં શું વાંધો છે આને પટોળાને?
મેં કીધું કે તારે
પટોળું છે યાર અમાર જેવા જે પેન્ટ અને શર્ટ પહેરીને ફરતા હતા તો
હા બરાબર છે
કેટલા મારે બદલવા જવાનું હોય ના
સાડી પહેરીને જ આવી છું ને હું એમ મને એમ કે આમાં શું કરવાનું છે આ લોકો બધા ફોર્મલ પેન્ટ જેવું અમને